Dr. Pranav Ranjan sir, my father, my godfather like, Dr. Vibhuti Sinha sir, Dr. Nilesh, Dr. Satyajit, Dr. Satyajit did the extraordinary thing. When I went to the BBI Foundation for Retina Training, then Dr. Saurabh Sinha said, Satyajit ने बोला अश्विनी को आगे बढ़ाना है. So I'm thankful to all you all. Because of you all I'm alive and I'm here. So I'm starting this. So when I started my low vision aid practice, I realized that most of the patients are very poor. So I invented new techniques like low vision aid with household techniques. So I started with that low household item.
You can say next slide and they will advance the slide for you. You can say next slide and they will advance the slide for you.
अच्छा. So मैं दिख रहा था. ना बैठ जाए क्या? When I first started my low vision aid technique, low vision aid treatment, I realized that most of the patients were from poor economic status. So I invented newer tools just by changing the daily household articles and low vision aid I started with changing the environment and with simple things like I will tell you. So the next slide. Sorry, first slide. Next. There were only 63 patients and it was very new to them, to me also. Nevertheless, it was the month of November 2003, we took the consent for the research. We didn't use any invasive techniques as majority of the patients were of poor socioeconomic background. Our common household items were used to help the patients with low vision aid to manage their daily activities. On follow, the majority of the patients expressed satisfaction and ability to perform simple activities. So, next slide. I recommend, there was a bell-shaped distribution. Next, there was a bell-shaped distribution of patients. Only 1/5 of the patients were female and 4/5 were male. So next slide. Next slide, please. So next one. While the subjects came from a large variety of occupational backgrounds, most of the patients attending the clinic are poor, and the clinic based in Mahavir Nadralaya had Mahavir Nadralaya run by a charitable trust. 25% of the patients were retired, 13% student, and 34% were homemakers, and rest were others. Next slide. The visuals of the subjects were overwhelming and had limited scope of correction using the lens of glasses. Over half of them had visual acuity poorer than 6/16 both the eyes. They all complained of inability to perform daily tasks and unable to benefit from surgery, medication, or use of spectacles. Next. The subjects reported difficulty in performing the common household items. However, it was surprising that majority of them complained about inability to perform the work over the mobile and watch television were highest concern. The prominent cause of concern they were writing and moving outside the home. Next one was next. So as you can see, there is a variety of household items were youth developed for their home to help them at home. Among over 30% reported that the cardboard tools were very helpful. Like as you can see, there is first separate thing. This is called signature guide to help them in counting, making the signatures. The next one was next slide. Next slide. Next. Sorry, next one, back please. As you can see, the patient could see very well. Next slide. Thank you. Thank you.
Thank you, Dr. Aswini, for doing such a wonderful job and working for the noble cause. May I request Dr. Gautam to please present on practical approach in treatment of allergic conjunctivitis. Please come, sir. Okay. May I request Dr. Zeba Khanam to present? Dr. Zeba, are you ready with your presentation? Please. Dr. Gautam is having some problem with his presentation. He'll be presenting later on. So now we have Dr. Zeba presenting.
Dr. Gautam, loading the slides. Pratik had been loading the slides with us for nearly when he was in class 5. Sorry, I think he was in class 5. Since then, he has become expert in this. When Gautam was young, Pratik was a kid. Now Gautam is old, Pratik is young. He has been doing this for years.
I request Dr. Roshan to get ready with his, Dr. Madhavi to get ready with her presentation on the other side of the podium.
Zeba, please continue.
Good afternoon, everyone. Myself, Zeba Khanam, presenting a case titled Acetazolamide Friend to Foe. No financial disclosure. A 68-year-old male, known case of primary angle closure, both eyes, underwent a left eye uneventful phakic emulsification with intraocular lens implantation under local anesthesia. Patient was advised to tab acetazolamide 250 mg 1 hour post-op. Patient is a known case of diabetes and no history of allergies or adverse drug reaction to the medications. Past ophthalmic history. The baseline IOP was 23 mm of mercury in the right eye and 25 mm of mercury in the left eye. On gonioscopy, the iris root was closed in all quadrant in both eyes, but on indentation scleral spur can be seen. So, patient undergone bilateral ND-YAG peripheral eye dot 1 month earlier, and after laser PI, the angles were open. The patient was not on any anti-glaucoma medication. So, preoperative, the IOP was 15 and 18 mm of mercury respectively in both the eyes, and the cataract was in the right eye nucleus spaces grade 2 to 3 and in the left eye 3 to 4 along with the pseudo exfoliation. So on the first post-operative day, the section was secure and the cornea was clear, but shallowing of AC which VH grade 2 was seen, and the sterile affirmation tonometry was 30 mm of mercury. So the patient was initially diagnosed as a malignant glaucoma. So tab acetazolamide 250 mg at the start given and advised to use the eye drop prednisolone half hourly and eye drop atropine. But the patient was reviewed after 1 hour and he complained of the development of bilateral blurring of vision with severe pain. On examination of the right eye, the cornea was clear but VH grade 1 was seen, and the IOP was 42 mm of mercury, and on gonioscopy 360 degree oppositional angle closure was seen, which was not open on significant indentation also. And the left eye, the VH grade was 2 and IOP was still 30 mm of mercury and 360 degree peripheral eye corneal touch was seen. So he was advised IV mannitol 200 ml stat with topical prednisolone and anti-glaucoma medication and eye drop atropine in both the eyes. So optos was done in the left eye, in which the fundus was seen. We can see the 360 degree choroidal detachment with including a hemorrhagic choroidal detachment in the inferior nasal quadrant. And the B scan of the right eye was within the normal limit, and the left eye it shows a dome-shaped elevation with moderate number of hyperreflective echoes in suprachoroidal space in the infero-nasal and the supranasal quadrant, suggestive of the hemorrhagic choroidal detachment, the serous choroidal detachment in all quadrant. So UBM of the right eye was done, in which we can see the 360 degree supraciliary fusion with anterior rotation of the ciliary body and the occludable angle. So the final diagnosis was bilateral acetazolamide supraciliary fusion with left eye 360 degree choroidal detachment and hemorrhagic choroidal detachment. So oral steroid was started and along with the pantoprazole and calcium tablet, and the topicals were advised as before. So on the first week follow-up, the both eyes 1 grade 3 was seen and the pressure was 15 and 16 millimeter of mercury. And the gonioscopy was right eye in sclerus per candice. So in the left eye, optos was within normal limit at 1 week follow-up, which is confirmed by the B scan of the left eye. And the uveum of the right eye was seen that a supraciliary fusion was resolved and the angles were open. So the final follow-up, 3 weeks, the visual acuity was 6 in both the eyes along with the IOP 14 mm of mercury. And the normal fundus was seen. So on discussing, idiosyncratic drug response is a type B adverse drug reaction which is not dose dependent, but the common causes are the sulfonamide drugs, which also include the acetazolamide. So it is based upon the Hampton hypothesis in which the metabolites modify the endogenous macromolecules and make them antigenic, which causes this damage to the neighboring cells, resulting in the maturation of the anti-presenting cell and the T cell involvement. And the sulfonamide hydroxylamine is a reactive metabolite. As the sulfonamide groups of these drugs stimulate the synthesis of the prostaglandin E2, which causes the vasodilatation and increased vascular permeability in the anterior UV. A case has also been reported with a topical dorzolamide that does bilateral acute angle closure. The choroidal effusion has been reported. So, according to the literature, a lot of cases have been reported of bilateral acetazolamide, including choroidal effusion. So, one case was reported by the Malagola et al. That the papillary edema along with the retinophores can also be reported. So in our case it's important because the patient developed salivophasia in the rise of IOP after the injection of acetazolamide, which worsened when he administered its second dose of IOP reduction in the post-operative day 1. And he also developed the serous and the hemorrhagic choroidal detachment, which subsided with the oral and topical steroid along with the avoidance of the culprit drugs. So take-off image is that acetazolamide can precipitate acute IOP rise by the secondary angle closure as an idiosyncratic reaction, and therefore careful evaluation of the antechamber depth of both the eyes prior to its administration will prevent the worsening of the idiosyncratic reaction. And intraocular pressure should be done both the eyes before administration of the acetazolamide. Thank you.
Zeba, you're from? So when you introduce yourself, you apart from the name, you give a more nice presentation. So what's your take-home message about acetazolamide? Friend, what's your take-home
message is that if we have evaluated the unoperated eye before giving the acetazolamide, then the patient might not have developed so much erase in IOP. So before administration, we should see both the eyes because any patient can develop idiosyncratic reaction with any dose, as it is a dose independent.
So with acetazolamide, do you all suggest something more to be taken like a Potlor or Nimbu Karas and Narangi, something like that?
So we can no for one tablet stat it's not necessary.
Big term, 3 or 2 tablets not required. Yes. Thank you very much. Gautam, are you ready with your slide? Gautam, actually the computer is automatic.
Please come this
young
way.
stars. If you are not young, it will not take. The computer will not upload your slide. Next.
Now we have Dr. Madhvi. She will be presenting on role of USG B scan in pre-operative assessment of patients undergoing cataract surgery with opaque ocular media. Dr. Madhvi, please.
Good afternoon, everyone. I'm Dr. Madhvi. I'm a senior resident at IGIMS, Patna. I'm presenting a study on the role of USG B scan in pre-operative assessment of patients undergoing cataract surgery with opaque ocular media. USG B scan is one of the most useful non-invasive techniques for the evaluation of the posterior segment of the eye. It can detect any intraocular abnormality in the presence of opaque media like corneal opacity, corneal edema, total hyphema, dense cataract, and vitreous hemorrhage. The most frequent posterior segment lesions seen on B scan ultrasound were retinal detachment, vitreous hemorrhage, and posterior vitreous detachment. This study was done with the purpose to visualize the status of the posterior segment with B scan ultrasound in preoperative dense cataract patients to find out any posterior segment lesions. This is a cross-sectional observational study. We performed diagnostic B scan ultrasound on 300 eyes of 284 patients with dense cataract preoperatively at outpatient department RIO IGIMS over a period of 12 months between March 2023 to March 2024. Thorough history and ocular examination was done. Patients with very dense cataracts whose posterior segment could not be visualized using 90D lens and slit lamp and indirect ophthalmoscope were selected for the study. An informed consent was taken from the patient. The patients were divided into 2 groups, dramatic and non-dramatic cataract group. Patients in the age range of 80 years of both sexes were included in the study. Patients with pre-existing posterior segment lesions and those who had previous history of ocular surgery were excluded from the study. Patients were briefly explained about the procedure. USG-B scan with the probe of direct contact, mind rays DC-70 was used. USG probe was placed over the globe of both of the eye with closed lid after application of the gel, and then B scan was taken. Out of the 300 eyes examined, 31 eyes were in the traumatic group and 269 were in the non-traumatic group. Traumatic cataract were more common in male patients, 25 males out of 31 patients, and it was more common in patients less than 20 years old. Out of 31 traumatic cataract eyes, 15 had posterior segment lesions, 8 were retinal detachment, 6 were vitreous hemorrhage, and 4 were choroidal detachment. Non-traumatic cataract was more commonly seen in male patients, 149 patients out of 269 patients. Most patients were in 40 to 60 years of age group. Out of 269 non-traumatic cataract eyes, 19 had posterior segment lesions, 13 had retinal detachment, 3 had retinal detachment, 9 had posterior vitreous detachment, 5 had vitreous hemorrhage, and 2 had posterior staphylogram. This is a slide showing the various posterior segment lesions that we found. The first one shows choroidal detachment, second shows vitreous hemorrhage, and the third shows retinal detachment. This chart shows the distribution of patients in our study. There were 25 patients in the traumatic cataract group, and non-traumatic cataract there were 149 males. Females were 6 in traumatic cataract and non-traumatic 120 females. The various findings that we studied in this study was retinal detachment, vitreous hemorrhage, choroidal detachment, posterior vitreous detachment, and posterior staphylogram. B-scan ultrasonography has enabled us to study posterior segment of the eye even in the presence of opaque media like dense cataract. Posterior segment of a total of 300 eyes were examined under B-scan ultrasound in 1 to 80 years old patients, divided into 2 groups. Majority of the eyes, 269 eyes, belong to the non-traumatic cataract group, and a small number, 31 eyes, to the traumatic cataract group. Similar groups in different age ranges have also been discussed in other studies. Findings of posterior segment lesions, that is 11.3% in this study, were similar to the other published studies. Out of 11.3% of patients, 56% patients were non-traumatic cataract group and 44% patients were in the traumatic cataract group. Ali and Rahman reported posterior segment lesions in 11% non-traumatic cataract patients and 65.85 patients with traumatic cataract. Retinal detachment in non-traumatic cataract patient was 8.8% and 23.5% in traumatic cataract patient. It was similar to that reported by Ali and Rahman, who found retinal detachment 3.3% in non-traumatic cataract and 29.26% in traumatic cataract patients. And another study conducted by them, 22.5% was noted in traumatic cataract. B-scan ultrasound is a very important diagnostic tool for the assessment of posterior segment before cataract surgery in patients with opaque ocular media. It helps in detecting posterior segment pathology and counseling the patient regarding the visual outcome post-surgery. It is especially important in young patients with history of trauma, as there is a high chance of finding posterior segment pathology like retinal detachment, vitreous hemorrhage, and choroidal detachment. Thank you.
That was a nice study you did. But one thing, like in the traumatic group, there were no patients with any PVD. What's the original detachment?
So the patients that we studied, we did not find, but other studies have reported that they have found PVD.
Okay.
But in our study, the patient that we took had retinal detachment, choroidal detachment, and vitreous hemorrhage.
Maybe there was no incomplete PVD, complete PVD, nothing.
So in traumatic cataract, we did not find. In non-traumatic, we found.
There is retinal detachment. There would have been some of PVD, definitely. That's what I think. If there is trauma, the chances of having even an incomplete PVD would be more. Probably can look back and check. But the sample size probably small, that's why probably also will be negative. Cataract. What was the sample size for your traumatic? And none of them had any PVD.
So in the traumatic group, there were 31 patients. Those patients we did not find, but we found vitreous hemorrhage and we found retinal detachment. But in the non-traumatic patients, we found PVD also. Maybe because of the vitreous hemorrhage.
Okay. Thank you.
जी वॉल्यूम बढ़ाइए
Thank you, Dr. Madhvi. Now we have Dr. Roshan, SR from AIMS. Now you will be presenting on role of retinal laser in common retinal diseases. Roshan, please.
Thank you so much, sir. A very good afternoon to all of you. First of all, I would like to thank Patna Ophthalmological Society from the deepest core of my heart for giving me a wonderful opportunity to say something about the role of retinal laser in common retinal diseases. I don't have any financial disclosure to make. To introduce, laser is an acronym for light amplification by stimulated emission of radiations. There are three properties: monochromatic, coherent, collimated. Most common retinal laser which we use is frequency doubled ND-YAG laser. Laser delivery is done by operating microscope, indirect ophthalmoscope or slit lamp. This is conventional slit lamp laser. This is how we deliver laser to eye with slit lamp. This is Poscon laser, patterned laser, in which there is facility of multi-spot. This is operating microscope, endoscope, endoprobe assisted laser. This is how we deliver the laser to retina through operating microscope. This is by indirect ophthalmoscope. There are so many contact lenses for laser, but hole and Menster lenses are quite popular. So coming to the topic per se, these are the indication of retinal laser in common retinal conditions like diabetic retinopathy, retinal vein occlusion, central serous chorioretinopathy, neovascular glaucoma, retinal breaks, diabetic macular edema, retinopathy of prematurity, traumatic subchoroidal hemorrhage, polypoidal choroidal vasculopathy, and ocular malignancy. Diabetic retinopathy, as we know, systemic strict glycemic control is the first line of treatment, but in case if diabetic retinopathy progresses to proliferative stage, then we do pan-retinal photocoagulation. Fundus fluorescein angiography may add in equivocal cases in which we see capillary perfusion areas and neovascularization. This is post-PRP fix. How PRP helps? Actually, it destroys hypoxic retina, which reduces VEGF production, which ultimately reduces neovascularization and edema formation. Apart from that, a position of inner layers to choriocapillaries gives better perfusion to healthy retina. These are different settings. Coming to retinal vein occlusion, in acute phase, there is role of anti-vascular, but when RVO is with neovascularization, then we do pan-retinal photocoagulation in case of central retinal vein occlusion, and in case of branch retinal vein occlusion, we do sectoral photocoagulation. As we know, central serous chorioretinopathy is self-limiting, but when it is resistant to conservative management, then we do FFA, and FFA guided laser is to be done. This is a case of CSCR in incidental case of optic disc fit, in which we did FFA, and FFA guided laser was done, from which best corrected visual acuity improved from 6/24 to 6/6. So just I want to emphasize what are the base differences between CSCR and OD pit maculopathy. In CSCR, there is acute onset diminution of vision, no connection between the optic disc pit and subretinal fluid, no schisis like retinal edema, but the presence of pigment epithelial detachment, thickened choroid and leakage on FFA. Coming to neovascular glaucoma, it carries 3.9% of all glaucomas. CRVO, PDR, carotid insufficiency or ocular ischemic syndrome are top 3 most important cause of neovascular glaucoma, in which PRP is gold standard to tackle with retinal ischemia. Retinal breaks, barrage laser is done to retinal breaks to prevent rheumatogenic retinal detachment in the future. In diabetic macular edema, if diabetic macular edema is not center involving, then leaking micro lesions are focal laser or grid laser is also done. Coming to retinopathy of prematurity. In retinopathy of prematurity, all type 1 ROP are treated with laser ablation of avascular retina. This is a case of a 27-year-old female who presented to us with sudden paleness, loss of vision in left eye following brain trauma on head. On examination, a large macular subchoroidal hemorrhage was found and vision was diminished to 2/60, in which we did posterior hyalotomy. Due to that, vision was improved to 6/6. In extrafoveal peripapillary and peripheral polypoidal choroidal vasculopathy, there is role of the thermal laser with or without anti-VEGF. In ocular malignancies like choroidal melanoma and retinoblastoma, there is role of transpupillary thermotherapy. So, my take-home message will be, in the current era of anti-VEGF, one of the disadvantages of anti-VEGF therapy is the burden of frequent injections, cost and clinic visits. Laser treatment offers the advantage of a longer lasting effect compared to anti-VEGF therapy, so its use should be optimized. Moreover, several studies have demonstrated that the combination of laser photocoagulation with anti-VEGF treatment has the potential to reduce the frequency of injections. However, it is important to note that the optimal timing and protocol for combining laser treatment with anti-VEGF injection have not yet been firmly established. Thank you so much for your patient listening.
Very well presented, Roshan. Deepak sir, would you like to impress a little bit about the micro?
Yeah, actually, in our scenario, what happens, there are many patients in which there is severe NPDR along with diabetic macular edema, but as they are financially not very well, they tend to come for follow-up. So in severe NPDR cases also, what I do pen retinal photocoagulation 2 disc diameter away from the arcades. Next, say for example, in case of extramacular PCV, where there is a burden of where we tend to give more and more injection, but there is no regression. But if it is away from the macula, extra macular or peripapillary, then we give. Although guidelines says that there is a thermal laser along with anti-VEGF should be given, but if patient is non-affording, then I just ablate the polyp. And in ROP cases also, usually to buy time, we give anti-VEGF many times, but as we know that this. Yes, sir.
And for diabetic macular edema, when do you prefer the laser? Like, do you do a prompt laser or a deferred laser?
In diabetic macular edema, my only indication is it should not be center involving. If it is parafoveal macular edema, and if I see that there is leaking micro aneurysm, then definitely I will focal laser to those leaking micro aneurysm. No, we don't have micropulse here. Thank you so much.
So now we have Dr. Gautam Kumar who will be presenting to us on practical approach in allergic conjunctivitis. And Dr. Gautam is working in Guru Gobind Singh Eye Hospital, Patna City, and we are all aware with him. He was the previous treasurer of the Patna Ophthalmology Society. Dr. Gautam, please.
Thank you, Dr. Abhishek. Practical approach in allergic conjunctivitis management. It is very common ocular morbidity affecting children as well as adults, and it is the most common causes of school absenteeism in children for the ocular vision. As a treatment, there are few steps we have to follow. That is proper grading, identify causes and types of allergic conjunctivitis, whether it is acute, chronic, intermittent, or it is has complications. And we have to discuss about the home cares, and we have to select drug accordingly. This is the grading of allergic inflammations, mild, moderate, severe, and the blinding stage. In mild only there is acute congestion in bulbar conjunctiva and this micropapillary. And in moderate there is 180 degree of limbal involvement with macropapillary less than 1 mm size, and there is bulbar congestion. In severe cases there is a bulbar glass spot with the congestions of bulbar conjunctiva and giant papillae more than 1 mm size, and 180 degree or more than 180 degree involvement of limbal areas. In blinding cases, there is granuloma, cholesterol appearance, and there will be the seals, and there will be impulses deficiency. So, we also understand about the acute, intermittent, and chronic diseases. In acute means the Acute means the sudden onset and are of different severity. Intermittent means the inflammation pre-interval of greater than 2 to 3 months. And in chronic diseases, there is a less than 1 month interval. And these are the classification of allergic conjunctivitis. Home care is very much important. We have to explain with the patient and parents. Importance of home care is it reduces the allergen loads of the conjunctiva and reduces the allergic symptom, also reduces the drug dosing and reduces symptoms and prevents the complications. There are 6 golden rules of home care that avoid exposure to dust, chemical, dyes, perfume, pollen, animal danders. This is done by the proper cleaning of houses, paint, reading places, workplaces to make dust and pollen-free spaces. In dusty area, close the window and the home gates. Wash the eye after coming from the outdoors. Apply cold compressions. Wash the eye many times if feeling of itchings come. Medical treatment maybe includes the lubricants, antihistaminics and muscle stabilizer, topical steroids, cyclosporin, tacrolimus and mitomycin C. The step leader approach is important in allergic conjunctivitis. Aim is to provide the safest possible way to control allergic inflammation based on the severity and periodicity. Typically, as the allergy wanes, we go down the ladders and use safer medication. As it worsens, we go up the ladders using more potent medications. LHM, it is avoidance, lubricants, antihistaminics and muscle stabilizer. This is the step ladder approach. In mild cases, ALHM is very much useful. In moderate cases, intermittent stage, low temperature pulse therapy with LHM. In chronic cases, cyclosporin or tacrolimus ointment may be given. In severe cases, ALHM with cyclosporin with steroid is important. And in blinding cases, ALHM with the potent steroid with immunomodulator and supratarsal injection of steroid in cases of Poscon. Sometimes surgery like debridement, cryotherapy, and amniotic grafting with the stem cell grafting may be done. Pulse therapy. In acute cases, according to severity, it may be given in dose of 4 to 8 times for 1 week, followed by the rapid tapering up to the lowest level to give the better control. Management of the Poscon. Supratarsal injection of steroid like triamcinolone, acetonide, or dexamethasone or hydrocortisone. It provides a temporary suppression of the inflammation. Other treatment modalities are the excision of joint papilla with the intraoperative use of the mitomycin C in severe and refractive cases. Topical cyclosporin 2% 4 times per day or tacrolimus 0.03 BID dose is also used. In CL ulcer, cold compression, topical steroid, loteprednol or prednisolone acetate or dexamethasone 4 to 6 times with broad spectrum antibiotic and cycloplegic may give favorable result in many patients. In drug-resistant cases, removal of plaque with scraping of the base of ulcer with or without amniotic membrane application results in healing of the seal ulcer. In GPC cases, removal of the causative factors like contact lens, exposure, followed by the short course of the topical steroid or topical 4 to 6 times per day. Immunomodulators like cyclosporin, tacrolimus are also effective in the GPC. And there are many drugs we use in allergic like antihistaminic, phenobarbital maleates, topical mast cell stabilizers, and dual-acting drugs like olpatadine, mifestatin, and captadine, and topical non-steroidal drugs like ketorolac. It is response on the late phase of the inflammations, and topical immunosuppressant like cyclosporin A, tacrolimus 0.03%, and topical steroids like prednisolones or dexamethasone, loteprednol. Point to remember, understand the grade and nature of the disease is important. Treatment is planned according to severity. In mild cases, home care, LHM, like antihistaminic, vasoconstriction or dual-acting drugs is useful. In moderate cases, with home care, LHM, mild steroid and dual-acting drug is important. In severe and blinding cases, steroid with immunomodulators, sometimes surgery has important role. Steroid pulse therapy, cyclosporin, tacrolimus is in recurrent cases, GPC and complicated cases, it should be given. Thank you very much.
Thank you, sir. And I have just one query. There's a new steroidal drug on the market that is loteprednol 1%.
Yes.
Do you have any experience in allergic conjunctivitis with loteprednol 1%? Sir?
Actually, allergic conjunctivitis in mild cases, there is no need of the steroid. In chronic cases or intermittent cases, loteprednol we use the in pulse mode, but I haven't used in 1%. Okay, like the other loteprednol, it is usually effective. Like it is the milder steroid, milder variety of steroid, no? So it is effective, but dose should be some less. Like 4 to 8 times, we have to give only 4 times or 3 times, because the dose is, strength is the higher of this drug.
Another thing like which I have seen in clinical practice that 0.03% tacrolimus, it doesn't act very well when compared to 0.1%. Actually 0.1% tacrolimus works better. That's what I have seen in clinical practice. Another problem is the duration. How long do you give tacrolimus or cyclosporin to these children who come?
Actually,
Like in one go, do you give it for a year, for a 1.5 years or 6 months? And when do you stop actually? Because
yes, it is very valid questions. Tacrolimus should be given only for 3 months. When the GPC or cobblestones decreases, we again go for the on the steroid. Again, after control of the symptoms and signs, we give weekly, like once weekly or twice weekly or once daily per day.
Hello.
After that, alternate day of steroid. After that, twice weekly, we can use this protocol for the control of the disease.
Gautam, one more query. Patient of GPC, steroid you give, patient is steroid responder.
Sir.
That is the problem. What do you do with that?
Sir, in that case, in GPCs, there are some insulting factors like foreign body, like some suture.
See, nothing. There is no insulting factor. It's a pure giant papillary allergic conjunctivitis. You need to give steroids. You give steroid. Patient is a steroid responder. Pressure rises. So when to stop? What to do? Any alternative thing like steroid injection of subtenon? Yeah, would that help? Raising the. I mean, what is the way out?
Sir, in that cases, we go for the cyclosporin or tacrolimus in that cases for 2 to 3 months. And after controlling that, we have to add weaker steroid like lotepanol or fluorometholone acetate once a week on the lower dosage. And we have to keep on the new drug like alkaptadines or bipostatin is very good in that cases.
actually oral immunosuppressives can also be given
Yes,
with
yes.
oral steroids.
Yeah, oral steroid has also role in. Yes, sir.
Oral levocetirizine
I have
and
few
keeping
cases
an eye
in
on
that
the
the patient developed the secondary cataract in younger age,
Keeping an eye on
cataract,
the
PSC type
systemic
cataract
copy
and glaucoma also.
Glaucoma 0.95 cup. Patients develop glaucoma 0.9 cup because of chronic use of
In
steroids.
DKC,
Steroid,
oral
yes.
immunosuppressives like methotrexate has been given.
I also fully agree that tacrolimus 0.1% is very effective, and there are also studies which show tacrolimus 0.1% applied over the eyelid skin to be
Yes.
effective in controlling those giant papillae.
Dr. Rasmi Chandra did a study and was published in the IGO that over the skin it's also very effective.
10.3%. Like toleration is better.
Actually, with the tacrolimus, very stinging and burning sensation is there. So we have to apply over the eyelid skins now. And with the lower doses like 0.03%, we can apply under the conjunctivas. With the long term, after 4 to 6 weeks, I have observed that cobblestones have vanished. GPC has also vanished. And there is drastic improvement in that cases. And after that, I have put the patients on the like lotepanol steroid for 4 to 6 weeks. And again, I have reduced the doses and once daily for 1 month. After that, alternate for 1 month and twice weekly. Patient is on this regimen and patient is happy with this.
This is a very important topic presented worldwide, and we do see patients coming with 0.9 cup because of visiting various doctors because the allergy doesn't get treated. Audience, any questions from the audience?
Maybe we take the last question now and move on to the next paper for paucity of time.
Sir, तो बताएंगे question थोड़ी पूछेंगे.
Very well presented. Just to add that once you have started steroid, you must educate the patient. Don't continue steroid at its own. Always do it under supervision. That is the only precaution we should advise to the patient. And always started with the tapering dose. Don't give full dose for the 1 month. Always make schedule on the paper. so that they understand that this is going to
Yes, sir.
stop.
In
after
tapering
few
dose,
days.
like
Yes, tapering
after
dose.
the control of the symptoms and signs, we have to go for the tapering dose, sir.
Thank you, Dr. Gautam. Now we have Dr. Yogesh, senior resident from RIO. He will be presenting on ocular presentation of Marfan syndrome and its management. Dr. Yogesh, please.
Thank you, sir. Good afternoon, everyone. Today I present ocular presentation of Marfan syndrome and its management. No financial interest. Marfan syndrome is an autosomal dominant genetic disorder caused by misfolding of extracellular matrix protein, fibrillin 1. It is a connective tissue disorder with varied expression in the body with ocular and systemic involvement. First described by Borger in 1914, Marfan syndrome is the second most common inherited connective tissue disorder, second only to the osteogenesis imperfecta. It affects both sexes equally and is found in all races. Approximately 25% of patients are affected by the sporadic mutation. Most common genetic inherited disease FV1 gene on the chromosome 15. The suspensory zonular fiber are mostly composed of fibrillin. Fibrillin is distributed in 3 anatomical locations of the capsule where it is probably serve different function related to structural function integrity of the capsule, suspension of lens by zonules, accommodation. Systemic manifestation. Marfan syndrome is a systemic disease that classically affects the cardiovascular, musculoskeletal, and ocular system. Non-ocular manifestations include tall stature, pectus excavatum, scoliosis, hypermobile joint, long tapering fingers and toes, aortic dilation, dissection, and aneurysm, metal prolapse. Ocular manifestation. Ocular abnormalities occurs in approximately 80% of the patient with Marfan syndrome, with most common abnormality being ectopia lentis, 50 to 80% of the Marfan syndrome patient. In anterior segment, cornea flattened, astigmatis, megalocornea, glaucoma. In iris, poor dilation people, iris globoma. In lens, ectopia lentis, microspherophakia, lens opacity, lens globoma. In posterior segment, vitreous liquefaction, abnormal vitreous attachment along the lattice degeneration, retinal degeneration, retinal tear, retinal detachment, thin choroid, thin sclera, and long axial length strabismus is another. This is the ectopia lentis in all patient with in a patient with Marfan syndrome with stretching of the general fibers. Ectopia lentis. Dislocation of the lens into the anterior chamber often seen, and it demands grand scale because the lens is entirely displaced and there are no zonules. Ectopia lentis occurs in the 50 to 80% of the patient and is a major criterion of the diagnosis of Marfan syndrome. This abnormality may present with the symptoms like blurred vision, fluctuating vision, and monocular diplopia. Refractive error. Most of the patients with Marfan syndrome have myopia due to long axial length. The prevalence of the Marfan syndrome in myopia is higher than in the general population. In one report, more than 50% of the patients with Marfan syndrome have myopia more than 3 diopter. They may also suffer from the lenticular astigmatism due to lens subluxation. Amblyopia. Children with Marfan syndrome are at risk of amblyopia. Ocular abnormalities such as myopia, astigmatism, and asometropia, ectopic lentis, and retinal prothenogenesis may result in the amblyopia. In retinal disease, posterior segment pathology is present in 18% of the eyes, and the incidence is even higher in patients with a subluxated lens. The incidence of the retinal detachment in Marfan syndrome ranges from 5 to 25.6%. Glaucoma may also occur about 1 to 3% of the Marfan syndrome with develop glaucoma sometimes in their life. Usually, in this case, glaucoma is diagnosed at a younger age than in the general population. The most common type of glaucoma in Marfan syndrome is primary open angle glaucoma. And coming to the management, ectopia lentis, most eyeglasses are the first step to correct the blurred vision caused by subluxated lens. In mild cases, correcting myopic astigmatism. If subluxated lens split the pupil, correcting the aphakic part leads to better outcome as images are less distorted by the lenticular astigmatism. Lens extraction is the main type of the treatment for anterior lens dislocation. Within the bag lensotomy, combined with a limited anterior vitrectomy is a safe procedure in a children with lens subluxation Option for intraocular lens include anterior chamber intraocular lenses, posterior chamber intraocular lenses. Sulcus fixation of an IOL in eyes without capsular support is an option to correct aphakia in children. Another option to stabilize the capsular bag is to use capsular tensor ring and oblique capsular tensor segment. IOL power calculation is also important issue in the patient with the Marfan syndrome. They usually have longer axial length and the staphylomatous area in the posterior pole that can lead to axial length miscalculation with ultrasound biometry. If the ultrasound hit the staphyloma, the calculated power of IOL results in the underestimation and the hyperopia after surgery. Refractive error can be corrected with the glass and or contact lenses. Retinal part, most surgical procedure, retinal detachment and repair are detachment depend on axial buccal and vitreous surgery, mostly in the retinal disease. Glaucoma mainly management with anti-glaucoma medication. In some cases, glaucoma surgery may also perform. Conclusion: ophthalmologists play a substantial role in the detecting Marfan syndrome. The diagnosis and management of the associated eye condition are challenging. Patients should be evaluated by ophthalmologists for reflection, IOP, lens status, peripheral retina, and changes in optic nerve. In case of subluxation, the first line if lens is bisecting the pupil, eyeglass removal of crystalline lens is necessary. Safe and effective means for for IOL centration and retinal.
Thanks, Yogesh. Now we have Dr. Ravi Kumar, SR from AIMS.
Yeah, I have a question, Dr. Yogesh, if you could comment. Choosing an IOL for a child with Marfan syndrome is quite a dilemma, whether you want to go for an iris fixation or a scleral fixation. What are the considerations that are followed in the regional institute? Can you comment on that? Dr. Deepak Agarwal, sir, could you comment on that?
No, first of all, we have to look at the age of the child, obviously. And most of the time, I prefer a scleral fixated IOL in these cases, and definitely above 5 years of age. And another important thing is removal of the lens. It should be, at no point there should be any vitreous traction like trying to do an SICs. It should be a pars plana, lensectomy, which is always a preferred technique for these cases. So for me, that is the important thing. And examining the periphery is very important because they may be having abnormal vitreous adhesions, and there may be lattice degenerations, and therefore taking care of the peripheral retinal degenerations is also a very mandatory thing in these particular cases.
Very important take-home points. Thank you, sir. Yes, Dr. Ravi, please proceed.
Thank you. Very warm good afternoon to respected chairperson, panelists, and my audience. I'm Dr. Ravi Kumar. Thank you. I'm Dr. Ravi Kumar, and I'm going to present a topic, the study of reversal of Bruch's membrane opening parameters after IOP reduction by 25% with topical anti-glaucoma medication versus placebo in glaucoma suspect patients. It's a randomized controlled trial. My co-authors are Dr. Bhavesh Chandra Saha sir and Dr. Amit Raj sir. I have no financial interest to disclose. So coming to the introduction, biomechanically, IOP-induced stress and strain are thought to play a major role in the remodeling of the optic nerve head tissues. Recently, Bruch's membrane opening derived neuroretinal rim parameters were shown to have better diagnostic performance and better correlation to the visual field compared with the traditional disc margin based rim measures that are RNFL. A better understanding of the mechanical responses of the nerve fiber layer to IOP elevation may be useful for improved glaucoma management in the future. So this study will help in estimating early BMO changes, correlating with the disc changes, and early diagnosis and management of the glaucoma at stage where no RNFL thinning has even set in. So this is the photograph showing the Brooks membrane opening, and this photograph is showing the BMO MRW. It is the least distance between the ILM and the BMO opening. So the primary objective of our study is to study reversal of the BMO MRW parameters after IOP reduction with topical AGM in disc suspect, and secondary was to compare the reversal of BMO parameters between the intervention group and the placebo group. The study setting is our department at AIIMS Patna. It is a RCT, single-centered, and the study period was 1 year. So inclusion criteria was any disc suspect patient of age 35 to 60 years with positive family history. The open angle should be open, and IOP is below 21 mm of mercury, and BMO MRW changes should be present on the OCT with normal visual field on 24-2 program. And in exclusion criteria, the patients who were not giving consent for participation, any congenital disc anomaly, closed angles, and history of any intervention to control IOP in past were excluded. And abdominal visual fields were also excluded. Any systemic illness severe enough to hamper examination and follow-ups were also excluded. So this is the stepped pilot study sample size rule for thumb. For pilot study, we used it to calculate the sample size. With this method, we got 20 in each group. So taking into account the 10% of attrition, 22 were incorporated in both the groups. This study is conducted only after prior approval from the ethics committee of the AIIMS Patna with CTRI registration. So coming to the methodology, patients consenting to participation were thoroughly evaluated for ocular and systemic examination. Patient particular visual acuity, slit lamp examination, GAT and OCT examination, and visual field analysis were recorded on the baseline enrolling day. And randomization was done with computer software. Patient and investigator were blinded. Patient randomized to intervention group were advised group 1 drug, that is topical anti-glaucoma, that is bimatoprost 0.01% eye drop, and patient randomized to placebo group were advised to group 0 drug, that is artificial tear drops, with aim of 25% reduction from the baseline IOP. And investigation which we did were the visual acuity by Snell chart, slit lamp examination for ocular examination and disc assessment, IOP measurement by GAT, OCT and Nepal with BMO MRW with Heidelberg spectralis OCT, and Humphrey visual field analysis program 24-2 were done. On first follow-up, it was checked that whether the 25% reduction in the IOP from the baseline has been achieved or not. In the second follow-up, the visual acuity, GAT, disc examination, and OCT were repeated to see the changes in the BMO. And in the third, the same thing was repeated on the 6th month. So the data were analyzed with the SPSS for windows, and difference between the means at 3 follow-up is calculated by the repeated measure ANOVA test with p-value of less than 0.05% were considered significant. So coming to the results, total 44 patients were incorporated into the study with 22 in the intervention group and 22 in the placebo group. So this table shows the comparison of the mean global BMO thickness between the groups at follow-ups, and over here we can see that there is no significant difference between the right eye and the left eye in the placebo and the intervention group, and also among the baseline and 3-month and further follow-ups. It was done with the help of repeated measure ANOVA test. And this is the Garvey Heath sectors showing the mean BMO thickness at baseline in the right eye and the left eye. And these are at the 3-month in the both group intervention and the placebo group. This is at the 6-month follow-up, the final follow-up. There was no any significant difference statistically. So coming to the primary outcome, this plot shows the comparison of the right eye mean global BMO thickness between groups at different follow-up. And this is of left eye. So in both the plots, we can see that the group 0, that is the artificial tear group, placebo group showing continuous declination in the BMO MRW thickening. And in the green one, which is the CareProst group, it is showing that after 3rd follow-up month, there is increase in the thickening. So coming to the discussion, in our study, the final mean global BMO thickness was similar between the placebo and intervention group after IOP control. However, there was a trend of improvement among intervention group after 3-month follow-up as shown in the repeated measure ANOVA plot. Nazia Uzair et al. Have reported BMO MRW is better indicator of glaucomatous damage in moderately myopic eyes as compared to OCT RNFL. Alinshi et al. Have reported longitudinal RNFL OCT measurement are more likely to detect a structural change between than BMO MRW in advanced glaucoma damage. But we have done this in the early cases, that is the suspect cases. So there is no statistical significant difference of Brooks membrane opening thickness between the intervention and placebo group after IOP control by 25% from the baseline among glaucoma suspect. So further studies are needed to compare diagnostic accuracy of BMO parameter in glaucoma patients, not in the suspect, and it can be also done in the long term. It can be also follow-up should be increased. So these are my references, and thank you everyone for patience listening.
Thank you, Dr. Ravi. Very nice study, very innovative. Dr. Bhavesh, any comments?
Basically, this study we plan, actually in previous report, it has been shown that in cases of primary open angle glaucoma, there is a changes after reduction of IP. And that is the reversal of Bruce membrane and BMO MRW width. That's why we plan this study, whether it is effective in cases of NTG or glaucoma suspect. That's why we found there is no significant difference after the reduction of IP in cases of NTG or this suspect. So by this study, we can say that IP is not a major factor in cases of NTG. So other than IP, there is no risk remodeling due to IP in cases of NTG or glaucoma suspect.
What is your criteria for keeping a patient as a glaucoma suspect?
So there should be positive family history. There any disc asymmetry? Yes, sir. Disc asymmetry. They are taken into high risk that they may develop glaucoma further.
Any IOP level? No.
No, so it should be normal, below 21.
So just a family history and disc asymmetry.
Disc asymmetry.
So if a disc is 0.4 and the other is like 0.5 or 0.6, even that?
No, there should be a disc asymmetry along with changes in MRW, BMO, MRW, but no changes in visual field and RNA thickening.
Okay.
That patient will be included in this study.
Okay.
Thank you, everyone.
Thank you.
So any questions from the house? Dr. Amit Raj sir probably wanted to comment something earlier.
Pratik, we are running out of time.
Okay.
So I thank all the chairpersons, the panelists for finishing session 1 on time, and I hand over the mic to Dr. Vidya Bhushan for conducting this session 2 of the day.
Thank you, sir. We finished first session on time only, and we will continue another session on time also. This is because of the dedication and hard work of our Sujit Mishra sir and Dr. Mitra sir. So next session we will start with PG free paper session, where judges is Dr. Ranjana Kumar ma'am, Dr. Deepak Agarwal sir, and Dr. Abhishek Kedia sir. Chairperson is Dr. Ajay Sinha sir. Panelist is Dr. Bhavesh Chanda sir. So I welcome all to the dais. First presentation by Dr. Abhishek Ranjan, PG from RIU IGMS. His talk is on tickling increased ocular firecrackers injury during the peak season. So, Dr. Abhishek Ranjan, be ready for your presentation.
Before that, I would like just to inform that all the certificates and mementos that is kept near registration counter. To save time, we are not presenting here. So you can collect it from the counter near registration counter. Thank you.
Respected judges and audience, good afternoon everyone. Today myself Dr. Abhishek Ranjan, first year PG from RIO IGMS Patna. The topic for my presentation is early insights and gains from a collaborative multi-centric project, Project Roshni, a single center perspective. There is no financial declaration, ethical clearance has been taken from the department, and there is no conflict of interest. Project Roshni is a pan-India initiative for inclusive comprehensive eye care services. It has been started by RP Center, AIMS New Delhi in collaboration with 4 other centers, including RIO IGMS Patna. The aim of this project is to set up a low vision clinic and a peripheral vision center, provision of logistic and equipments, recruitment and training of staffs to conduct surveys on visual disability. Objective of the study is to determine the number of individuals evaluated for low vision and blindness under Project Roshni, to know the ocular pathologies leading to low vision and blindness, to analyze the rehabilitative measure implemented, to analyze the impact of this project and draw conclusions for future. Rationale of the study is inclusive comprehensive eye care aims to ensure not only prevention and treatment but also vision rehabilitation. Low vision and blindness often receive much less attention compared to treatable cause of blindness. Therefore, we need data to understand the burden and improve the care for individuals with irreversible vision impairment. Methodology. The place of study is Low Vision Clinic, RIO, IGMS. Period of study is of 3-month duration from 1st December 2023 to 28 February 2024. Data collected from patients presenting at Low Vision Clinic, RIO, IGMS. Demography and cause for low vision and blindness analyzed. Comparison with previous data set of similar duration done. Analysis of the low vision aids prescribed and rehabilitation measure taken. Statistical analysis done. Low vision corresponds to visual acuity of less than 6/12, but equal to or better than 3/60 in the better eye with best correction. Blindness is defined as visual acuity of less than 3/60 or corresponding visual field loss in the better eye with best possible correction. All the patients presenting at RIO IGMS OPD falling under the criteria of low vision or blindness are henceforth referred to low vision clinic. The results were a total in this 3-month duration, 176 patients presented, out of which 125 was male and 51 female. Mean age of the patients was 34 plus minus 6.9 years. Mean uncorrected visual acuity using logMAR chart was noted. Mean best corrected visual acuity using logMAR chart was noted. We found out that out of total patient presenting, 86% patient was of low vision and 14% patient was blind. The cause for low vision blindness was also analyzed, and we found that retinal disorder was the major contributory factor for low vision blindness. Among retinal disorders, we found retinitis pigmentosa, fundal coloboma, advanced diabetic eye disease, macular disorders, retinal detachment was the major contributory factor. Apart from retinal disorders, glaucoma and optic nerve pathology was also contributing to maximum, then high myopia and corneal opacity. Number of low vision aids prescribed to the patient was also analyzed, and we found that dome magnifier, handheld telescopes, these were prescribed in maximum amount. Apart from optical devices, non-optical devices were also prescribed. Mobile apps like VZoom, SuperSense was prescribed to all those patients who can use Android phone. These are the various rehabilitation aids available at our RIO low vision clinic. This is handheld magnifier, pocket magnifier, loop magnifier. We can see a patient reading using dome magnifier, patient using Noir filter. Gains from this project. There is significant increase in number of patients seeking low vision and rehabilitation clinic. We can see from this bar diagram that in comparing to data of previous year, there is significant increase in number of patients. There is upgradation of low vision clinic and addition of new low vision aids. Training in low vision aids dispensation and rehabilitation has added to efficiency at low vision clinic. Insight and implication. Rehabilitation is an important component of inclusive eye care which should not be ignored. Need for low vision services and rehabilitation is an unmet need. Surveys are needed to assess problem of low vision blindness in community and a major policy rethink. Limitation of the study, impact of low vision aids in improving quality of life could not be analyzed, need more studies in this regard. To conclude, there is a huge burden of low vision and blind population. We need dedicated low vision clinic like RIO IGMS low vision clinic. Outreach programs are needed to assess the number of low vision and blind population and bring them to the low vision clinic. Collaborative projects like Project Roshni help in data generation leading to policy changes, technology transfer, and training of personnel and monitoring. That's all. Thank you.
Thank you, Dr. Abhishek. So in your study, what was the most important cause of low vision?
In my study, sir, I found retinal disorder was most important.
Retinal disorders. And blindness?
we didn't analyze the data separately for low vision. Just overall data, sir, we found that retinal disorder was the most common cause. Among retinal disorders, sir,
But your
retinitis
study was for low vision and blindness, right?
Yes.
So you couldn't analyze the blindness data.
We could autopsy a total 176 patients whom we analyzed. For 25 was blind.
So the cause of the blindness could not be assessed.
Sir, we didn't do separately.
You didn't do it
We do it in the bulk together.
I just wanted to know that you have specified different categories like retinal detachment, ARMD or whatever.
Yes.
So if there was an overlap, how did you classify it? Because you have made all the classifications very distinctly. So a lot of times there's an overlap. It's like you have RP and fundal coloboma. So how did you segregate them that, okay, this is the reason for the main low vision? Just a curiosity.
Basically, mainly, there were some cases of overlap which I don't, there was confusing diagnosis which I don't take. Thank you.
Next presentation is by Dr. Sanjit Kumar Rai. He is a JR3 NMCH. His presentation on pertinence of using loteprenol elaborate 1% in patient undergoing laser peripheral iodectomy. Welcome here.
There is one small announcement. Those who have missed the lunch, there will be a high tea at 4:45. So don't get disheartened.
Shall I start? A very warm good afternoon to you all. Topic for today's my presentation is pertinence of using loteprednol etabonate 1% in patients undergoing laser peripheral iridotomy. There are no financial support or any conflicts of interest. Introduction. Loteprednol etabonate is first retrometabolically designed topical steroid that undergoes rapid metabolism into inactive metabolites after achieving desired pharmacological action, thereby providing improved safety and lower risk of clinically significant IOP elevation even in steroid responders. Loteprednol etabonate 1% suspension achieves higher concentration in ocular tissues due to high lipophilicity and new mucus penetrating nanoparticle technology that increases its permeability through mucus layer. Many clinical studies shows that loteprednol 1% is safe and effective formulation for postoperative inflammation and pain following ocular surgery. It is the only US FDA approved twice daily ocular corticosteroid for the treatment of inflammation and pain after ocular surgery. The image above shows an eye with angle closure, and in the image below we can see opening of the angle after laser peripheral iridotomy. Now coming to the purpose. Purpose is to assess the pertinence of using loteprednol etabonate 1% suspension in patients undergoing laser peripheral iridotomy. It's an observational study on patients undergoing laser peripheral iridotomy at Rajendra Nagar Super Specialist Eye Science Center, Patna during December 2023 to March 2024. It included patients of primary angle closure suspect, primary angle closure, and primary angle closure glaucoma requiring PI. Exclusion criteria were prior inflammatory disease of eye and patients not giving consent. Patients were treated with pilocarpine 2% to achieve meiosis, and YAG laser was used for doing PI. IOP was measured 30 minutes post laser PI. Loteprednol etabonate 1% was advised for 2 weeks, and at 2 weeks follow-up, patients were assessed for patency of the laser PI and for the inflammation by looking for the AC cells and AC flare. Data collect was assessed. Findings. IOP 30 minutes post laser PI was either decreased or if increased, there was no clinically significant IOP elevation. And at 2 weeks follow-up, 1 out of 34 eye was lamellar PI and required PI augmentation. 1 out of 34 eye had clinically significant IOP elevation even after multiple PI was done. This patient was having primary angle closure glaucoma with iris Bombay. Rest 32 eye had patent PI. This bar chart shows the number of IOP after 2 weeks in the corresponding eyes. And then, although there was 11 eye having rise in IOP, mean of rise in IOP was just 2 mm of Hg. Mean of fall in IOP was 10.67 mm of Hg, and there was no eye with clinically significant rise in IOP. This bar chart shows the number of eyes with AC cells and flare. Now the results. Loteprednol etabonate 1% is effective in preventing post-laser PI inflammation, as 32 out of 34 I had cells with grade 0 and 2 I had cells with grade plus 0.5, and there was no I with grade 1 or more. Loteprednol etabonate 1% is not associated with significant IOP elevation when used post-laser PI, as mean rise in IOP was just 2 mm of Hg, although 11 out of 34 I had IOP above baseline. No I had clinically significant rise in IOP. This article reported about a trial conducted on adult patients undergoing uncomplicated cataract surgery and with grade 2 anterior chamber cells on post-operative day 1 with potential post-operative Snellen's distance visual acuity of more than 6/60. As per this trial, there was complete resolution of AC cells in 20.7% patients in lotepred etabonate 1% BID group versus 12.4% in the vehicle. Resolution of ocular pain in 57.1% in lotepred 1% BID group versus 37.1% in the vehicle group. The efficacy results significantly favor lotepred 1% BID over vehicle. As far as they have removed. Sir, they have changed the. As far as conclusion is concerned, lotepred etabonate 1% is effective in controlling the inflammation and pain efficacy results. As far as safety results are concerned, it is adverse effect and IOP elevation was very minimal, or there was no clinically significant IOP, so it is very efficacious and at lower dose we can use it without compromising the safety.
Nice study, Sanjeev. In what dose did you use loteprednol and for how many days?
Sir, 1% was used 4 times a day.
For how many days?
Sir, 15 days.
Like 4 times. 4. You did not taper it?
Yes, sir.
You did not taper it?
No, sir, no taper. Okay. Sir, because it has retrometabolic design that provides its disintegration after the pharmacological effect is achieved, sir. Because there are esterases that breaks the ester bond as compared to conventional steroid that we use. They are having ketone bond. So once pharmacological action is achieved, it disintegrates and no adverse effect is seen, sir.
And did you give any anti-glaucoma medication to the patients?
Yes, sir.
What was that drug?
Sir, brimonidine, sir, brimonidine.
For 15 days?
Yes, sir. In the patients, those who are requiring, sir, such as angle closer glaucoma, in angle closer suspect, they are not used.
No, so you did not give brimonidine to all the patients who underwent PI?
Sir, for controlling the post-inflammatory, yes, after laser we were using it. Yes, ma'am.
How long was the patient follow-up? Like, was there any?
Ma'am, after doing laser PI for after 30 minutes, we took IOP just for. Yes, ma'am. Yes, ma'am. Yes. Because all the patients' inflammatory signs were subsided. Did you see any rebound inflammation after that period, No, ma'am.
Did you observe any patients who underwent bleeding like intraprocessor bleeding? Did they also respond to this drug? Like, did you have to augment
Sir,
this drug? Did you note anything like this?
There was no patient with any bleeding. Sir.
You did not have any patient who had
After
had bleeding
laser
during
PI,
the
there was
procedure?
no patient with bleeding. Sir.
That's wonderful.
Post laser, like half an hour, there was no rise in IOP. Rather, there was a decrease in IOP in all your cases.
No, sir. Some patients were having rise in IOP, but that was not clinically significant.
Okay.
Means not more than 10.
Okay. Thank you.
Thank you. Thank you, Dr. Sanjit. Next presentation by Dr. Mohan Raj. He is a postgraduate at AIIMS Patna now, and his presentation is Management of Traumatic Retinal Detachment with Retinal Dialysis by Scleral Buckle with Vitrectomy. So welcome.
Good afternoon, everyone. I am going to present a case report on management of traumatic retinal detachment with retinal dialysis by scleral buckling with vitrectomy. I have no financial interest to disclose. Retinal dialysis is a circumferential retinal break located at the ores aorta and a common cause of retinal detachment in children and young adults. Ocular trauma is the most common cause. Prevalence of 55 to 88% of all unilateral dialysis. Long-standing treatment of choice for retinal detachment due to retinal dialysis, scleral buckle, most commonly involved inferotemporal quadrant. A 13-year-old boy from Bhojpur, Bihar, school student came to the IOPD with the chief complaints of diminution of vision in right eye for last 15 days, floaters in right eye for last 10 days. Patient was apparently asymptomatic 15 days ago, after which he had trauma to the right eye by wooden stick while playing with the gully. He developed diminution of vision in right eye, which was sudden in onset, rapidly progressive in nature. Ocular examination in the right eye, best corrected visual acuity shows 3/60, left eye shows 6/6. Anterior segment examination shows in the right eye traumatic mydriasis. Rest of the anterior segment examination, including gonioscopic findings, are within normal limit. On fundus examination of the right eye, hazy media noted, macula of subtotal regmentosgenous retinal detachment noted. On peripheral examination, retinal dialysis from 10 to 11 o'clock with the inferior vitreous hemorrhage noted. Left eye, anterior and posterior examinations are within normal limit. Case summary: a 13-year-old boy presented to AIIMS Patna IOPD with the chief complaints of sudden painless and rapidly progressive diminution of vision for 15 days in right eye after trauma with the wooden stick. On examination, right eye BCVA was 3/60, left eye BCVA was 6/6. Anterior segment of right eye shows traumatic mydriasis. On right eye fundus examination, subtotal RRD with macula of retinal dialysis in 10 to 11 o'clock with the inferior vitreous hemorrhage. In left eye, anterior and posterior segment examination within normal limit. Diagnosis: right eye traumatic macula of subtotal RRD with the inferior vitreous hemorrhage. Routine blood investigation done. Patient underwent right eye scleral buckle plus pars plana vitrectomy plus endolaser plus silicon oil injection under GA with guarded visual prognosis. This is the steps of scleral buckle surgery. 360-degree peritomy done and traction suture, 4 traction suture under the recti taken and 240 band applied. Ends of 240 band introduced into the Watt's sleeve and 3 PPV ports made. Injection core vitrectomy followed by injection RO given, PFCL injected and drainage retinotomy made at 9 o'clock position, SRF drained. Endolaser around drainage retinotomy and retinal dialysis area done. Silicon oil injected. PP ports are removed, sutured with 80 vigral suture and peritomy closed with 80 vigral suture. On POD1, best on examination, best corrected visual acuity in the right eye 1/60. Anterior segment examination shows subconjunctival diffuse subconjunctival hemorrhage with a scleral buckle in place. On fundus examination, laser parts around retinal dialysis and drainage retinotomy site. Silicon oil filled globe, retina on. Routine post-op medication given with strict prone position for 7 days. At the end of 2 months, best corrected visual acuity in the right eye was 6/36. This first week post-op shows scleral buckle in place. This POD 1 month scleral buckle in place. Retina on, silicon oil filled globe, and adequate buckle height. At the end of POD 2 months, extraocular movements are full and free. Patient review after 1 month in retina clinic for right eye silicon oil removal. Discussion a retrospective consecutive case series involving 30 eyes of 30 patients with retinal detachment secondary to retinal dialysis was completed. All 30 patients underwent primary pars plana vitrectomy in addition to circumferential scleral buckle. The primary detachment rate was 6 months after a single surgery. At the end of the result, the final anatomical successful rate was 93% with a pars plana vitrectomy with a scleral buckle. This is another one study. At the end of this study, pars plana vitrectomy with a supplemental scleral buckle associated with a greater single operation success rate. Complication, choroidal common case. Take a message, ocular trauma is the most common cause, most commonly inferior temporal quadrant.
Nalla present.
Question like, this was a 13-year-old boy, okay, with a, you said infratemporal dialysis?
Superior temporal dialysis.
Supratemporal.
10 to 11 o'clock patients.
Okay, so why did you go for vitrectomy, not just buckling? And what was the buckle you used? You just used the 240 band?
240 band only, sir.
So why not just a buckling in this case?
This is just only 10 to 11 o'clock position, sir, retinal dialysis. If it is long means I can use scleral tire. That
no, it's short, so then a young boy with a small retinal dialysis, the procedure of choice should be just a scleral buckling with a cryopexy. Why a vitrectomy in this case?
There is a inferior vitreous hemorrhage, vitreous haze, sir. We cannot.
That will get resolved.
We can left any other break.
Somehow I feel that this case should have been just buckled. Okay, because you know whenever you are going for a vitrectomy in such kind of cases, the chances may, if a PVR develops again, you know, and inducing a PVD again must have been a bit difficult in these kind of cases. Roshan was there.
I agree with Dr. Deepak.
Yeah.
So, Roshan, the choice of treatment in dialysis is buckle. So, why did you undertake vitrectomy for 24 patients? Roshan, is it?
No.
Yeah.
Okay.
Thank you.
Thank you.
Next presentation is by Dr. Drishti Kumari. She is a postgraduate at RIO and she is presenting an epithelioid hemangioendothelioma and uncommon tumor of eyelid, a case report. So welcome.
Should I start? Good afternoon, respected judges and audience. Myself, Dr. Drishti, a junior resident RIO. I am presenting a case on epithelioid hemangioendothelioma, which is an uncommon tumor of the eyelid. It is a case report. There is no financial and conflict of interest. Coming to introduction part, epithelioid hemangioendothelioma is a vascular endothelial cell of neoplasm of low malignancy. EH occurs in the superficial or deep soft tissues of the limbs, liver, lungs, and bones. Among others, rarely occurs in the orbit or eyelid. Incidence is almost 1%. Epithelioid hemangioendothelioma occur at any age group, with cases occurring in patients between 13 to 86 years old, with a median age group of 50 years. Epithelioid hemangioendothelioma occurs in slightly more often in a woman, Male is to female ratio is 1:4, especially in the lungs and liver. The overall 5-year survival rate for patients with a complaint with this neoplasm is 73 years. Coming to my case presentation, a 60-year-old male resident of Darbhanga, Bihar presented to RIO OPD IGMS with a complaint of a mass in left lower eyelid from 3 years, for which he visited local ophthalmologist where he prescribed medication and referred to higher center. History of presenting illness was patient presented with a mass at lower eyelid. Mass was painless, smaller in size initially, which was progressive, increasing in size from last 3 years. Coming to physical examination part, the lower eyelid mass was measuring 2.5 into 2 centimeter into 1.5 centimeter in size with an irregular surface, experiencing mass effect at lower eyelid. He was having normal vision. Mass swelling was mobile, no bony attachments were there, non-tender, painless, regular, soft consistency, non-pulsatile swelling, and also local temperature was normal. There is no significant past history or family history related to this mass. No history of association to trauma is also there. On general and systemic examination, all examination were within normal limit. On general skin examination, patient had a sign of white patch all over the skin, which is suggestive of vitiligo. Coming to anterior segment examination, visual acuity was 6/12 in both eyes. IOP were normal. There is a 15 and 14 respective right eye and left eye. Extraocular movement were full and free in all gazes. Conjunctiva and cornea were clear. Lens having NS1 and NS1 to 2 in right and left eye. Pupil were reactive to light. Anterior chamber were normal in depth, no cells and flares in both of the eyes. Posterior segments examination were within normal limit. Coming to radiological examination, CCT orbit suggestive of a soft tissue neoplasm, FNAC showing soft tissue tumor which is epithelioid hemangioendothelioma. For confirmation, we sent the specimen under local anesthesia. Incision were made and cystic mass in toto was removed and suture of Mercel 60 applied, and excise samples sent for HP, which were also suggestive of epithelioid hemangioendothelioma. From clinical, radiological, and histological investigations, we came to diagnosis of epithelioid hemangioendothelioma of lower eyelid of left side. In further follow-up, we sent immunohistochemistry marker. Post-operative picture were there, no wound secondary infection noted, well opposed wound were there. DDs were in benign cases. We can go through squamous papilloma, epidermal inclusion cyst, cutaneous dermoid, keratoacanthoma, and malignant eyelid melanoma, squamous cell tumor, basal cell carcinoma, squamous cell carcinoma, Merkel cell, and epithelioid hemangioendothelioma. Coming to discussion part, epithelioid hemangioendothelioma is an uncommon vascular tumor which was firstly described in 1982. Its malignant potential is intermediate, essentially related to its location. Its occurrence in the eyelid region is very rare. It's 1% almost, so positive margin dissection and post follow-up with immunohistochemistry is much needed. To require follow-up, we come for immunohistochemistry marker. Thank you. Patient was doing normal, wound were completely normal, and patient's vision and wound were completely opposed, ma'am. No recurrence was there. 1 month. Yes, ma'am. Thank you, sir.
Next presentation is by Dr. Renuka J. She is a postgraduate at AIIMS Patna, and she is going to present as a clinical presentation and consideration in management of fundal coloboma among Eastern Indian population. Welcome.
Good afternoon, everyone. The title of my paper is Clinical Presentations and Considerations in the Management of Iridofundal Coloboma among Eastern Indian Population. No financial interest to disclose. Oculocolobomas are rare congenital disorders due to defective closure of the embryonic fissure affecting anterior to posterior all the structures including the iris ciliary body to the optic nerve. The average incidence ranges between 0.5 to 7.5 per 1 lakh live births, and it can be sporadic or hereditary, and it can either be isolated or associated with syndromes. The presentations of a coloboma are diverse. The aim of the study is to describe varied presentations and ocular comorbidities of the iridofungal coloboma. Rationale: having information on the varied presentation, systemic associations and management is crucial to provide better visual rehabilitation to the patients. Novelty of the study is this will be the first study in Eastern India to highlight the diversities of presentation and management of ocular coloboma, thus providing valuable insights and practical guidance for optimizing care for individuals with coloboma. Methodology of the study: it is a retrospective analysis of data of all the 47 cases of iridofungal coloboma registered in our retina clinic between June 2023 to March 2024, and the clinical examination and ophthalmological examination was done, and the colobomas were classified according to Edelman's classification. Fundus photographs and OCT macula were done wherever possible, and comorbidities such as cataract and RDs were treated accordingly, and patients were kept on regular follow-up. Analysis was done by entering the data in Microsoft Excel 2021, and categorical data and quantitative data were expressed as means and proportions respectively. Coming to the analysis, age. The mean age of presentation in our study group was found to be 22 years, with 60% of the population were under 18 years of age at their first presentation. And gender predilection was male population had a predominance with 63% of the patients were male, and there were bilateral involvement was maximum with 65% had bilateral involvement. The presenting features are listed here. With diminution of vision was found in 36 out of 47 cases studied. It was a main presenting complaint in all the patients, and syndromic associations were found in 3 cases. Other comorbidities associated with iridofungal coloboma are listed here, of which microcornea, nystagmus and cataract were the commonest and found in most of the cases, and family history was found significant in 2 cases. This is the anterior segment examination showing a typical complete coloboma in the inferior nasal quadrant with a lenticular change showing cataract. Based on Edelman's classification, type 1 coloboma was reported in 14 cases, and it was the most common in our study, and type 2 coloboma was seen in 5 cases, and type 3 is the second most common with 12 cases reported. Type 4, the coloboma involving the disc was presented in 6 cases, and type 5, 7 and 6, in each type 1 case reported. Lenticular findings, 13 cases of cataract were noted, of which IMSE is the most common type, and phacodonosis was noted at 1 patient, and subluxation was noted at 1 patient at the time of presentation. The mean age of cataract presentation in iridofungal coloboma was 18 years. 3 cases were operated, of which 1 went phacoemulsification and other were operated with SICS. Complications in cataract surgery were due to poor dilation, hard nucleus and zonular deficiency, and the choice of surgery depends upon the presence or absence of zonular instability and corneal diameter. Other considerations in surgery were making a corneoscleral tunnel, use of iris hooks or capsular tension rings or Sioni rings, and high molecular dispersive viscoelastics. This is a case of a patient who presented with both the iridofungal coloboma with a nucleosclerosis of grade 2 to 3. Phacoemulsification was done. Intraoperatively, iris hooks were used for better visualization, and 2 capsular tension rings were used, one before breaking the nucleus and one after breaking the nucleus, and phacoemulsification was done with successful implantation of the IOL, and the post-op visual recovery was finger count at 2 meters and in the follow-up. Retinal detachment. The incidence of retinal detachments was found to be 19% in our case series, with RRD accounting for 8 cases, and fractional RD was found in 1 case. Mean age of presentation was RD was 14, and 4 cases in coloboma which didn't have any RD, but we gave prophylactic laser barrage, sparing the foveal margin, and 1 case of RD was given laser barrage only. The surgery in case of RD was postplanar vitrectomy without lensectomy and endolaser with silicone oil implantation. And RD surgery in case of iridofungal coloboma, the challenges that we faced were difficulty in visualization, detection and closure of breaks, and laser photoablation couldn't be done at the level of fovea, which has a complication of recurrence in future. The common site for break is the intercalary membrane in case of RDs associated with coloboma. Conclusion, complete typical colobomas were seen in maximum number of cases, and diminution of vision was the most common presenting complaint. Bilateral presentation with a male preponderance were seen. Presenting visual acuity was poor in colobomas involving macula. Colobomas not involving macula without any other comorbidities were given refractive correction for the possible best corrected visual acuity. And the choice of cataract surgery in case of coloboma is based on corneal diameter and zonular instability. Retinal holes are and no specific association between the type of coloboma and RD was noted. Genetic factors had minor contribution, and patient education and follow-up is highly crucial.
Thank you. That was very fast, actually. Yeah. Actually,
47, ma'am. Yes, ma'am.
47. So actually, you ran through your table, actually. You have your result table, actually. We couldn't see it very clearly. So, so from, according to you, which was the most common type of coloboma?
In our study, it was type 1, sir.
Type
1.
So that was the Idaman classification.
Yeah, according to Idaman, type
also
1.
by Lingam Gopal sir's classification.
Sir?
Dr. Lingam Gopal's classification is also there.
Yes, sir.
So according to you, type 1. So type 1 means the visual acuity was very poor?
Poor.
Very poor. So majority of patients were type 1.
Majority were type 1
So that was
only,
the
sir.
disc was inside the coloboma or outside?
Inside the coloboma, sir.
Inside the coloboma. Okay. Thank you.
Thank you, sir.
Next presentation is by Dr. Akshay Kumar. He is also postgraduate at AIIMS Patna. His presentation on management of OSSN with topical 0.04% mitomycin C.
So good afternoon everyone. I am going to present on management of ocular surface squamous neoplasia with topical 0.04% mitomycin C. No financial interest to disclose. Introduction. OSSN encompasses precancerous and cancerous epithelial lesion of conjunctiva and cornea. It accounts for 39% of pre-malignant and malignant lesions of conjunctiva. Incidence of invasive cancer is 0.02 to 3.5 per lakh of population. Currently, surgical excision with no touch technique is the standard mode of treatment for OSSN. But surgical management, it may leave residual unrecognized disease, and there may be risk of limbal stem cell deficiency, cryotherapy effects, and infection. Topical chemotherapy advantages. It treats entire ocular surface, microscopic as well as subclinical lesion. There is no LSCD, and it is well tolerated. Cons. Longer time for resolution, compliance issues, cost, and side effects. Indications for medical treatment. Diffuse disease, corneal involvement, and recurrent disease. Topical chemotherapeutic agents for OSSN are interferon alpha-2b, 5-fluorouracil, and mitomycin C. It is an alkylating agent and it inhibits DNA and protein synthesis. It is easily available and it is a cost-effective medication. Design of the study retrospective case series, duration November 23 to Feb 24, sample 20 cases of OSSN, site of the study Department of Ophthalmology, AIIMS Patna. So detailed history and general and systemic examination were done, comprehensive ophthalmic evaluation and detailed slit lamp examination performed, diagnostic workup was done using Rose Bengal stain and anterior segment OCT. And then finally patient was started on eye drop mitomycin C 0.04% QID for 4 days a week. So demography, total 20 patients were there, 13 were male and 7 were female. Unilateral cases were 18 and 2 cases were bilateral. So here are the various presentations. So papilliform variety, total there were 8 cases, leukoplakic 3 cases, gelatinous 6 cases, and 3 cases were others. So papilliform OSSN, it consists of pink papilliform minimally elevated flat lesions with intrinsic vascularity. In another photograph, you can see there is whitening and thickening of tuber surface. It indicates leukoplakic OSSN. Next is the gel-like consistency of the lesion indicating gelatinous OSSN. So results, there were among 20 cases, 5 cases were lost to follow-up. Partial resolution was there in 5 cases, and complete resolution was there in 10 cases with 8 to 9 cycles. So success rate was almost 66%. Here are some of the representative cases. In the first image, you can see with just 6 cycles, there is the atrophy of the lesion. In next diagram, next photo, you can see that it is involving upper 1/3 of the cornea, but with 6 cycles, it has resolved. So in this also, there is complete clinical resolution. And in the second image, there is decreased thickness as well as reduced vascularity, and the underlying scleral surface has now become clearly visible after 9 cycles. Discussion. In our study, total number of cases were 20, number of male and female patients were 13 and 7 respectively. 5 cases were lost to follow-up. In 15 cases treated with mitomycin C. So the resolution was seen in 8 to 9 weeks in 10%, that is 66% of the cases. Another randomized controlled trial by Hurst et al. He selected 48% and 26% were given the mitomycin C, Among them, 24 had complete resolution. Another study by Balali et al. In 18 patients, he gave mitomycin C continuously for 28 days at QID dose, and there was 100% resolution. Summary. Uh, there has been shift toward medical management considering better efficacy and tolerance of topical drugs. A strong suspicion of OSSN should be there in high-risk patients, old age or immunocompromised, if the lesion is present over the limbus or if it invades cornea. If no response with topical therapy is seen in 6 weeks, we should change the drug or we may plan for surgery. Long-term follow-up of 5 years is mandatory to rule out any recurrence even after initial resolution. Thank you very much. Yes, ma'am, we use lubricant. Okay. We use carboxymethyl cellulose along with it.
Okay. Study Akshay. What was the protocol? Like, how did you use the medicine?
First, all the patients were selected and it was started as QID dose, sir. 4 times a day in a week, 4 days and 3 days off in a week.
And it was given continuously for 6 weeks?
Yes, sir.
And then stop for how many weeks?
What?
Stop for how many cycles? Like, how did you stop and restart?
Means we were continuously giving it.
For how long?
Till resolution.
You did not between?
No, sir, it was continuously given. Yes,
okay,
sir.
okay. So, what happened? Did you encounter any patient who was continuously using it, like without putting it off? Did you see any side effects?
No, mostly hyperemia was there, sir. So, it was well controlled with lubricants and all.
Therapy was complete, compliance was 100% in all patients?
Almost, ma'am.
Okay. So there was no withdrawals, no dropouts?
No. 5 follow-up were lost only.
Next presentation by Dr. Namrata Upadhyay. Her presentation is orbital apex syndrome, a case report. Please welcome.
Good afternoon, everyone. Myself, Dr. Namrata Upadhyay. I am second year ophthalmology resident at GMCH Betia. I will be presenting about my case report on orbital apex syndrome. I have no financial interest to disclose or no conflict of interest. Coming to the case history, we have this patient, 55 years old female, who came to our OPD with the chief complaint of sudden loss of vision in her right eye since 3 days. It was associated with orbital pain and drooping of the right eyelid. There was no other significant history of diabetes, hypertension, or any other systemic illness. There was history of cataract surgery done in both eye elsewhere some year back. No other ocular disease or medication history or any history of trauma. Her systemic examination was well within the normal limit. Her ocular examination revealed some positive findings in the right eye, which included the ptosis, fixed and mid-dilated pupil, absent light reaction. It was pseudophakic, and the eye movements were restricted in all the 9 gazes. Her best corrected visual acuity was PL negative. Her fundoscopy revealed pale fundus and pale disc. These are the images of the patient. Here we can see that the eye movements are restricted. Differential diagnosis we thought were orbital apex syndrome, since there was optic neuropathy, ophthalmoplegia, and orbital pain. We ruled out superior orbital fissure syndrome since in SOF there is no involvement of optic nerve. Cavernous sinus syndrome we rule out because of involvement of optic nerve, and there was no facial pain, which is a feature due to maxillary division of trigeminal nerve. Other causes of ophthalmoplegia like ocular myasthenia were also ruled out. Certain investigations were ordered like blood sugar fasting and postprandial, complete blood count, and CECT brain and orbit. CECT showed mucosal thickening in the right maxillary, bilateral ethmoid, and right sphenoid sinuses, and gliosis in the right frontal lobe. A provisional diagnosis of right eye orbital apex syndrome was made. The treatment given was supportive, which included antipyretic, antibiotic, and antacid. The patient was referred to a neurophysician for further evaluation and management. So, orbital apex syndrome is characterized by vision loss from optic neuropathy and ophthalmoplegia due to involvement of ocular motor nerves in the anatomical region of orbital apex. Orbital apex is basically the posterior part of orbit positioned at the craniofacial junction where the four orbitals wall converge. It incorporates optic canal and the superior orbital fissure. This is the image of orbital structures involved in the orbital apex syndrome. Here is we can see there is dysfunction of optic nerve, oculomotor nerve, trochlear nerve, abducent nerve, and the ophthalmic branch of trigeminal nerve. The most common initial manifestation is the visual loss and ophthalmoplegia. Other features include diplopia, mydriasis, ptosis, absent corneal sensation and corneal reflex, RAPD and anisocoria, periorbital pain and hyperesthesia of forehead, proptosis, optic disc edema or optic atrophy. Etiology are broadly categorized into various groups like inflammatory, which included SLE, sarcoidosis, Churg-Strauss syndrome, Tolosa-Hunt syndrome, and thyroid orbitopathy. Infectious causes like bacterial, viral, fungus, and most often it is associated with invasive fungal sinusitis or post-septal bacterial orbital cellulitis. Neoplastic causes can be there. Then we have iatrogenic or traumatic causes, vascular causes like carotid cavernous aneurysm, carotid cavernous fistula, and cavernous sinus thrombosis. Other causes are mucocele, neurofibromatosis, and fibrous dysplasia. Treatment depends upon the etiology, and OAS responds to treatment within 48 to 72 hours once therapy is initiated. An accurate diagnosis and prompt specific treatment determines the prognosis of patient with inflammatory causes subside with the steroid therapy. To summarize, we can say orbital apex syndrome causes painful external ophthalmoplegia with vision loss. The patient presented to us with right eye sudden loss of vision associated with orbital pain and right side drooping eyelid. Based on our ocular examination and investigation, provisional diagnosis of orbital apex syndrome was made and the patient was given supportive treatment. The patient was then referred to a neurophysician for further evaluation and management. Thank you.
Thank you, Dr. Renuka. Thank you.
Thank you, sir.
Next presentation by Dr. Sneha Raj, JR2 in ophthalmology from GMC Betia.
Good afternoon, everyone. Myself, Dr. Sneha Raj, JR2 Ophthalmology Department, GMC Betia. I'm going to present cases of sudden vision loss, optic neuritis. There is no financial interest to disclose, no conflict of interest. Introduction: optic neuritis is demyelinating inflammation of optic nerve. It can be classified as retrobulbar neuritis, papillitis, neuroretinitis. In retrobulbar neuritis, optic discs appear normal and most common in adults and frequently associated with multiple sclerosis. In papillitis, is characterized by hyperemia, edema of optic disc, which may be associated with peripapillary flame-shaped hemorrhages and most common type in children. Neuroretinitis is characterized by papillitis in association with inflammation of nerve fiber layers, and in macular star, it least common type and only a rarely manifestation of demyelination. Etiology: demyelinating, most common cause, para-infection following a viral infection or immunization. Infectious: this may be sinus-related or associated with catastrophic disease, syphilis, Lyme disease, cryptococcus meningitis, and herpes zoster. Non-infectious associated with sarcoidosis, SLE, PDA, and other vasculitis. Differential diagnoses are neuroretinitis, retrobulbar neuritis, labral hereditary optic neuropathies, anterior ischemic optic neuropathies, compressive optic lesions, sarcoidosis, syphilis, vasculitis, toxic or nutritional neuropathies. In case 1, a 30-year-old female presented to OPD with sudden diminution of vision in left eye since 7 days and associated with eye ache. There was no history of trauma, fever, vaccination, recent travel, body ache, numbness, or any neurological deficit. There was no history of diabetes, hypertension, and any other systemic illness. And on systemic examination, the patient was cooperative, vitals are stable, and other systemic examination within normal limit. In case 2, a 45-year-old male presented to OPD with sudden diminution of vision in right eye since 10 days and associated with eye ache, past history of herpes zoster ophthalmicus 3 months ago, treated elsewhere. There was no history of trauma, fever, vaccination, and any other systemic illness, and systemic examination within normal limit. In case 3, 29-year-old presented with sudden diminution of vision in left eye since 3 days, and there was no significant history and systemic examination within normal limit. In case 4, the 35-year-old female presented with sudden diminution of vision in both eye, left eye is more than right since 6 days and associated with eye ache. There was no significant history and systemic examination within normal limit. In case 5, there's 25-year female presented with sudden diminution of vision in right eye since 10 days. There was no significant history and systemic examination with a normal limit. And these are ocular ophthalmic examination of 5 cases, and the similar features found in these cases, that is color vision, decreased contrast sensitivity, decreased color perception, diminished light and bright appreciation. Ocular movement was pain exaggerated on movement in all 5 cases. There was mid-dilated and fixed pupil. RAPD was present. On fundoscopy, there is hyperemic and edematous disc margins, blood disc margins. In case 2, there is additional features, that is interstitial keratitis due to herpes zoster ophthalmicus history 3 months ago. There was fluorescein stain negative. There was no active infection. And the basis of these features, the optic neuritis was made on provisional diagnosis of respective eye. And the treatment was given, considered only for patients who require fast recovery, have severe bilateral vision loss in patients with poor vision in fellow eye. Steroid and optic neuritis are used for the acute exaggeration. In these cases of optic neuritis, treatment was given according to ONTT. The patient was given intravascular dexamethasone 12 vial of 8 milligram in 100 ml of 5% dextrose for 3 days, and then the patient was shifted on oral prednisolone tablets in tapering dose for 11 days. Results, out of 5 cases of sudden vision loss, we had male to female ratio 1:4, and with ODOS 2:3, and all of them presented with classical symptoms such as pain, eye movement, abnormal color visions, and impaired contrast sensitivity. Treatment was given according to ONTT, and all of them recovered with best corrected visual acuity 6.9 or better, and significantly improved contrast sensitivity. And conclusion, optic neuritis causes sudden vision loss with decreased contrast sensitivity and color vision. We treated all the 5 patients according to ONTT guidelines. Now, after treatment, contrast sensitivity, color vision was tested, which returned to normal, and also visual acuity improved in all cases. Thank you.
No investigation such as VEP or anything was done in any of the cases?
Ma'am, blood tests were given normal infectious causes, that's it. CBC, ESR, blood sugar, nothing else.
One of your cases was bilateral, you said?
No, sir.
All were unilateral?
Visual acuity was within 6/12 or...
No, one case you said both the eyes were affected.
Yes, sir. That's visual loss, no affected, left eye was not affected. There is diminution of vision due to some other causes that cataract was present.
Oh, optic neuritis?
Optic neuritis was present in one eye.
One eye only in all the cases. So anything new you found in this? I mean,
sir, second case was the herpes zoster ophthalmicus was present 3 months ago. This interstitial keratitis, nothing else, sir.
We usually give IV methyl prednisolone in these cases. Why did you give Deca?
Sir, government supply is available. Dexamethasone was available in government supply. That's why I'm using dexamethasone.
Okay. I think if available, IV methyl prednisolone gives much better results than Deca. No.
thank you.
Next presentation by Dr. Rahul Kushwaha. He is going to present on computer vision syndrome. Please come.
A very good afternoon. Myself, Dr. Rahul Kushwaha, postgraduate, present first year from GMC Betia. I am here to present on the topic Computer Vision Syndrome, Modern Era Challenge. Firstly, no financial relationship to declare. What is Computer Vision Syndrome? Computer vision syndrome is also known as digital eye strain, is the combination of ocular and visual symptoms resulting from prolonged digital screen exposure. It affects most 75 to 85% of computer users. The prevalence of computer vision syndrome has surged in recent years due to the widespread adoption of digital devices across all age groups. Studies indicate that the significant proportion of individuals who use computers, smartphones, and other digital screens experience symptoms of CVS, highlighting the urgent need for preventive strategies and effective management approaches. The aim of the study is to evaluate risk factors associated with computer vision syndrome and to prevent and treat such cases to reduce the impact of computer vision syndrome. Methodology. We studied continuous 150 patients who were using computer and other digital screens for more than 4 hours, presented with symptoms suggestive of CVS in the time period between October 2023 to January 2024. The inclusion criteria is age group 15 to 45 years of age, screen time more than or equal to 4 hours, patient with best corrected visual acuity 6/6. Exclusion criteria are age less than 15 years and above 45 years, patients suffering from any infectious condition of eye like conjunctivitis, scleritis, uveitis, staph, blepharitis, and meibomitis. Detailed clinical history including duration and pattern of digital screen use and ocular symptoms. comprehensive ophthalmic examination including visual acuity, refraction, and slit lamp examination was done. Sharma's test and tear film breakup time was done for dry eyes. Patients were followed up after 2 weeks, 3 weeks, and 4 weeks to see any improvement in their symptoms. For intervention, glasses were prescribed, artificial tear drops were given, preventive measures were described to patient example 2022, proper sitting posture, use of proper light during the use of digital screens, blink more, sufficient hours of sleep, and not using digital devices just before the sleep. Results, 150 patients were selected, out of them male were 83 patients, female were 67 patients, most of them are young patients. Best corrected visual acuity in all patients is 6/6. According to profession, most of them are students, 76%, professionals are 22%, and housewives are 2%. The presenting symptoms of the patients were headache, dry eyes, watering eyes, irritation and redness, neck pain, blurred vision, and shoulder pain. By the third week, out of 150 patients, we noticed that 136 patients shows improvement, and remaining patient also shows improvement by the end of the third week after the preventive measures and treatment given. Discussion. In this study, 150 patients, of all of them had screen time more than or equal to 4 hours. Most of them patient presented in OPD after 10 to 15 days of appearance of symptoms. Glasses, artificial tear were prescribed. Preventive measures were described to patients. And all these preventive measures are easily acceptable and simple for the patients. Various studies shows that there is an important association with the blink rate, that when we use computer or other digital devices for prolonged hours, the blink rate decreases. Normal blink rate is 60 to 20 per minute, but when we use computer or screens, then it goes down to 6 to 8 per minute. Then in the absence of adequate blinking, eyes become dry and irritated. Prolonged use of screen also associated with sustained effort for near vision, or that is accommodation, which leads to increased stress in near vision, leading to inaccurate accommodative power. Conclusion. Computer vision syndrome has become increasingly prevalent in modern society due to the widespread use of digital devices in both professional and personal settings. Students are more affected than other people who use computers. By recognizing risk factor and implementing preventive measures, we can reduce the impact of computer vision syndrome and promote ocular health and well-being in the digital age. Take-home message. Preventive measures remains the main strategy in managing computer vision syndrome. Last but not the least, do not become slaves to your digital devices, as these may impact our future generation in an irreversible and dangerous way. Thank you. Mostly it can be the headache and irritation, dry eyes.
You did not use any questionnaire to assess them? No questionnaire?
No, questionnaire is not.
Out of the remedies which you gave them, which was the most effective? Was it artificial tears, or was it glasses, or was it a combined one? How did you find out?
Combined preventive measures which gave the results.
In all the cases?
Yes, mostly.
Okay, thank you.
Thank you, sir.
Next presentation by Dr. Anurag Kumar Das. He is going to present of evaluation and management of herpes zoster ophthalmicus, a case series. Please welcome.
Good afternoon. I, Dr. Anurag Kumar Das, PG first year from Government Medical College, Betia, here to present my topic on evaluation and management of herpes zoster ophthalmicus. There is no any financial interest. Introduction. Herpes zoster ophthalmicus occur when the varicella zoster virus is reactivated in the ophthalmic division of trigeminal nerve. Most patients with herpes zoster ophthalmicus present with periorbital vesicular rash distributed according to the affected dermatome. It constitutes approximately 10% of all cases of herpes zoster. Permanent sequelae of herpes zoster infection may include chronic ocular inflammation, loss of vision, and debilitating pain. A minority of patients may also develop conjunctivitis, keratitis, uveitis, and ocular cranial nerve palsy. Our aim is to manage the patient of herpes zoster ophthalmicus with antiviral medicine, eye lubricant, cycloplegic eye drop, antibiotics, oral analgesic, and steroid. We also evaluate the visual outcome after antiviral therapy in patients with herpes zoster ophthalmicus. We also see various presentations of patients with herpes zoster ophthalmicus. materials and methods. 15 patients with herpes zoster ophthalmicus from November 2023 to January 2024 were included. The eye were treated with acyclovir eye ointment along with cycloplegic, oral analgesic, acyclovir tablet, eye lubricant, and moxifloxacin eye drop and steroids eye drop. We have done visual acuity, corneal sensation, staining of cornea, and slit lab examination of the patient on every visit of patient. The patient were followed up at 2 days, 1 week, 2 week, 3 week, 4 week. Visual outcome were evaluated at each follow-up. Result: 15 patients were selected. All of them were above 40 years. 12 was male, which constitute 80%. 3 patients was female, approximately, which constitute about 20%. Hutchinson sign was present in 10 patients. Corneal sensation was absent in 12 patients, 80%. Corneal staining was positive in 12%, 80%. Eye was present in all the patients. Keratitis was present in 6%. Uveitis was present in 15%. Conjunctivitis was present in 10%. Post-herpetic neuralgia were present in 3%. Discussion. Herpes zoster ophthalmicus may result in central corneal scarring and opacification. Stromal keratitis occur in approximately 40% in patients with herpes zoster ophthalmicus. Post-herpetic neuralgia affect about 20%. Elevation of pain with oral acyclovir during initial stage of disease, especially if drug is taken within first 3 days of symptoms, and it may have favorable effect on post-herpetic neuralgia. Acyclovir administration within 72 hours of onset have been found to speed resolution of skin lesion, reduce viral shedding, and decrease the incidence of dendritic and stromal keratitis as well as anterior uveitis. The incidence of late ophthalmic complication was also reduced by about 50%. For management of keratitis, topical steroid was given once the ulcer is healed. Acute pain control was achieved by local care and oral analgesic. For skin lesion, dermatological reference was advised. Visual outcome was also improved after the treatment. These are my references. Thank you.
Nice presentation. So what was the incidence of post-herpetic neuralgia in your case series?
Approximately 3% was affected with post-herpetic neuralgia, which constitutes 20%, sir.
Yours was 20%.
Yes, sir.
Even the normal.
I have read other studies, and 7% post-herpetic,
in other studies.
7%
yeah.
difference was given. I think it was a small size, only 15%, so this variation occurs.
Yeah, definitely we do see a lot of post-herpetic neuralgia, so that's okay.
Thank you.
Did you have any patients with ocular motility problems, like any nerve palsies?
In this 50%, I do not have any patient with nerve palsy. All of them recover very well.
Did you require any systemic corticosteroids for any of the patients?
Yes, sir. I have given systemic steroid to 2 patients, sir.
Was it mentioned?
With the suggestion of my senior and dermatology department senior.
Okay.
Yes, sir. Thank you.
Next presentation by Dr. Anita Sankla. She is going to present a cross-sectional study of anterior chamber angle parameters and biometric parameters in patients with shallow anterior chamber and their siblings at tertiary care center in Eastern India. Please welcome.
Good afternoon, respected judges and my dear friends. So my free paper is on the topic of cross-sectional study of anterior chamber angle parameters and biometric parameters in patients with shallow anterior chamber and their siblings at a tertiary care center in Eastern India. There are no financial disclosures or conflicts of interest. These are the abbreviations used. So primary angle closure glaucoma causes 2.5% more blindness compared to primary open angle glaucoma in spite of less prevalence, and Asia accounts for 76.7% of total cases in the world. Many factors predispose for angle closure glaucoma, and a positive family history is important risk factor predisposing siblings to angle closure 8.8 times more compared to general population. So my primary research objective was to evaluate the difference between the anterior chamber angle opening distance, AOD 750, which is measured at 750 microns from the scleral spur, between the two groups, group 1 being probands and group 2 being siblings. And the secondary research objective was to evaluate the differences between the angle and biometric parameters between the groups and the two subgroups which were concordant and discordant.
Concordant groups were, these subgroups analysis were divided based on the angle status of the siblings. Concordant siblings had shallow anterior chambers, while discordant pairs had siblings with open angles. So my study design was a cross-sectional observational study, which was held at Ames Patna Ophthalmic OPD. Inclusion criteria consisted of 20 to 60 years, males and females. Group 1 being of von Harry grade 0, 1, 2, and group 2 being siblings with the same biological mother and father. So the patients were recruited from the OPD itself, and VH grading was based clinically on slit lamp examination. Consent was taken, and the patient was counseled to bring their sibling along on the next visit. The patient and the sibling underwent ASOCT and biometry after consents, and outcome variables were measured. So looking at this ASOCT image, so the parameters which were concerned in my study was anterior chamber width, which was the distance between the two scleral spurs, lens volt, which was the perpendicular distance from the anterior-most surface of the lens to the anterior chamber width, AOD 750, which was angle opening distance 750 microns from the scleral spur, and TISA being trabecular iris space area at 750 microns, again from the scleral spur. So this is an image of my patient from the machine we have in our department, Heidelberg Spectralis, and these are the measured parameters. And the magnified view shows that the AOD was measured from the inbuilt tool present in our machine, while TISA was from a drawing tool. This is a biometry of a patient in which the parameters which were concerned were axial length, keratometry, TK1, TK2, anterior chamber depth, lens thickness, and CCT, central corneal thickness. The results were that 25 patient sibling pairs participated. Maximum participants were females, 92%. The mean age of the probants and siblings was not significantly different. 8 variables from ASOCT and 6 variables from optical biometry, which was measured from IOL 700. All the variables were normally distributed and t-test was used. So this result table graph shows that there was no patient of VH0. Coming to AOD 750, as we can see that it was measured in 2 quadrants, nasal and temporal. There was statistical significant difference between the proband and the siblings in the nasal and temporal values, as well as in the discordant pairs. However, there was no statistical difference in the concordant pairs. This is the QQ plot showing the same normal distribution. The secondary objectives, we can see that there were 9 parameters with a statistically significant difference. This is again showing the difference in the concordant pairs and discordant pairs. So there was statistically significant difference in 4 parameters in the concordant pairs and 10 parameters in the discordant pairs. So coming to the discussion, from the previous study, it was shown that AOD 750 has a difference of more than 0.12 mm in the proband sibling pairs. It was similarly proven in our study. Also, the statistically significant values of temporal values of AOD 750, TISA 750, and ACA 750 were similar to the study which was held by Ciocciola in the South Indian population. In conclusion, we suggest that the parameters lens volt, ACD, anterior chamber depth, axial length, as well as nasal values of AOD 750, TISA 750, and nasal anterior chamber angle 750 can be used for screening in patients. In siblings, as concordant siblings showed no statistical difference in these values, and the corneal parameters analyzed showed no statistically significant difference in the group and analysis. The limitations were that the study was a smaller size and single-centric, and therefore we recommend a larger size and multi-centric longitudinal study. Thank you.
The angle measurement was done manually. The angle measurement that is done manually. The tools that you use it, you draw it yourself?
No, ma'am. First, manually the scleral spur was identified,
okay,
and the rest of the tools like anterior chamber width, that was given by inbuilt tool. Only TISA required freehand drawing.
Freehand drawing. So was there any observer bias? How was that negated? Like how many observations you took to take the final, or 2 people took the observations? How was it negated?
Ma'am, I was the only investigator. So if there was a bias, then I used to draw 2 to 3 in different images at the same level. And if the values came to be same, then the average was taken.
Okay, so this was done for every patient or was? in which you felt that there could be a mistake?
Ma'am, it was done in case if I had discrepancy. Most of the patients, ma'am, TISA was more or less same. Matlab, even if we take the boundarings once or twice, the area came out to be the same.
Okay. And another thing I wanted to know that why was keratometry was not introduced if you want to prove something that, okay, in siblings this is the pattern or whatever, so keratometry also has an influence. And was there any other parameter which was measured, like siblings are there, or height, weight, or anything else was taken into consideration?
No, ma'am, only ocular parameters were taken into consideration.
Very nice presentation. Next presentation is by Dr. Sumedha Parasar. She is going to present on mechanical ptosis, burden on leads, different cases, scenario, evaluation and management. Welcome.
Good afternoon, everyone. This is Dr. Sumedha Parashar, JR3 from IGIMS, and today I'm going to discuss about mechanical ptosis, burden on lids, different case scenarios. I have no financial disclosure or conflict of interest. So ptosis is known as the drooping of the upper eyelid, and the patient usually present with the complaint of defect in vision and cosmesis. It can be congenital or acquired, or it can be neurogenic, myogenic, aponeurotic, mechanical, or traumatic in origin. Proper evaluation, diagnosis, and accordingly treatment are the key to prompt management of ptosis. In this case series, we will be discussing different cases of mechanical ptosis, their evaluation and management. Case 1 is a case of mechanical ptosis due to plexiform neurofibroma. An 11-year-old boy presented with a right eye upper lid mass, which was painless, progressing for the past 2.5 years, causing drooping of the eyelid. On examination, visual acuity were both high 6/6. Right eye mechanical ptosis was prominent with a mass-like felt through it, having bag of worm-like consistency, soft and immobile. Anterior and posterior segment examination were within normal limit. Multiple skin nodules were present on both forearms and abdomen of patient as well as patient's father. Here is the image showing the same. A contrast-enhanced MRI of the brain plus orbit was done. A provisional diagnosis of plexiform neurofibroma involving the right eye upper lid was made. Optic nerve head and brain parenchyma were not involved. Patient underwent debulking surgery and was discharged post-surgery with sufficient discharge instructions and followed up with good recovery. Here is the post-op day 1 with significant lid edema and sutures are intact, whereas post-op day 10 with significant reduction in edema, preserved levator function and good visual acuity. Second case is a case of dermoid. A 65-year-old male came with the chief complaint of a large painless mass in the right eye, superiorly since birth, increasing in size over years, causing drooping of the upper eyelid. Mass was firm, round, regular, smooth, non-tender, non-inflamed, mobile under the skin, approximately 4 into 3.5 centimeter in diameter, appeared to be originating from the superior-temporal orbital rim. Posterior margins were palpable, denoting superficial origin. Anterior segment examination, right eye visual acuity 636, left eye 624 with lenticular changes in both eyes, and right eye severe ptosis due to the mass. Rest of the anterior segment and posterior segment examination were within normal limit. Contrast in an CCT of brain plus orbit shows extraconal well circumscribed non-enhancing cystic lesion arising from superior temporal orbital wall with normal underlying bones suggesting of dermoid. This is the mass which was excised in toto, and this is post-op day 1 with lid edema and post-op day 10 with significant reduction in edema and improvement in ptosis. Case 3 was a 65-year-old female came with chief complaint of left eye upper lid mass from few months. The mass started with a small grainy lesion that progressively increased in size over few months, involving almost complete upper eyelid, causing mechanical ptosis. There was no evidence of lymphadenopathy. MRI was suggestive of 2.5 into 1.6 centimeter mass with enhancement, likely of malignancy. Patient underwent excisional biopsy of the mass with 3 mm clear margin away from the induration, and sample was sent for frozen section. Post-confirmation of free margin, cutler blade surgery was performed in 2 stages to fill in the large defect. Stage 1 involved a full thickness cutaneo-myoconjunctival advancement flap raised from the lower eyelid and sutured in the upper eyelid defect, and stage 2 involves dividing the pedicle after 6 to 8 weeks. Histopath examination shows sebaceous cell carcinoma. Patient was followed up with good recovery. This is the image showing post-op day 1 of stage 1 cutler beard reconstruction surgery, and this is after stage 2 of cutler beard surgery. Another case was of a 57-year-old female who presented to RIO with the chief complaint of mass on the inner side of the upper lid that was rapidly increasing in size. Mass was irregular, multilobular, fixed to the underlying conjunctiva with posterior margin not well defined. No evidence of lymphadenopathy was noted. MRI was suggestive of multilobulated variable enhancement mass of 1 into 0.8 centimeter. Patient underwent excisional biopsy. Mass was excised with 3 mm of clinically normal tissue margin away from the induration and sent for frozen section and histopathy examination. Post-confirmation for tumor-free margin, upper lid was reconstructed through tendial rotational flap and patient was followed up with good recovery. Here is the image showing the same. So discussion is mechanical doses can affect patients' day-to-day life, impairing vision, affecting cosmesis, causing social embarrassment, and can be reverted back to much extent with timely diagnosis, evaluation, investigation, and appropriate management. Different cases come with different challenges like neurofibroma, complete excision is difficult, and recurrences are high. In suspected malignancy, lid defect can only be constructed after confirmation of tumor-free margin by histopathology. Recurrences are very common. Despite all the challenges, desirable outcomes can be achieved, giving good patient satisfaction. Thank you.
Thank you.
I, on behalf of all my colleagues, congratulate all the presenters. All of you have presented very well, and presentation in these forums will make you achieve further heights. So try to keep presenting in all these forums. Thank you.
So thank you, respected Chairman Dr. Ajay Sinha sir, panelists Dr. Bhavesh Chanda sir, and respected judges Dr. Ranjana Kumar ma'am, Dr. Deepak Agarwal sir, and Dr. Abhishek Kedia sir. We finished on time almost, so next session we are going to hand over to Dr. Shivani Sinha ma'am. So please come to the dais. Dr. Ravi Kumar का भी नाम इसमें स्मिता का चेंज हुआ है.
So we start the session 3 of PG free paper session, and I would like to call upon the stage the judges, Dr. S.K. Rungta sir, Dr. Pranav Ranjan sir, Dr. Subhash Prasad sir, to chair Dr. Rajesh Tiwari sir, and to convene Dr. Abhishek Anand sir, and my co-moderator Dr. Ravi Kumar. So the first presentation is by Dr.
Get ready with the certificate यहीं पे रखा हुआ है, पेन भी चाहिए. ठीक है, जाते हैं.
So while the judges are being seated, Dr. Pankhuri Verma is requested to be ready with the presentation.
सब तो चले गए. Everyone please, presenter please collect your memento from back side there.
So we'll be starting with the first presentation by Dr. Pankhuri Verma on medial rectus fading operations with recession for partially accommodative esotropia associated with high accommodative convergence to accommodation ratio.
Medial rectus Swaden operation with recession for partially accommodative esotropia associated with high AC by A ratio. Good afternoon, everyone. I am going to present a case series of this. There was no conflicts of interest or any financial disclosures. Esotropia is partially accommodative when accommodative factors contribute to but do not account for entire deviation. Conventionally, surgical correction of non-accommodative component along with spectacle correction or bifocals for accommodative part have been advocated. However, many a times children are non-compliant to glasses, resulting in poor control of esotropia and worsening loss of stereopsis. Phalanopexy has been a promising alternative to near-eye glasses in cases with high AC by A ratio. Here we report a series of 3 children with esodavation at distance along with significant increase in esodavation for near. These children underwent MR recession with phalanopexy. Patients underwent standard ophthalmologic examination, patching was done for the amblyopic eyes, neuroimaging was done, and squint evaluation was performed pre and post-operatively at 1, 3, and 6 months. AC by A ratio was calculated using the gradient method. Stereopsis was measured using random dot stereoacuity test for both near and distance, and successful motor alignment was defined as esodavation, exodavation up to 8 prism diopter post-operatively. Using Fornek's approach, bilateral MR recession was done, taking into account deviation at distance. Posterior fixation suture was placed at least 16 mm from limbus with 5-0 polyester, and suture was fixed to the sclera on both sides. Coming to the result, all 3 patients underwent uneventful surgery. There was successful motor alignment at 1, 3, and 6 months post-operatively, both for distance as well as near. There was also improvement in stereopsis for near in 2 out of 3 cases. Coming to the case 1, a 7-year-old boy presented with visual acuity of 6 by 6 in right eye and 6 by 9 in left eye with a near distance disparity of 21 prism diopter. AC by A ratio was 6.6. The patient underwent bilateral MR recession with 6.5 mm with phalanopexy, and the post-op deviation measured at first month, it was 6 prism diopter base out for near, and for distance there was no deviation noted. The result remains same even after the 6 months follow-up. In the second case, we can see 13-year-old girl presented with visual acuity of 6 by 6 in right eye, and in left eye it was 6 by 12 with near distance disparity of 20 prism diopter. AC by A ratio was 7. Bilateral 6 mm MR recession with phalanopexy was performed. The post-op deviation at first month measured for near was 6 prism diopter base out, and for distance there was no deviation noted. At 6 months follow-up, there was no deviation noted for near, neither for distance. In the third case, 9-year-old boy with a vision of 6 by 6 in both eyes with a near distance disparity of 25 prism diopter and AC by A ratio of 8.3 underwent MR recession of 5 mm with phalanopexy. At the follow-up, it was noted there was no near or distance deviation. Out of 2 out of 3 cases, we can see the stereopsis developed at post-op 6 months of follow-up. So this is the first case where we can see the esodavation is present in the 9-gaze photograph, and it increases with the near target. In post-op, we can see the esodavation for distance had become ortho, and for near it has left to 6 prism diopter. Similarly, in case 2, we can see the esodavation is present, it increases with near target. And post-op first month, there was noted ortho position for in all the gazes. In the third case, we can see there is also similar increase in esodavation with near target, and the patient became ortho in both near and distance at 6 months follow-up. Coming to the discussion part, in Faden operation, basic muscle tone remains same as distance between muscle origin and insertion remains same. There is only weakened rotational force or torque of the rectus muscle when the eye moves in the field of action of the Faden muscle. According to Zak et al., this treatment should be recommended for patients with a near distance incompetence no greater than 14 prism diopter. However, our series had satisfactory results with near distance disparity of even 25 prism diopter. A decrease in effect of posterior fixation over time has been reported by Akkar et al. And Happe et al. However, no decrease in effect was seen in our series. So the take-home message is, Faden operation is a very effective surgical option for treating esotropia associated with a high AC by A ratio. It can be a preferred alternative in children non-compliant to glasses or bifocals in cases with high AC by A ratio. Thank you.
Very nice presentation.
Thank you, sir.
Just wanted to know, have you evaluated the refractive error of these patients too?
Yes, sir.
So these were not mentioned.
Cycloplegic refraction was performed for the patient, and the patient were prescribed spectacles for that. After that, only the surgery was performed.
And one patient had amblyopia. Was there any anti-amblyopia therapy was also started
Yes, sir.
before?
Patching was done given for the patient.
So once the vision improved to normal in both eyes, then only you went for the surgery, or?
So we waited for 2 years. If the the vision improved for the patient, then only we have performed the surgery.
What was the average age of the patient that you undertook?
So around 7 years.
7 years.
7 year, 9 year, and 10 year.
And any comparison with medial rectus recession with inferior rectus? I mean, that is also one of the options probably.
So medial rectus recession was done only for the patients.
In recession, you usually what we do is retroplacement of the origin of the insertion.
Yes, sir.
So you must understand that a proper measurement is essential. What hazards can occur if measurements are not proper?
So in post-op we can see exodeviations if we measure inaccurately, or the ESO can not be corrected. And
That we have to keep in mind.
yes, sir. Thank you.
Since medial rectus, the approach is very difficult in medial rectus side. So if had done at distance of 16 millimeter would have been very difficult. So was there any difficulty or surgery that could be actually abandoned because of that in any of the patient? No.
No, so in all 3 cases we have done it. And modified Faden has also we can use in newer cases. We are planning to do that.
Okay, thank you.
Thank you, sir.
So the next presentation is by Dr. Sheel Meshram to demonstrate centration and stability of the capsular bag in case of traumatic lens subluxation with great extent of zonulolysis using fixated capsular tension devices.
Good afternoon, everyone. I'll be presenting the rings and hooks managing subluxated traumatic cataract. There is no conflict of interest and no financial disclosure. Purpose is to demonstrate centration and stability of the capsular bag in case of traumatic lens subluxation with greater extent of zonulolysis using fixated capsular tension devices. Subluxation is partial displacement of lens from the patellar fossa. It could be congenital or acquired, as in case of trauma. Management depends upon the amount of subluxation. If it is less than 3 clock hours, placing a PMMA IOL or CTR is enough. It is 3 to 6 clock hours, then CTR or a modified CTR with a single loop should be done. If it is more than 6 to 9 clock hours, then a modified CTR with double loops or a CTR with CTS can be used. In more than 9 clock hours, cataract extraction with SFIOL or a ACIOL can be done at the same or at different settings. Presenting case of a 9-year-old male child resident of Bhojpur, Bihar, who came with diminution of vision in left eye and whitish reflex in left eye since 1 year. Patient was apparently all right 1 year back when he developed diminution of vision in left eye following trauma with firecracker, which was sudden in onset and gradually progressive, associated with whitish reflex from same eye. Also experienced lid edema, redness, watering, pain initially following trauma, which subsequently subsided. There was no history of deviation, limitation of eye movements, and floaters and flashes of light. Past history was not significant, family history was not significant, personal history was normal, general physical examination was within normal limit. Ocular examination of the left eye, there was the visual acuity of hand movements close to face and PR accurate in all quadrants. IOP was 17 mmHg. The rest anterior segment findings were within normal limit. The iris showed sphincter tear at 8 o'clock position with wide gap and irregular mid-dilated sluggish reacting pupil, cataractus lens with 7 clock hours of temporal subluxation from 1 to 6 clock hour position. The fundus was within normal limit and the right eye findings were within normal limit. This is the image of the left eye showing sphincter tear at 8 o'clock position with wide gap and cataractus lens with 7 clock hours of temporal subluxation. Case summary: a 9-year-old male presented with diminution of vision and white reflex in left eye with history of trauma to left eye with firecracker. Examination, there was hand movements close to face with PR accurate in left eye and iris sphincter tear at 8 o'clock position and cataractus lens with temporal subluxation of 7 clock hours. The diagnosis was left eye traumatic cataract with temporal lens subluxation from 1 to 6 clock hours with iris sphincter tear at 8 o'clock position. The investigations were within normal limits. Management plan was left eye phacoaspiration plus PCIL implantation with capsular tension ring and capsular tension segments. Here's a small video. AC entry was done. The capsule was dyed. Capsular access was done in controlled manner. The capsular hooks were applied to stabilize the capsule. The CTR was placed to centralize the capsular bag. A scleral pocket is made and a capsular tension segment Eyelet is threaded with 10-0 straight needle proline suture. It is inserted in the capsular bag. And using a 26 gauge needle as a guide, it is threaded or externalized out into the sclera and sutured. Post-operative finding: on post-op day 1, the vision was hand movement close to face. We can appreciate that the bag is centered, and we can see the eyelets of the capsular tension segment, and the capsular tension ring is also visible, and the PCIL is in the bag. Follow-up at 3 weeks showed visual acuity of 6/6. There was a PC plaque present. The bag was well centered. The anterior capsular excess margin can be appreciated. CTR can be seen, and the eyelets of the CTS can be appreciated. PCIL is in the bag. Discussion: in case of traumatic lens subluxation, there may be also other issues like rise in IOP and iridodialysis and traumatic mydriasis which need to be considered. CTRs have been successfully used in traumatic cataract with less than 6 clock hours of zoniolysis. Fixated capsular tension devices like Sionis ring with eyelets and CTS with eyelet can be required when there is a larger extent of zoniolysis. In case with severe zonular weakness, capsular tension segment does not expand the bag, as well as capsular tension ring alone cannot center the bag. This can be overcome by using a combination of capsular tension segment with capsular tension ring. While the surgery is technically challenging and time consuming with a steeper learning curve, the bag can be successfully preserved in severely subluxated traumatic cataract with the aid of fixated capsular tension devices. Thank you.
Very nice case, very nicely dealt. I mean, just one question. When do you put the CTR? Capsular tension ring.
Sir, it can be put before doing phacoemulsification, because in that case there is a less risk of bag dislocation, and in some people also prefer it placing after doing phacoemulsification or after removing the cataract. In that case, a better removal of the complete lens material is assured.
I think the general concept is you can put the CTR once you make the
after capsular excess is done.
After that, any stage which is convenient, you can put the CTR. And second question is, can one put the CTS before the CTR for such cases?
So there is more chances of torque in these cases if we go first for a capsular tension segment.
I think the CTS, the capsular tension ring has to
Ring
be
has to be placed first and then the segment.
You inflate the bag and then only you put in the CTR so that you can pull the bag towards the intended side.
I would have expected from you to talk something about whether you checked any vitreous is there in the anterior chamber or not. So did you check?
Sir, vitreous was not in the anterior chamber.
That was not so, or in every cases of like this, it should be checked with triamcinolone,
Yes,
strychnine.
sir.
That is very important.
Sir, it was not there.
How many cases you observed putting CTR?
Sir, in our institute Sir, in our institute I have seen 4 to 5 cases. Sir.
So what opinion you made? Dr. Pranav, I asked you the question, when to put, in your opinion, what is your opinion?
Sir, would prefer it placing before cataract extraction. Thank you, sir.
Next presentation is by Dr. Deepak Patel on surgical results of manual small incision cataract surgery performed by residents, a time trend analysis in DMCH from 2022 to 2024.
Good afternoon, everyone. My paper topic is a time trend analysis of surgical results of manual SICS performed by junior residents in DMCH. There is no any financial interest. The aim and objective of this study is to report the surgical results of manual SICS performed by residents in DMCH. This study collected surgical results prospectively registered of 1410 consecutive cases of manual SICS performed by 24 resident ophthalmologists under supervision from February 2022 to February 2024 at DMCH hospital. This 2-year period was divided into 4 equal intervals for a time trend analysis with 6 months in each interval. In this study, 824 cases, that is 58.43%, were performed by third-year junior residents, 540 cases performed by second year residents and 46 cases were performed by first year residents, although the first year junior residents generally receive part or step-by-step training. The criteria for the supervisors to take over included 3 failed attempts of any maneuver, anterior capsulorhexis extending to the iris, repeated iris prolapse or at residents or attendings discretion. As long as no major complication occurred during the surgical process, the resident would complete the entire operation. The intraoperative complications, if occurred, and any of the following 4 outcomes, namely A, incomplete surgery due to supervisor's interference and without complication, B, incomplete surgery with either major or minor complications, C, complete surgery with minor complications, and D, complete surgery without complications were recorded. The completion rate is calculated as the number of cases with C plus D and divided by the total number of cases, and the complication rate equals the number of cases with B plus C outcomes divided by the total number of cases. The complications that occur when the supervisor performed the surgical process were excluded from the resident's complication rate. The group differences were determined using chi-square test, and a p-value of 0.05 denoted statistical significance. Coming to the results, of the 1410 surgery, residents independently completed 952 cases, that is 67.51%. Of the remaining 458 incomplete cases, residents encountered a major complications leading to discontinuation of the surgery in 204 cases. The 40 cases were complicated with vitreous loss, representing an overall rate of 2.8%. In the 204 cases, 279 complication events occurred. The categories of complication events included like anterior capsulorhexis extension, vitreous loss, iris damage or prolapse, posterior capsule tear without vitreous loss, and others. The completion rate gradually increased from in first interval to the final interval, and the complication rate similarly gradually decreased from first interval to the final interval. The table shows the time trend of completion and complication rates. We can here see that the completion rate gradually increased from 44.70% to the 81.80% in the final interval, and the complication rate gradually decreased by 27.4% to 7.30%. This table shows the time trend of complication in different steps of manual SICS. In here, the most common complication done by junior residents were during anterior capsulorhexis and irrigation and aspiration of the cortex, which also gradually decreases along the time interval. Coming to the discussion, the cataract surgery is the most performed operation in ophthalmology, and manual SICS is a key technique learned by residents. However, it is challenging for both trainers and trainees due to its distinct property of a small error margin and patients' high expectation of immediate visual recovery. The surgical results of resident performed MSICS show wide variation due to numerous variables such as amount of practice and prior experience. Although some creative and innovative methods such as practicing in the wet lab and properly assessing surgical competency in the training programs have been suggested to help trainee surgeons overcome their barrier steps. The 2 most difficult steps reported by basic trainees were anterior capsulorhexis and the removal of the cortex, which also had the highest complication rates despite the highest rate of supervisors' assistance. In a patient-based practice, most supervisors try their best to avoid a high complication rate of the trainee surgeon and may take over the barrier step, especially for residents who are struggling before the inflection point of their learning process. Arranging junior residents to perform more surgeries of capsulorhexis and to practice in a wet lab is helpful for overcoming this problem. The key strength of this study include the large number of patients and residents involved, prospective records with well-defined criteria, and elimination of the inter-trainer bias when assessing institutional surgical training results. The outcome is encouraging, but such progress is multifactorial. Our limitation lies in the difficulty to tell exactly which factors are more important. Further studies are necessary to clarify these issues. The conclusion is our results demonstrate that it is possible to reach a goal of both higher completion. Thank you. These are my references. Thank you.
Very good compilation of the data. I think that you should have also included the time frame, the time taken by the resident in the first and third and second, third. That would also say that how confident the residents has become. Another thing is the post-op complications. Some of the post-op complication has to be taken into account like corneal, the corneal edema, the amount of the handling, the tissue handling which reflects in a way that more patient will develop corneal edema. So post-op, these two factors are also very important as far as training is concerned.
Yes, sir.
Number one, you put in too many words in your slides. I mean, if they were very cramped up. So you need to reduce the number of words that you use in every slide, right, for a presentation. Secondly, do you have any training schedule for SICS or a cataract? Like the first year residents, they are given only the incision part for 1 week, 2 weeks, and then step by step. I mean, any.
Yes, sir. In our institute, the first year residents get their training by step. Firstly, they have given for first bradal suture for at least 4 to 6 cases, and then to incision and tunnel formation.
I mean, that is one way by which one can learn and one can reduce the complication rate as well.
Yes, sir. Yes.
What is the post-operative protocol there? When you put the bandage also?
Yes, sir.
In SICS cases?
Yes, sir.
So when do you take out the bandage, and what is the post-operative protocol? What do you see?
Sir, we remove the bandage and do dressing on the post-op day 1, and after checking on a slit lamp, if there are any complications are there, then we observe for one more days. Otherwise, we discharge the patients and followed up after 5 days and then respective 15 days.
Whenever complication is there, some supervisor is there.
Yes, sir. Yes. Thank you, sir.
The next presentation is by Dr. Rajiv Kumar Singh on multimodal imaging for diagnosing pigmented retinal lesions to rule out choroidal melanoma.
Good afternoon, judges and everyone sitting here. I, Dr. Rajiv, junior resident at RIO, going to present on a topic of multimodal imaging for diagnosing a pigmented retinal lesion and ruling out the choroidal melanoma. There is no conflict of interest or financial interest regarding to my presentation. 77-year female presented to our institute with a complaint of painless blurring of vision. She was apparently all right, and on our subsequent examination, she has a bilateral senile cataract along with a pigmented retinal lesion which was noticed incidentally, and she was referred for the same. And there was no significant past ocular history, and in past medical history she was hypertensive under treatment, and there was no medical or surgical illness. There was no history of hypertension, diabetes, and ocular malignancy in her family. Has a normal vegetarian diet and normal bowel and bladder. On general examination, she was only having a pallor. Rest of the examination was within normal limit. There was no significant history of weight loss, appetite, or bony pain. There was no palpable periocular lymph nodes. Both eye visual acuity was found 624 and 636. Rest of the anterior segment findings was within normal limit, and only she has a NS3 cataract in the both eye. This is the anterior segment picture of both eye having a cataract, significant. This is the posterior segment image of both eyes. In the right eye, there is a well-defined mass of which appears clinically flat and hyperpigmented with well-defined of around 8 to 9 disc diameter, of color of yellow with some yellow to white hypopigmented spots. The overlying blood vessels was clear, and rest of the periphery was tessellated with no evidence of subretinal fluid around the region. So based on the above clinical findings, we suspect the case is of choroidal nevi, but keeping the other differential of choroidal melanoma, hemangioma, metastasis, and neovascular AMD was kept and further investigated. In order to support my diagnosis, we investigated the patient. B scan was performed, which shows a slightly flat elevated hypoechoic lesion with apical dimension of 1.82 with basal dimension of 5 mm noted, with no evidence of acoustic hollowness or choroidal excavation. This further supports my diagnosis. Additional fundus autofluorescence was done, which shows a small area of the autofluorescence pattern was also present. Through the lesion, there swept source OCT was also performed to document the evidence of if there was a presence of subretinal fluid. There was no evidence of subretinal fluid, and there was only a sagginess of photoreceptors with RPE atrophy in the some of the part of the scan. Other eye OCT scan was within normal limit. FFA was also performed to rule out the double circulation, which is a typical finding in the choroidal melanoma, but though no double circulation was evident in any phase of the FFA. So based on the above findings, we came to a definitive diagnosis of a right eye pigmented choroidal nevi. Patient was assured for the benign nature of the lesion and informed for the malignant conversion, but it is very slowly. So we counseled the patient and call her for 6 monthly follow-up. Coming to the discussion, mnemonic was given by the Carol Shields to find in our case we find only apical thickness which are around 1.8 mm. There was absence of subretinal fluid. There was diminution of vision, which could be probable due to cataract. There was absence of orange pigment, that is the lipofuscin. And the lesion was present to the optic disc, which was around 3 mm. But there was absence of ultrasound hollowness and acoustic hollowness, halo around the lesion. Drusen was present, which shows the chronicity of the lesion. And so further, the patient was asked for follow-up, and based on the risk factors, there was a we counseled the patient that could be a chance of conversion, and photograph and rest OCT and these were added to the for further examination. So concluding my case, such kind of pigmented retinal nevi should be examined with a thorough investigation, multimodal imaging to document potentially fatal choroidal melanoma. Thank you.
What is the incidence of conversion of nevus to a malignant melanoma?
So, in the younger patient,
so what do you advise when follow up?
Yes.
What kind of a protocol one has to follow?
So, based on the risk factors like apical thickness on B scan and subretinal fluid and the presence of lipofuscin pigmentation, orange pigmentation, if these are present, there is a high likely to be conversion of, even in the case of atypical nevi, if these are present, there is a high chance of conversion. In the age group of more than 60 years, if there is a 0.1 mm increase in the size, then their likelihood of conversion is 19%.
1 mm increase in how many months?
So
how many years?
1 years.
Looking at the case, there is hardly any doubt that there would be just differential diagnosis of nevi and the melanoma.
Yeah.
But what other things you thought that it could be some, let us differentiate with the other things also, like hemangioma, this CNBM.
Yeah.
So clinically it looked like only two things which has to be differentiated. Anyway, good presentation.
What investigation you did? It is, I think, B-scan, OCT, FFA, and color fundus photograph.
Yeah.
Anything more?
So extra investigation, if there is a more doubt of, we can go for a MRI for extracellular scleral extension to look for.
Thank you.
Next is Dr. Ashmita Adhikari. She will be talking on tackling increasing ocular firecracker injuries during the peak seasons.
Good afternoon, respected judges and all audience members. I am Dr. Ashmita from RIO IJMS. My topic of presentation is tackling increasing firecracker injuries during peak seasons. I have no financial or conflict of interest. Peak seasons of festivals and weddings pose a risk to vulnerable populations. Festivals like Diwali and Chhath in Bihar to children and innocent bystanders. Weddings, especially during Bharat or the procession, to young adults and experimenters. Specifically during unsafe practices like lighting firecrackers in crowded areas on roads with running vehicles and allowing children to handle them without supervision. Purpose is to assess the incidence pattern and severity of ocular injuries sustained by firecrackers. It is a prospective observational study over 2 months, that is October to November 2023. Center is IGIMS Patna. It is a tertiary hospital-based single center study. Departmental ethical clearance was taken prior to study. All patients presenting to RIO, OPD and emergency with firecracker injury were enrolled and consent taken. It was ensured patients' vitals were stable and they were oriented to time, place and person, and active bleeding, if any, was attended to first. Then history, vision and IOP were recorded and visual prognosis was explained after thorough slit lamp examination whether there was any need for active intervention. Consent for inclusion in this study was taken. All patients, regardless of age, presenting to RIO, emergency and OPD within the time period as mentioned with history of firecracker injury were included, and excluded were patients unwilling for examination, intervention and refusing consent for inclusion in the study. Data of 22 cases of firecracker injury were recorded. By majority, 11 were children, 8 were young adults less than 30 years and 3 were middle-aged between 35 to 45 years. By sex ratio, 17 were male and 5 were female. Children were mainly innocent onlookers, adults were experimenters. Most common firecracker injury were missiles or rockets, which is the combination of chemical and projectile injury. Total 12 closed globe and 10 open globe injuries, and laterality were 13 right eye and 9 left eye injuries. Closed globe injuries were treated mostly conservatively, and open globe injuries repaired by primary or secondary repair. The data represented, firstly, according to age groups and sex. Firstly, most commonly affected were males as compared to females in the 6 to 10, 16 to 20, 21 to 25 age groups. Closed versus open globe injuries. In closed globe injuries, these were the injuries seen. Most commonly, traumatic subluxation of cataractus lens and traumatic hyphema, and open globe injuries, globe rupture, 4 cases, that is 45%, where the globe was unsalvageable. And vision at presentation mostly was PL positive and PR inaccurate. And vision at the time of presentation, most had presented within 12 hours. One had presented within 2 hours itself, and one had presented post 24 hours. The time of presentation also determines the visual outcome post intervention. Post-intervention, most had, however, progressed to PL negative status, that is 5 patients, and the rest had 6 by 36, 6 by 6 by 60 and 6 by 18, etc. The injuries encountered include a burn injury at the medial canthus in a child, lid abrasion in the left eye with periorbital edema, corneal abrasions, traumatic hyphema with subconjunctival hemorrhage, traumatic iododialysis, traumatic cataract with AC prolapse and zonular dehiscence, traumatic cataract with posterior subluxation where IOL drop with secondary rise in IOP due to vitreous prolapse, open globe injuries which were salvageable by primary repair, and closed globe injuries which post repair were not salvageable. Retained IOFB included firstly first case of a wooden piece removed from the eye and the second case of a glass shard removed from in front of the retina by VR surgery. In conclusion, firstly collaboration between government healthcare providers and community with stricter laws and ensuring regulations, that is restricting burning firecrackers between 8 to 10 p.m. And this is the study and these are my references. Thank you.
Thank you. Of late, I think that the number of injuries with the firecracker has definitely has gone down due to some increase in awareness and less use of firecrackers. You told that you measured the intraocular pressure also. So did you do in open glove injury also?
So it was measured digitally.
In open glove injury?
So what?
In open globe injury you did with the digital method. You measured the pressure. What was the need of? Any kind of any pressure would further increase the injury. The aim of the management in any open glove injury is to prevent the glove from further injury. So if you press by the finger anything, if you take the pressure, then it is further going to. So I would say that it's not, it should not be done. Anyway, it should not be done. I think that you must not have done that too, but you just mentioned it. And which patient actually, what was the how could you come to the conclusion that which patient actually had a better outcome? Those presenting with the better initial visual acuity had some bearing with the final outcome, or?
So those, for example, those with hyphema, with maintained IOP, where it could be managed conservatively with steroids and antibiotics, oral and topical, and it was cleared within 1 to 2 months. And secondly, those with traumatic cataract, where posterior segment was clear and within normal limit, was managed with operation and removal and secondary IOL implantation.
Did you have any time limit for open globe injury like a corneal rupture and all? How much time did you take to repair that? How fast was it done?
Some blood investigations were done, and as soon as they were available, the reports, they were taken for surgery.
So I think for an emergency condition, you have to do the primary repair immediately and then subject for other blood reports and all. Because once the corneal edema sets in, the corneal repair becomes very difficult. So if you get a case of traumatic corneal rupture, whatever, you have to do it almost immediately. I mean, that is one thing which I have learned from my experience and also from the books. I think, Subhas, what do you say about that? Primary.
In your title, you mentioned peak seasons. What do you mean by this?
So in India, it is during festivals and wedding seasons.
And also cricket in lighter vein?
Yes, sir.
One comment on this, that the incidence of injury, especially during festival time, has drastically gone down. In the last couple of 15 years. 15 years back, it used to be really.
So there was the law passed in 2017 for restricting firecrackers between 8 to 10 p.m. and to use green firecrackers in place of explosive firecrackers.
The legal factors, other things, they have really played a role. Thank you so much.
Next is to present Dr. Veronica Agarwal on ocular surface disease, why it is crucial to evaluate for dry eye disease before cataract surgery. Good afternoon, everyone. I am Dr. Veronica Agarwal from DMCH. My topic is ocular surface disease, why it is crucial to evaluate for dry eye disease before cataract surgery. There is no conflict of interest, no financial interest. Introduction. Cataract surgery is one of the most frequently performed ophthalmic surgeries. Recent developments have made the outcomes of cataract surgery almost predictable and replicable in restoring emmetropic status. It is not unusual for DED to coexist with cataract, as both conditions are commonly associated with aging.
In many previous studies, we have observed that cataract surgery can lead to the development of DED in a normal eye. It is obvious that it can also exacerbate pre-existing DED. Here in this study, we aim to explore the importance of evaluating dry eye before cataract surgery. My study is a prospective study in which 90 patients who are willing for senile cataract surgery were included in IOPD DMCH from April 2023 to June 2023. 90 patients attending the IOPD at DMCH who were willing to undergo senile cataract surgery were taken. During pre-operative evaluation, in addition to other routine tests, patients were assessed for dry eye disease. An ocular surface index questionnaire was used to quantify symptoms along with Summers 1 and T-BUT test. All the patients having OSDI scores more than 12 and Summers value and T-BUT values less than 10 seconds are considered DED patients. This OSDI score more than 12 and Summers test. Results. Out of 90 patients, 48 males and 42 females were analyzed. Of this, 54 patients had all these tests considered positive. 16 patients showed pathological values of OSDI score, but normal values of Summers and T-BUT. The remaining 20 patients had normal values of all this. DED is often underestimated in the cataract surgery population because patient can be asymptomatic but still show evidence of clinical significant DED during clinical testing. Cataract and OSD symptoms often overlap. Cataract patients who experience intermittent blurriness, burning sensation, stinging, or other vision fluctuation throughout the day may mistakenly attribute these symptoms to their cataract, when in fact the underlying issue is often untreated OSD. Preoperative assessment for DED is crucial for better outcomes. A pre-existing DED impacting the tear film is likely to influence biometry. Both eye conditions become more common with age. Our study suggests that nearly 60% of patients with cataract also have dry eye disease. Cataract surgery can also lead to a flare-up of dry eye. The incision made during the surgery can upset the balance of tear film and ocular surface homeostasis. Eye drops often used before and after the surgery may contain preservatives that can irritate the ocular surface. Exposure to irrigation, drying, and light from the operative microscope during surgery can cause damage to the conjunctival and corneal surface, worsening dry eye symptoms. Even if dry eye or OSD is mild before surgery, worsening symptoms can last for several months afterward, negatively affecting vision. Conclusion. In our research, we discovered that almost 60% of patients who underwent cataract surgery were diagnosed with dry eye disease. It is crucial to educate people about DED and its consequences after cataract surgery. If left untreated, it can result in patient dissatisfaction despite better visual outcomes because surgery can exacerbate symptoms. Although managing DED firstly can cause some delay in cataract surgery, it will surely give better outcomes and happy faces post-cataract surgery. My take-home message is never hesitate to delay surgery until the ocular surface is optimized. These are my references. Thank you.
Was it analyzed in different subgroups like male, female, age-wise? Any patient having any systemic collagen vascular disease kind of thing? So
no, sir. This all were excluded. Collagen vascular disease and Sjogren.
But male, female, and age
No,
has
sir.
some bearing also.
Yes, sir. I don't include this in my criteria.
The tests that were done were only Sharma's test and the TUBT.
And
like
sir,
based
OSDI questionnaire were also
Questionnaire.
used. Yes, sir. OSDI questionnaire. Thank you, sir.
Next to present is Dr. Swati Singh on a case report on microsporidial keratitis.
Good evening, everyone. I'm Dr. Swati Singh, JR from NMMC Gaya, to report a rare case of microsporial keratitis. Rare cases are always interesting, aren't they? So let me begin. A 32-year-old lady from a nearby village came to our OPD with complaints of pain, watering, redness, photophobia, foreign body sensation in her right eye for past 7 days. In the negative history, there was no history of similar complaints in the other eye, no previous history of trauma or foreign body contact, no history of contact lens wear, no history of previous cornea or ocular surgeries in the past, no history of diabetes or hypertension or any other systemic disease. Personal history and family history was non-significant. Medical history, she went elsewhere and was treated with a cyclovir 3% eye ointment, but there was no relief to it. Perplexed, I digged further into the history And I found out that she had a history of contact with pond water 7 days ago, post which she developed these symptoms. So on my clinical examination, I found general examination was within normal limits, local examination, visual acuity was 618 partial in the right eye, eyelids and lacrimal drainage was normal in both the eyes, conjunctiva showed mild congestion, cornea showed multiple superficial punctate epithelial lesions seen under SLBM, fluorescence staining was positive, they appeared stuck onto the cornea. There were no KPs, however, corneal sensitivity was intact in both the eyes. Antechamber was quiet, and iris, pupil, and rest of the parameters were normal. This is a picture depicting the diffuse illumination on the left side, and on the right side we have, under the blue filter, the fluorescence-stained raised epithelial lesions stuck onto the cornea. So my differentials based upon this were adenoviral keratoconjunctivitis, which is very common in the monsoon season, as well as it is common in epidemic in Gaya. Then Thigerson superficial punctate keratitis, microsporidial keratoconjunctivitis, a rare entity, and dry ISP case. Based upon my history and clinical picture, I thought and suspected maybe it is a superficial punctate keratitis due to microsporidial infection. I went ahead with the investigation. Routine investigations were normal, the immune status was normal, corneal scraping of 1 to 2 epithelial lesions was done, and I found that they came out in toto, and there were clear corneal pits that was found. The epithelial lesions were sent for gram staining, showed gram positivity later on. Cultures, however, showed no growth. I followed up with a treatment that is antifungals, topically fluoroquinolone, cyclopyrrolidoxy for the pain, and lubricants were given. On the follow-up visit after a week, I found the patient was very happy because there was symptomatic reduction, reduced conjunctival congestion, and resolution of the epithelial lesions on the slit lamp. So this brings us to a very important question, that is, how many of us have encountered a case of microsporidial keratitis in our clinical practice? I guess not so many. The reason being it's very rare, and more than the rare, it is also missed out. This map shows the incidence of ocular microsporidiosis is 0.4% of infective microbial keratitis. Let me brief you about the causative agent, that is microsporidia. It is an obligate intracellular parasite, hence difficult to culture, known to cause collapse of silk industry in France in 1857, known as pebrine disease. And association has been found in immunocompromised patients, especially HIV and organ transplants. Ocular microsporidiosis is the second most common manifestation. Person-to-person transmission has not been reported. Direct inoculation of the spores onto the cornea is the most possible route, and the common implicated risk factor is contact with a contaminated water source. Ocular microsporidiosis, it can occur in two forms. The first being the epithelial forms, the characteristic raised epithelial lesion showing stuck-on appearance, whereas the second picture showing stromal edema and stromal infiltrate and stromal keratitis. This table depicts what are the differences. The epithelial form and the stromal can mimic Thigerson SPK's mycobacterial keratitis, whereas the stromal can mimic fungal bacterial HSV stromal keratitis, which is rather severe but rare condition, and hence it is misdiagnosed often. The other diagnostic modalities could be, apart from the lab microscopy, we could do PCR in vivo confocal microscopy limited to higher centers, ASOCT. The treatment options are self-limiting in case of MKC. It is most often treated with the antifungal antiprotozoal or topical antibiotics. Apart from that, stromal usually has a devastating course and requires early keratoplasty. The prognosis is guarded in case of MSK. This picture shows the lab microscopy pictures, rice grain or starry sky appearance under the fluorescent microscopy in the first picture, the gram positivity of the spores, and the ZN staining showing the acid fastness. ASOCT shows multiple hyperreflective areas which are raised in case of the first. So the dilemma we have here, the clinical history, increased awareness, diagnostic modalities, and an MDM approach with microbiologists and pathologists is what we need to do. There are so many mimics over here, and hence what we need to do is that if a case of multifocal a diffuse epithelial keratitis or a chronic non-refractory, chronic culture negative refractory stromal keratitis comes to our OPD, we must think of microsporidial keratitis, keeping it in our DDs so that it does not get missed and it does not get misdiagnosed. Thank you so much.
I must appreciate your slides. It was very much visible and few lines written, and it was very attractive too. But you must learn to respect the time also.
Yes, sir.
The case you presented is a very common entity. Actually, we get confused many times. Like in this case of in this era, for last few months back, we had series of adenovirus conjunctivitis. Some of them looked like this. So definitely there is a diagnostic challenges. But in any case, we give antibiotics, fluoroquinolone and lubricants. Many times it improves. So there could be hidden cases of microsporidia. Actually, this is.
Yes, it gets missed out a lot because it also has a self-resolving nature. So even with the lubricants, it does resolve on its own sometimes.
The literatures, they have written that even on lubricating eye drops,
Yes, sir.
it
Yes,
gets
yes, sir.
killed.
Studies from LVPI has shown that just on the lubrication and epithelial debridement, it could be taken care of.
Besides fluoroquinolone, what else you used in this case? Anything systemic, albendazole or something?
Not systemic, sir. Only topical antifungal.
Topical
Fluconazole, yes, sir. With that, it resolved.
that gave the response.
Yes, sir. Because those were only superficial lesions.
And how did you establish that it is microsporidia?
So my diagnosis was mainly clinical based on the slit lamp picture, and also because she had a retrospective history of contact with the pond water, so I came to the diagnosis. Apart from that, the other DDs that I was thinking of, like viral conjunctivitis, due to the unilaterality nature of it, and also the gram positivity showed. I asked the microbiologist to further look particularly for the spores of microsporidia into the gram staining. We did not have calcofluor white or the fluorescent microscope at center, so we could not go for that sensitive
so
test.
you can level it as a suspected microsporidic cases.
Yes, sir.
You cannot say that it is established case of.
I agree.
But clinically, the Stockton is very
Clinically,
important.
it was-
Stockton look appearance.
The look was very much evident, sir.
Can we have the next speaker?
Thank you, sir.
Next, I request Dr. Amit Kumar to come up to present his topic, bilateral progressive anterior and posterior lenticonus, its significance and management with toric IOL.
Good afternoon, respected judges, all audience members. I am Dr. Amit, third year resident from RIO IGMS. I am going to present a case of bilateral progressive anterior and posterior lenticonus, its significance and management. I have no financial disclosures or a conflict of interest. My patient is an 18-year-old female, unmarried student, resident of Gaya, Bihar. She presented with complaint of bilateral painless, gradually progressive diminution of vision since last 1 year, which was not improving with glasses. She was on glasses for the last 6 years, but was not improving currently. She had no history of trauma or any significant past medical or surgical history, neither any family history of similar complaints. All systemic examinations were within normal limits on clinical examination. On local examination, the head posture was erect and facial symmetry maintained, and periocular area was within normal limits. On ocular examination, the uncorrected visual acuity was 660 in both eyes, which improved to 636 in the right eye and 618 in left eye with pinhole. And best corrected visual acuity was 624 in both eyes. The NCT was 16 and 15 respectively in right and left eye. The lid were normal in both eyes. The movement were full and free in all gauges. The conjunctiva, cornea, antechamber were all normal, had normal findings. And the pupil was normally reacting to light. But the lens was clear on slit lamp examination with anterior and posterior lenticonus and showing all droplet sign in retroillumination. Here's the image showing all droplet sign in the right and left eye respectively. And below image showing anterior and posterior lenticonus. The posterior segment was within normal limits, and on retinoscopic evaluation, scissoring reflex was noted in both eye. This was supported by UBM and the topographic examination showing lenticonus. So on the basis of this clinical examination and investigations done, the diagnosis of a bilateral anterior and posterior lenticonus was made, and the patient was further consulted in ENT and nephrology department. On ENT examination, the audiometry showed bilateral sensorineural hearing loss, and on a urine examination ordered by nephrology consultation, it shows 2+ proteinuria and increased urine protein creatinine ratio suggestive of nephritis. So on the basis of these three findings, nephritis, sensorineural hearing loss, and lenticonus, the diagnosis of Alport syndrome was made. The patient was planned for clear lens extraction with phacoemulsification with foldable toric IOL implantation in both eye. This is the table showing toric aspheric IOL calculation data. The post-operative period was uneventful, and the other eye was operated the same procedure 8 weeks later, and the best corrected visual acuity improved to 6/6 with small myopia correction in both eyes. Coming to discussion, the Alport syndrome is a rare basement membrane disorder with defective type 4 collagen. It is characterized by a progressive hereditary nephritis, sensory neural hearing loss, and ocular abnormalities. It has predominantly X-linked inheritance, 85%, and overall prognosis is generally favorable in these cases. Close long-term monitoring is essential to manage the refractive changes and to address the potential development of cataracts which can happen in these cases. The early diagnosis can aid in retarding progression of nephritis in patients presenting with ocular symptoms first, and clear lens phaco emulsification is considered to be an excellent surgical procedure for the treatment of anterior lenticonus in Alport syndrome, allowing for rapid visual rehabilitation. However, such cases are associated with various surgical challenges also, and several considerations has to be made. Increased elasticity of the lens capsule is seen in these cases, and the risk of spontaneous rupture of capsule is also well documented. The AC is relatively shallow in these cases due to anterior lenticonus, and there is also high risk of PCR when it is associated with posterior lenticonus. So general anesthesia is worth considering as the process is longer and echinacea is more important, and high molecular weight viscoelastic agent helps a lot in deepening the anterior chamber and flattening the anterior capsule. Hydrodissection is usually avoided if there is associated posterior lenticonus or posterior subcapsular cataract, as in this case. Good hydrodilation is done to ensure easy locus rotation, and the lens cortex is aspirated, should be done in a circumferential fashion in order to avoid tension on the zonules. So coming to conclusion and takeaways, I like to highlight the importance of comprehensive management approach, as these cases may require multidisciplinary approach in different departments, and also emphasis should be given on early intervention which can prevent further complications. The course of disease changes, therefore continuous monitoring and adaptability is important, and overall patient-centered care is the best approach. These are my references, and thank you.
Just one query. I mean, did you do a routine phacoemulsification for these cases, or will you recommend a flax for these conditions? Because anterior lenticonus, what you said, has a high tendency of the rexus going haywire.
Yes, sir. Sir, in these cases, there is a variable kind of the anterior capsule is seen tough in some cases and also seen to be elastic in some cases.
Because that is the only issue. Once you get a rexus done,
yes, sir.
After that, the entire surgery is basically very easy to do.
Yes, sir. But sir, the variable nature of the capsule, sir.
And what was the instrument that you used for doing the rexus? Was it a cystitome or a rexus forceps?
The cystitome, sir. It was done, and
So
later it was completed with forceps.
Cystitome does not have that much of control in comparison to
it was completed
the
with
rexus
again.
forceps.
Yes, sir. And the
So
rexus,
if you have a high risk of the rexus going haywire,
yes, sir.
why not use the rexus forceps right from the beginning? I mean, that is. This is my personal experience that the rexus, if it is done even in a normal case with a rexus forceps,
yes,
you are bound to complete in almost 99.9% of the cases.
Yes, sir. Actually,
It's individual choice, sir. The person who is confident with even 26 gauge cystitome can do that.
But this particular condition, what do you suggest?
I don't find it would be so difficult when we are, any competent surgeon can manage all these cases.
thank you, sir.
Next, I request Dr. Supriya Sharma to come up and present her topic.
Good afternoon, everyone. I'll be presenting prospective observational study to compare manifest astigmatism following OCCI with monofocal IOL and monofocal toric IOL with the steep axis corneal incision in patients with 1 to 2 diopter of total keratometric astigmatism undergoing phacoemulsification. There are no conflicts of interest to disclose. Astigmatism accounts for approximately 13% of all the refractive errors, and of all the patients undergoing cataract surgery, about 57% patients have more than 1 diopter of astigmatism, 20% patients have about 1.5 diopter of astigmatism, while the uncorrected astigmatism of more than 0.75 diopter can cause suboptimal visual outcome due to blurring of vision, ghosting of images, or halos. So various approaches have been advocated for tackling the pre-existing astigmatism, which includes giving peripheral cornea relaxing incisions, toric IOL implantation, and bioptics, which is done with the help of excimer laser. Primary objective of the study was to compare post-operative manifest astigmatism at the end of 3 months between the OCCI group and the monofocal toric IOL group. Secondary objective was to measure and compare changes in total keratometric astigmatism, uncorrected and best corrected visual acuity, preoperatively and at 3 months post-operatively in the two groups. It is a hospital-based prospective observational study, and patients who reported to our OPD with cataract and preoperative total keratometric astigmatism in the range of 1 to 2 diopter and decided to undergo phacoemulsification by the same surgeon on the same phacoemulsification machine at this center were included in the study, and subsequently 2 groups were studied. In group A, monofocal IOL was implanted with single incision of 2.8 mm on steep axis of total keratometric value, and a clear cornea incision was given diametrically opposite to the steep axis incision. In group B, toric IOL was implanted through steep axis cornea incision of 2.2 mm, and IOL was aligned using Callisto markerless alignment. Sampling was done taking study by Mandicut et al. As baseline, and a sample size of 30 for each group was achieved for declaring that the test method, that is OCCI, is equal to active control method, that is toric IOL. This is a flow chart showing how we included and excluded patient at subsequent follow-up visits to conclude our study. Post-operative data on uncorrected visual acuity, best corrected visual acuity, manifest and total keratometric astigmatism along with toric IOL alignment was measured at day 1, at 6 weeks, and at 3 months of follow-up. Study period ran for 15 months from June 2022 to September 2023, and analysis of data was done using Jamovi software. This is the result showing cylindrical component of manifest astigmatism was corrected to a greater extent and significantly in group B than in group A. As can be seen at the end of 3 months, the mean correction at the end of 3 months was more in group B, as the magnitude of manifest astigmatism was less, and it was quite significant. While the mean change in total keratometric astigmatism at the end of 3 months was significant in group A as compared to group B, which can be seen by the magnitude of mean over subsequent visits, and paired sample t-test was also done to quantify the magnitude of change, which was seen at the end of 3 months in group A in the above table and group B in the below table, which was quite significant. Improvement in uncorrected and best corrected visual acuity was also measured, although the difference was not significant between the two groups. Coming to discussion, our results were comparable to the studies conducted by Mandicut et al., Anand et al., and Medel et al., in that the correction of cylindrical component of manifest astigmatism was better with toric IOL, while total keratometric astigmatism correction was better with OCCI. Literature search was done, and various researchers were seen to conclude that the mean reduction in corneal astigmatism using OCCI was quite variable, which can be seen in this table, while in our study at the end of 3 months, the mean reduction was 0.597 diopter. These differences depend upon the variety of incision lengths and the amount and type of pre-existing astigmatism. Improvement in uncorrected and best corrected visual acuity was comparable with various studies. To summarize, OCCI is extremely unpredictable based on the configuration of incision, and toric IOL takes care of astigmatism at the lens plane as well as at the corneal plane. So the results of toric IOL is much predictable, although OCCI is a cheaper alternative for non-affording patients. These are my references. Thank you.
There is nothing new in this study, but outcome is almost known to everyone, but you have presented it so well. Everything is in perfect position, the data, the analysis and everything, so you are bang on time also. So it's a very good presentation.
Thank you, sir.
But the amount of astigmatism corrected, one has to know how much incision and where to give incision to make a difference in the astigmatic correction, and that also depends on the surgeon to some extent. So was this surgery done by a single surgeon? Or?
Yes, sir. So I've written that in my presentation also. Thanks.
So your study further establishes that the toric IOL is better than doing the...
Sir, but in non-affording patient, we were basically studying...
definitely in non-affordable patient we can do that.
Yes, sir. Thank you, sir.
Next is Dr. Kopal Srivastava, and her topic is Phaco Blues, a tough complication.
Good
Good afternoon, everyone. I'm going to present on phaco blues, a tough complication. There is no financial disclosure or conflicts of interest. As we all know, trypan blue is used for anterior staining of capsule while doing cataract surgery, but it can also lead to staining of posterior capsule or vitreous, which is commonly reported in cases of zonular compromise, that is trauma, surgery, or pseudo-exfoliation. Few cases where similar staining have been reported in absence of zonular compromise on preoperative examination. So we are going to report some few cases. In our first case, there was 45-year-old female presented to us with diminution of vision. There was history of trauma to right eye with wooden stick, which leads to development of cataract formation. On anterior segment examination, it reveals irelodialysis as well as subluxated lens, and the patient was further planned for right eye cataract surgery with IOL implantation. As we can see in this picture, there is anterior segment iris iridodialysis with subluxation of lens. An anterior capsular staining was done, and it was seen that in the area of zonular compromise, there is posterior spilling of dye into the vitreous, which lead to posterior capsule and as well as vitreous staining. Our second case was 20-year-old male who presented with complaints of diminution of vision. There was no history of ocular trauma, recurrent redness, pain, or previous ocular surgery. There was no any signs of zonular compromise or pseudo-exfoliation or uveitis was noted preoperatively. As we can see in this video, there was inadequate pupillary dilation, so excessive amount of OVD was injected to attain the adequate dilation. We use both dispersive as well as cohesive OVD. After staining and rhexis, phacoemulsification was done. While doing phacoemulsification, we noted dark fundal glow, as we can see in this picture. That means posterior spilling of dye in normal zonular cases. In our third case, 45-year-old female presented with complaints of diminution of vision. There was history of intravitreal injection in right eye due to severe NPDR changes. There was no any signs of zonular compromise which was noted previously. So we can see in the quadrant of intravitreal injection given, there was cataract formation and anterior capsular staining as well as dye washout was done, and we see there was posterior staining of capsule in the area of where intravitreal injection was given previously. While doing phacoemulsification, that was completely normal and does not show any changes in posterior capsule as well as zonules. So in post-op period, there was bluish tint visible on fundus examination, and it disappeared up to first week. And retinal toxicity was not observed in our patients. So I'm coming to on discussion. On staining of posterior capsule in vitreous is commonly seen in cases of zonular compromise, as we see in our first case. In second case, there was inadequate pupillary dilation, so we use excessive amount of OVD, which elevate the pressure and force the dye to move posteriorly to structurally normal zonules. In a case report by Marcus et al. And a case report by Pellet et al., they both suggest that increase in IOP due to excessive amount of OVD lead to posterior spilling of dye. In our third case, there was history of intravitreal injection. So according to Welles et al., there is intravitreal injection which cause inadvertent posterior microtrauma or uncharacterized biochemical damage to zonules, which can lead to posterior spilling of dye. So how can we prevent that? As there are various measures, we will discuss first one measure, that is viscoelastic barrier creation. So as we can see in this video, there is 6 clock hour subluxation, so ejecting OVD in the area of subluxation, and further staining of capsule is done, and dye was washed. After washing the dye, phacoemulsification was continued, and we saw that there was no posterior spilling of dye, as we can see in this video. So our 3 cases highlight the possibility of vitreous staining in clinically normal patient and can lead to unusual complications, so pre-op examination is necessary. Thank you.
Did you try that in these cases, normally it doesn't go posteriorly, but in these cases, can you reduce the duration of the trypan blue?
Yes, sir, we can reduce, but we use excessive amount of OVD, which created, as we all know, in pre-operative examination, there was no zonular compromise, and there is no any signs of trauma, and in one patient, other eye operation was also uneventful.
can you comment on one statement using a OVD? Did you use a dispersive or a cohesive viscoelastic for seeding that area?
Yes, sir,
Which is probably going to be better? I mean, this is just a hypothetical question.
So we can use cohesive OVD in that area so that after staining we can easily wash out that OVD for further surgical procedures.
But the dispersive will act better. It won't let the things to go like. So because of that reason, the OVD which has a dispersive property is used to plug the PCR to prevent vectors coming into the AC. So that would be a better thing. The only problem which is encountered once lot of this triple blue goes is the visibility of doing cataract surgery. That is the only thing, but otherwise it doesn't cause any toxicity.
No, so it doesn't cause retinal toxicity because the concentration is 0.06%. In retinal surgeries, we already use 0.15%, so that it does not cause any retinal toxicity.
Next. And how much time it takes to disappear from the vitreous?
Sir, it depends. Mostly within 1 week it goes. Yeah.
Next is Dr. Anu Rai to present the topic Through the Eyes of Sturge-Weber, Unveiling the Ocular Mysteries.
Good afternoon, everyone. Myself, Anu Rai, second year junior resident, RIU IGMS Patna. I am presenting on the topic Through the Eyes of Sturge-Weber, Unveiling the Ocular Mysteries. I have no financial disclosure to make and no conflict of interest. A 14-year male presented in RIU OPD with a chief complaint of diminution of vision in the right eye and pain in the right eye and a headache since 6 months. The diminution in right eye was gradual in onset, progressive, associated with redness of eye pain and unilateral headache. There was no diurnal variation, not associated with nausea, vomiting, and colored halos. Patient reported history of similar ocular episodes that has occurred intermittently during the last 6 months. Patient gave history of using topical eye drop prescribed by an ophthalmologist outside the institute. Now, on general examination, there was a flat, reddish-purple, pigmented lesion on the right side of the forehead, upper part of the face, and the right side of the nose, which was present since birth. Soft tissue hypertrophy of the right side with the facial asymmetry is noted. On the ophthalmical examination, right eye showed 6 by 12 pars, uncorrected vision, and best corrective of 6 by 9. Near vision was normal. Lid, upper and lower lid shows the reddish purple color and congested conjunctiva with the apparent dilatation of the episcleral vein. Pupil showed IRPD and AC was of normal depth and optically clear. Left eye ophthalmological examination was within normal limit. On fundus examination was done with the slit lamp using 90D. Right eye showed cup disc ratio of 0.9:1 with thin neuroretinal limb and binating and nasalization of the vessels with the peripapillary atrophy. Left eye shows the cup disc ratio of 0.5:1 macula was on. Now, Goldman aplanometry gives the measurement of IOP, which was right eye 28 mmHg. In right eye, the gonioscopy showed open angle with blood in the Slem's canal inferiorly in the nasal quadrant and pigmented trabecular meshwork inferiorly and superiorly. Gonioscopic finding of the left eye was within normal limit. On the relevant glaucoma-related investigation, the central cornea thickness, right eye was 495, left eye 507. On the OCT RNFL, on the tomograph, you can see the loss of the retinal nerve fiber layer and the thinning in all the 4 quadrants of the nerve head, optic nerve head. Further, automated perimetry test was done, which showed ring or ring scotoma and a probable diagnosis of type 2 Sturge-Weber syndrome was made. Elevated IOP was initially treated with the topical drops in addition with the previously advised topical medication, and the patient was advised to come after 1 week with the blood report and contrast enhanced MRI, brain and orbit. Blood reports were within normal limit. MRI of the brain and the orbit showed no significant changes. IOP was 20 on the follow-up, and it was not adequate to have such an IOP in the advanced glaucoma, so the patient was wired and counseled for the surgery. Dermatology consultation and psychiatric consultation was done for the presenting illness. Now, differential diagnoses include Klippel-Trenaunay-Weber syndrome, Rendu-Osler-Weber syndrome, Maffucci syndrome, and Beckwith-Bidman syndrome. Now, Sturge-Weber is a rare neurocutaneous disorder characterized by the abnormal vasculature in the skin, brain, and eye. Patient with the Sturge-Weber have facial capillary malformation, also known as port vein stain, leptomeningeal malformation, and abnormal blood vessels in the eye and glaucoma. It is caused by mutation of GNAQ, and more recently GNA11 gene is also associated. It occurs in 1 in 20,000 to 50,000 live births, affect male and female equally without racial predilection. It is the third most common neurocutaneous syndrome behind neurofibromatosis and tuberous sclerosis. Now it present as a 3 distinct type. Type 1 include facial malformation and brain malformation. Type 2 include facial angioma along with the glaucoma. And type 3 include only the leptomeningeal angioma. Now, Sturge-Weber is a very rare and challenging disease for both patient and their family. It can affect many systems of the body, and the key is the management of the Sturge-Weber is to prevent and reduce the intensity of complication. Early identification and early institution of the treatment is imperative for the patient to have a better quality of life. These are my references. Thank you.
Your presentation is nice, but the visibility of the slide is not okay. And you have not to do anything. You just make the fonts bold. That will improve the thing.
So what category you put this Sturge-Weber syndrome? Whether you put it in the open angle glaucoma category or the closed angle
So
glaucoma?
open angle.
Okay, right.
Yes.
And what is the treatment for Sturge-Weber syndrome?
So for glaucoma.
For glaucoma, yeah. Basically, you're for ocular this thing you are treating glaucoma because the pressure and all that is.
So firstly, we start with the topical eye drops, mainly which increase the uveo-scleral outflow, like the alpha agonist and the PG analogs. But in my case, there was advanced glaucoma. The Cup-Dix ratio was 0.9, so surgery was advised.
Medical management basically fails in such cases. So ultimately, one has to go for the
Yes,
surgical
sir.
management.
Yes, sir. So
And
surgery
surgical
includes
management basically you have to do goniotomy to
Yes, sir.
trabeculotomy to trabeculectomy
yes, sir.
and even to shunt.
Two-stage, yes,
shunt
GDD.
also.
Yes.
Yeah, so that is the ultimate fate of the patient.
Yes.
So ultimately, the idea is to control the intraocular pressure.
Yes.
Did you specifically look for choroidal hemangioma or anything?
Yes, sir. I did the base scan, but did not. Thank you, sir.
Our next presenter is Dr. Priyanka Mohanty. She is going to present on caniculi involving lead laceration, a case series.
Good afternoon, respected judges and everyone. I'm going to present a case series on canaliculi involving lid laceration, showing functional and anatomical outcomes. There is no financial disclosure or no conflict of interest associated with my study. Eyelid laceration involving the canaliculi has a prevalence of around 10 to 20% in all eyelid trauma, and the common modes of injury include animal bite, blouse hook fastener, falls, blunt trauma, and RTA. Presentation to our center is usually late and associated with concurrent life-threatening situations. Delayed repair leads to scarring and obstruction of lacrimal pathway and lifelong symptomatic epiphora. It's more prevalent in children and young adults, with males more frequently affected than females. Surgery involves mono or bicanalicular stent placement along with primary repair. We took patients with lid laceration with canalicular involvement operated by the same surgeon over 6 months of period in AIIMS Patna. After cleaning the wound, the distal cut end was identified as a pinkish white elevated mucosal structure, as you can see in the picture. After that, Bauman's probe was used to look for hard stroke. And after that, we can see the monocanalicular minimonoca stent was placed and pericanalicular suturing was done. Stent removal was planned at 3 months after surgery and syringing was to be performed. Anatomical outcome was observed with respect to structural integrity and patency of nasolacrimal duct, and functional outcome was observed with respect to absence of epiphora. This was our first case of a 24-year-old male with left eye lower lid full thickness laceration, allegedly due to dog bite. After that, he underwent primary repair with monocanalicular stent placement under GA within 24 hours of injury. And on the recent follow-up visit, we could see the stent in situ as in this picture, and removal was done after 3 months, and on syringing, there was no regurgitation of fluid. This was a similar case of 40-year-old female with lower lid full thickness tear due to RTA. She also underwent the same procedure, and on last visit at 2 weeks post-op, there was no complaint of epiphora and the stent was in situ. This was a case of 1-year-old female child with left eye lower lid laceration due to blouse hook while breastfeeding. The child underwent the same procedure with repair and stent placement within 40 to 8 hours of injury, and on last follow-up visit at 2 months, the stent was in situ. In our fourth case also, a 2-year-old male child had injury due to blouse hook and undergone the same procedure. In this case, orostent was implanted instead of mini monoca, and at 2 months of follow-up, we could not locate the stent. It was most probably excreted due to spontaneous manipulation. In our fifth case, a 13-year-old male child had history of fall and presented us with lid laceration, who also underwent primary repair with stent placement within 72 hours of injury. The stent was in situ after 1 month and no complaint of epiphora. Now this was the interesting case of a 5-year-old male child with both upper lid and lower lid laceration, and both the canaliculi was involved. Hence, due to intraoperative difficulty, only primary repair could be done and the stent could not be placed. With our case series, we observed that canalicular involvement is more prevalent in lower lid than upper lid, with males more frequently affected. And children and adolescents are predisposed group. 2 toddlers had injury due to blouse hook fastener that is quite unique to Indian subcontinent, and presentation subsequent repair to our center ranged from within 24 hours to 5 days. Edema and inflammation in late presentation produced some difficulty during intraoperative procedure for stent insertion. And as for results, only one patient, the stent removal was done, and on syringing there was no regurgitation of fluid. Premature pooling was present in one child, and in the rest of the patient, the stent was in situ. Now coming to the discussion, lacrimal canaliculi lacks a tarsal substructure, and displacement from the medial canthal tendon increases its risk of tear. The tear should be preferably repaired within 48 to 72 hours, but there is no clear-cut guidelines formulated. And as far as the procedure is performed, we can locate the canaliculi using anatomical landmark as a pinkish white mucosal structure, or we can also inject fluorescein or air bubble. As for recent advances, we can use fiber optic light probe, and traditionally pictal catheter can also be used, but in inexperienced hand, it increases the chances of tear. These are some related work that has been done in India and abroad with respect to my study, and these also confirm the demographic findings, and that monocanalicula stents have excellent anatomical and functional outcome in lid laceration repair, and dog bite with late presentation are poor prognostic factors. I would like to conclude saying that it needs skillful surgical intervention in appropriate time. Stent placement can significantly improve patient's quality of life, and there should be awareness regarding safe breastfeeding, especially in a country like ours. Thank you.
When did you remove that mini monaca stent in these patients?
Yes, sir, as an OPD procedure.
After how many months I mean?
3 months, sir.
3 months.
3 months.
In all patients?
No, sir. Only one patient has been the time up to 3 years. Rest of the patient, it has been only 2 months or 1.5 months. Thank you.
All the cases were followed by you?
Yes, sir.
All 6 cases in same center?
Yes, sir. And operated by the same surgeon, sir.
Next is Dr. Ansuman Singh. His topic of presentation is ocular involvement in RTA.
A very good afternoon to respected judges, my seniors and dear colleagues. I am Dr. Anshuman Singh, a first year PG resident from RIO. I am here to present a case of exposure keratopathy with concomitant 6th and 7th cranial nerve palsies following road traffic accident. There is no financial support or conflict of interest in this presentation. Patient profile, my patient is a 24-year-old female, a student by occupation. She was unmarried from a suburban background. Chief complaint, my patient had diminution of vision since 2 weeks in right eye, foreign body sensation since 2 weeks in right eye, inability to close right eyelid since 2 weeks, and discharge from right eye since 2 weeks. History of presenting illness, patient had a history of road traffic accident 1 month before presentation to RIO. She had a collision with a truck. She was on a two-wheeler. At the time of accident, she had no history of, she had no episode of loss of consciousness, epistaxis, rhinorrhea, hearing loss or vomiting. 2 weeks later, she developed DOV in right eye, watery discharge, inability to close her right eyelid, itching, and foreign body sensation. There was no complaint of diplopia. 10 days later, she presented to RIU OPD. At the time of the accident, she was managed medically at a local hospital post the trauma. Personal history, family history, and surgical history are not of much significance. General examination was within normal limits. Coming to the slit lamp examination, left eye was within normal limits. In the right eye, she had both UCV and BCV were finger counting close to face. Her eyelids, she had inability to close, that is lack of ophthalmos. Bell's phenomenon was poor. Extraocular movements was restricted in lateral gaze. Palpebral aperture height was reduced to 7 millimeter. Conjunctiva was congested, and in the cornea there was inferior epithelial defect, a horizontal oval inferior epithelial defect, 6 mm by 5 mm of size. She had a few DM folds with corneal edema, and the margins of the defect were smooth. Corneal cessation could not be assessed. Schirmer's test, both 1 and 2 were reduced to 7 mm and 5 mm respectively. Pupil was hazily viewed, but it was round and reacting to light. Lens, she was phakic, but the clarity could not be assessed. Fundus could not be visualized on indirect ophthalmoscopy. Cranial nerve examination, all the nerves were tested and were normal except 6th and 7th. Investigation sent were KOH and gram staining, which was negative. Conjunctival swab culture was negative. B-scan right eye was within normal limits. X-ray skull AP view showed temporal bone fracture in the right side. NCCT head showed fracture of right maxillary bone extending into the sphenoid wing. After this, we came to a provisional diagnosis of right-sided 6th and 7th cranial nerve palsy with lack of ophthalmos and exposure keratopathy. The DD was dry eye, neurotrophic keratitis, and drug-induced keratitis. Management course, the patient was immediately started on empirical treatment like topical antibiotics, topical lubricants with oral doxycycline course, and multivitamins daily. She was advised lid taping for as long as possible, especially at night with eye gel application. Treatment was modified with addition of topical low-dose steroid after ruling out fungal etiology with KOH. She started improving symptomatically. A neurologic consultation was done and patient was put on oral steroids. Patient was discharged on the above medication 4 days later with BCL application. Right now she's on weekly follow-up and is showing signs of improvement. Tassoraphy is being planned. Discussion. Post-traumatic 6th nerve palsy associated with 7th nerve palsy is an exceptional condition. Fractures involving the petrous part of the temporal bone and facial wounds transecting the branches of facial nerve can cause facial nerve palsies. The 6th nerve may be impacted against the Gruber's ligament, that is the petrosphenoidal ligament, following an upward thrust, or is injured when it impacts against the ridge of the petrous pyramid. Facial nerve recovery is the major concern in these cases as it can lead to exposure keratopathy. 6th nerve usually recovers spontaneously. Fluorescent dye can reveal areas of keratopathy secondary to exposure, which can range from mild punctate epithelial erosions to large epithelial defects and corneal infiltrates. Prolonged exposure can lead to corneal thinning, keratitis, sloughing, and perforation, especially in the setting of poor Bell's phenomenon and diminished corneal sensation, as in this patient. Conservative management includes lubrication, retaining moisture, obstruction of tear outflow, improvement of tear quality, and bandage or scleral contact lenses. Surgical management includes temporary or permanent tarsorrhaphy. Take-home message from this case is that road traffic accidents can lead to multiple nerve injuries and resultant ocular manifestations like lack of ophthalmos and exposure keratopathy. A multidisciplinary approach, that is complete neurological and ophthalmological examination, is required in diagnosis and management of these cases. Management of lack of ophthalmos and exposure keratopathy is crucial for preservation of globe and injury. Thank you for a patient listening.
Very unusual case presentation of combined 6th and 7th with the road traffic accident patient. So could you come to any point why did these two happen in this patient without any other neurological, could not find out the cause?
So we can, so there are two possibilities. Either
possibility in this patient, could you find?
So we could not localize exactly where the lesion is, but there are possibilities. The lesion can be at multiple places or at a single place impacting both 6th and 7th cranial nerves.
Thank
you. Next, I request Dr. Swati Singh to present her topic, Recent Advances in Management of Amblyopia, a review.
Good evening once again. I'm Dr. Swati Singh, JR in Ophthalmology at NMMC Gaya. I'm here to present a talk upon recent advances in management of amblyopia. This famous comic strip from daily newspaper shows
awareness about patching, and the treatment of amblyopia. So what is amblyopia? It is the reduction in best corrected visual acuity in one or both the eyes due to abnormal binocular interaction or pattern visual deprivation during visual immaturity, although there is no structural abnormality. What causes it? Stimulus deprivation, strabismus, refractive amblyopia. This map shows that India falls under the high prevalence country. So why must we bother? Because amblyopia is known to affect at least 2 to 3% of children and causes reduction in visual acuity, leads to reduced contrast sensitivity, as well as 3D image and depth perception is also impacted. It affects stereopsis, and hence there's difficulty in driving, playing the games, which focuses on games, ball games, and then their career in aviation. It affects the reading fluency and speed, and the fine motor and gross motor skills of the child is also affected. The management has to be, the earlier the better, refractive error correction has to be given. The critical period is defined as few weeks after birth to 7 to 8 years of age. Conventional methods that are into play are patching and penalization with atropine drops. We all know the pros, so what are the cons? With the spectacles, we have the prism effect. With the gold standard patching, we have seen there's skin irritation, poor adherence, monocular treatment, and reverse amblyopia chances. With atropinization, we see there's increased light sensitivity and reduced schoolwork and learning, as well as their potential systemic side effects. What are the problems not addressed yet? The binocular vision stereo acuity, near-focus accommodation, tracking and eye movements, visual motor coordination and processing, contrast sensitivity, not addressed. So what must we do? Look for options. Our approach has to be binocular, the push-pull method, advantaging the amblyopic eye and disadvantaging the good eye. Also, we need to look for options which affect the 3D image viewing and depth perception. Now coming to the main topic, the recent advances. There are new screening technologies, visual perceptual learning protocols, VR headsets, and orthoptech. New screening technologies include the binocular retinal birefringence, optokinetic nystagmus visual acuity, and artificial intelligence. These are lazy eye apps available on the App Store or the Play Store. The child can play and help exercise their muscles. Visual perceptual learning protocols includes the dichoptic video games using the dichoptic therapy, contrast rebalance movies, and online training platforms. Dichoptic therapy is basically stimulation, simultaneous stimulation of both eyes with different visual stimuli, and helps in binocular interaction and reduces suppression. This is a picture. This is a small clip from a very famous video game where the patient wears anaglyph glasses. Contrast rebalance movies. VR headsets, which helps in immersive experience of the child. Here the contrast in the weaker eye is stronger, whereas in the stronger eye it is reduced to at least 15%. Orthoptic, a novel method which was pioneered by Dr. Sandanam Gopal based out of Bangalore, exercises brain by stimulating paracellular and magnocellular pathways. Other emerging amblyopia treatments are liquid crystal display eyeglasses, but very expensive. Pedic trials have shown that reduced hours of daily occlusion is equivalent to greater hours of occlusion as well in case of moderate severe amblyopia. Pharmacotherapy, citicoline and levodopa has shown that there have been effects and increased effect in the amblyopia. Others, citalopram, donepezil, and subanesthetic ketamine are under trials. These all work on the concept that is the brain can be stimulated to form new connections between existing brain cells and old ones by strong, persistent, and appropriate stimuli. So the take-home message would be, we must understand what is the neuroscience behind amblyopia so that it could lead to future treatment discoveries. Extensive research and well-designed studies required to find the pharmacological and the medical methods. Then use of artificial intelligence which could help us find avenue for the research wonders. So be innovative, keep thinking, find a treatment to amblyopia. Thank you so much. I hope this presentation helped you.
No question, but good information there and good presentation.
Our next presenter is Dr. Pooja Singh. She will be presenting on golden hair syndrome, a case report.
A very good evening to all. I'm Dr. Pooja Kumari, second year PGT, and I'm here to present on golden hair syndrome, a case report. So a 39-year-old male patient came to our OPD at IQ City Medical College with complaint of redness in left eye for 2 days. He had a history of trauma 2 days before by his own hand in left eye. He presented with yellowish pink mass on limbus and conjunctiva at temporal side of left eye associated with hair follicle, which was present since birth. There was no associated pain or discomfort in left eye and no associated visual complaints. Past history, there was no past history of any ocular surgery or trauma to eye, no history of hypertension and diabetes mellitus. Personal history, he was a non-smoker but alcoholic, but no history of any drug allergy. There was no significant family history. On general examination, physical examination shows a preauricular tag present on left side. Ocular examination, anterior segment examination was normal, vision NCT pupil was normal. On slit lamp examination, there was a limbal dermoid with hair follicle at inferotemporal region in left eye. On fundus examination, media, cup disc, macula was normal. Differential diagnosis, epibulbar dermoid, lipodermoid, ocular surface, squamous neoplasia, granuloma. Investigation, complete blood count was normal. CT scan orbit shows hypodense lesion of fat attenuation on lateral aspect of left orbit. X-ray spine lateral shows no vertebral anomalies. Intraoral examination reveals malocclusion of lower dentition. So provisional diagnosis, all this investigation and features suggest it is a case of golden heart syndrome. Points in favor, golden heart syndrome is a rare congenital disorder which comprises various anomalies such as preauricular appendages, limbal dermoid, auricular malformation. There was a limbal dermoid with hair follicle present at temporal side of left eye, preauricular tag was present, and malocclusion of lower dentition. Plan of management, surgical excision of the dermoid cyst. Discussion, golden heart syndrome is a rare and sporadic condition of unknown etiology characterized by a combination of anomaly, oculo-auricular vertebral dysplasia, dermal epibulbar cyst, and malformation of ear. So multidisciplinary approach is mandatory for early diagnosis and management to avoid complications and to increase awareness about this rare entity to highlight the importance of clinical finding and its association with its various systemic conditions. Thank you.
No time. Next.
Our next presenter is Dr. Aditya Ranjan. His topic of presentation is clinical profile and prognostic indicator of visual outcome in a tertiary care hospital.
Good evening, everyone. I'm Dr. Aditya, Junior Resident AIMS Patna, and my presentation is on traumatic cataract, clinical profile and prognostic indicators of visual outcome in a tertiary care center. So there are no conflicts of interest or financial disclosures to begin. Trauma is one of the major causes of visual impairment and ocular morbidity, especially in children. Both closed globe and open globe injuries may lead to traumatic cataracts, which may require early meticulous and multi-stage procedures. Open globe injuries are generally repaired first, followed by cataract removal, and management is often challenging with a guarded visual prognosis. So these are some of the pictures showing the cases that presented to our center. The objective of the study was to determine the demographic and clinical profile and visual outcomes in patients with traumatic cataract presenting to a tertiary care center of Eastern India. Traumatic cataract is an important cause of ocular morbidity and blindness. Nearly 16 lakh people lose sight due to traumatic cataracts every year, and it may lead to amblyopia in pediatric cases. Management widely differs from that of a senile cataract. So it is a hospital-based, retrospective records-based study, and the study population consisted of patients of all ages with traumatic cataract presenting to our OPD, and there was purposive sampling done employing complete enumeration method of data collection. The study duration was from January 2022 to January 2024. So during this period, 56 patients of traumatic cataract presented to our lens clinic, and out of those patients, 43 fulfilled the inclusion criteria, which were cases of cataract secondary to trauma with at least 3 months of follow-up and no signs of secondary or complicated cataract in the fellow eye. Data of these 43 patients were tabulated and appropriate statistical tests were applied to meet the objectives of the study. The primary outcomes were proportion of traumatic cataract with open versus closed globe injury and the final visual outcome. And the secondary outcomes were age and gender proportion, proportion of various modes of injury, and proportion of associated ocular findings secondary to trauma. So there was an equal proportion of open globe and closed globe injuries in cases of traumatic cataract in our study. There was a preponderance of younger age group. More than 60% of the patients were younger than 20 years of age. Males were 4 times as much more commonly affected than females. And there was corneal involvement in all cases of open globe injury, out of which 45% of the patients had involvement of the visual axis. LC breach was more common in open globe injuries, and lens subluxation was more common in closed globe injuries. In posterior segment, 5 patients had posterior segment complications, out of which vitreous hemorrhage was the most common. 86% patient underwent primary phacoaspiration with PCIL, and the remainder underwent secondary IL with SFIL. And of all the patients that required the use of CTR, 90% of the patients had a closed globe injury. So all our patients with both closed globe and open globe injury had a presenting visual acuity of 6/18 or less. And 86% of the closed globe injury patients, they recovered with a visual outcome of 6/18 or better after 3 months follow-up. However, in the open globe cases, only 50% recovered with a visual acuity of 6/18 or better after 3 months. So Shah et al., they also found a similar predilection of younger males in their study, and in their study, which was conducted on over 500 eyes, there was a higher proportion of open globe injuries, and closed globe injuries are mostly complicated by associated lens subluxation, and open globe injuries, they are also complicated due to corneal involvement, which leads to visual impairment, as shown by Bruno Santos et al. And posterior segment complications like intraocular foreign body, vitreous hemorrhage, and retinal detachment, they are associated with a poor visual outcome. To conclude, younger males have a higher chance of suffering from traumatic cataract, and in our study we found a similar proportion of open and closed globe injuries. Blunt trauma has a higher chance of leading to cataracts with lens instability, and penetrating trauma often leaves patient with a corneal scar. And secondary IL implantation is prudent in cases of ocular inflammation. These are my references. Thank you.
Thank you, judges. With this, we conclude our session 3. I request Dr. Dekant sir and Dr. Deepak Agarwal sir to moderate the next session, the mixed bag session, session 4. Sir, इसमें नाम I request Dr. Akanksha to come up to the podium to present her topic.
Good afternoon, respected judges and all my dear colleagues. Today I'm going to represent on a very interesting and rare congenital anomaly, that's optic disc split maculopathy, and I've labeled it as changing fortune due to the waxing and waning course of SRF resolution. There was no financial disclosure and conflict of interest. The purpose of my study was to evaluate surgical intervention with pars plana vitrectomy for correction of optic disc split maculopathy. It was a prospective interventional case study over the past 2 years in IGIMS with patients of optic disc split maculopathy who underwent PPV. It included 5 patients, that is 5 eyes with a diagnosis of optic pit and schisis or retinal detachment in macula. So pre-operative and post-operative data was collected that included demographics, that included age and gender, laterality, presenting visual symptoms, best corrected visual acuity, and type of surgery. OCT, swept or OCT was performed in all the patients. Informed consent was taken prior to any surgical intervention, and the study was conducted in accordance with ethical principle represented in Declaration of Helsinki. Follow-up was done for 18 months at post-op day 1, post-op 1 month, and thereafter 3 monthly. So here are the pictures of my patients, 5 patients, and that means 5 eyes. So my first patient was a 38-year female with visual acuity of 3/60 and diminution of vision in right eye. Here we can see the optic pit inferotemporally with SRF presence. Second was a patient, 50-year-old female with primary open angle glaucoma suspect, visual acuity 6/36 with similar complaints. As macular mottling can be seen, which represents the chronic nature. Third patient is a 39-year female with visual acuity 6/60 and shows a central large optic pit. And fourth patient was a 28-year male with visual acuity of 6/18 with similar complaints. And fifth patient shows a similar clinical picture, which was a 14-year male. So moving on to the, I have tabulated the preoperative as well as postoperative visual acuity, OCT, surgical intervention, and CMT of all the patients, which shows that of all the 5 patients, visual acuity improved only in the first patient, and SRF resolution was noted, as we can see from the postoperative picture. PPV and ILMP was done in all the patients, and 3 patients were followed with scleral patch grafting, and 2 were done with gas tamponade. In all the patients, CMT decreased postoperatively. So on the basis of this, most commonly affected eye was noted to be right eye with best corrected visual acuity 6/18 to 6/36, and 30 to 40-year age group was more commonly involved, with female being the most common. Of all the 5 patients, PPV and ILMP was done in all cases, scleral patch was done in 3 patients, and gas tamponade was done in 2 patients. Anatomical resolution as well as functional resolution is noted, with, which included CMT decrease, SRF resolution in 5 patients, and gain in visual acuity in 1 patient. So on the basis of this, PPV was the most important surgical intervention that was done in all the patients, with adjunct procedures like ILM peeling, scleral patch grafting, gas tamponade, and active fluid drainage with 41 gauge needle to displace the macular SRF and stimulate the retinal epithelial pigment for resolution of SRF. So the complete resolution was noted in 4 patients in the follow-up period. One of these 4 patients needed second surgical intervention due to increasing SRF, and mean time for complete resolution was about 14 months plus or minus 2 months. Resolution of optic disc pit maculopathy was noted to be faster in patients with gas tamponade, and scleral patch grafting was observed to have better SRF resolution. So according to a MECPIT study, which is the largest study on optic disc pit, which included 51 eyes by R. Vinci et al., showed that PPV and gas tamponade with or without juxtapapillary laser photocoagulation and ILM peeling is effective for most of the cases. It is combined with other different adjuvant techniques, but due to the decrease in, due to the rare nature of this disease, the groups were not of sufficient size, and this is a limitation of all the studies of optic disc pit. And sealing the pit with sclera seemed to be the best option, and macular buckling being another one of them, but not commonly used. So conclusion, elimination of vitreous traction and SRF drainage are key procedures in the anatomical and functional resolution, and need of prospective and comparative multi-center trials are very urgent in now era. These are my references. That's all. Thank you.
Thank you, judges. Thank you, Dr. Akansha. Here, I request Dr. Devkan sir to come up and moderate the next session, the mixed bag session, session 4.
Now we will have a high tea break of 15 minutes, and don't forget that just after this break of 15 minutes, we will be having audience quiz, and there is a cash prize for that. Sir, I will come and collect. So there is a cash prize for that. So you have to choose between extending your high tea or come back and grab the cash. Thank you.
Shall I start? Okay. Can I have the question on screen? Acha. Okay.
Please take your seats. Okay. Okay, can I have the question? So the person who's going to answer first will get the heavy cash prize. Flash the question on screen. So name the person you're seeing on the screen. Time over. Okay. Answer? Okay. So I'll give you the answer. Yeah. Bruce Shields. Okay. So no problem. Probably there'll be another quiz question later on. So to start this session, can I request the chairpersons, Dr. Pradeep Karak sir, Dr. A.K. Gupta sir, Dr. J.G. Agrawal, Dr. Sunil Parmar, Dr. Vikas Sinha, Dr. Soni ma'am to please come and take the chair. The panelists for this session, Dr. C.M. Singh sir, Dr. Divya Kumari, Dr. Rashmika, Dr. Binod Kumar, and Dr. Vivek. Please come on the dais. So to start this session, can I request Dr. Subhash Prasad sir to give his talk on life begins at 33 centimeters. Is your PCIOL ready?
ये this is actually sponsored talk for this conference. The company or this J&J has not sponsored my talk, but basically they have given the fund to this conference, so I am talking on their behalf. And the title is Life Begins. क्यों खुल नहीं रहा? यहाँ पे? It's all because of synergy IOL. ये क्या हो गया? ये है. Good evening. The title says life begins at 33 centimeter. I would say that life begins for any ophthalmologist at 33 years of age. So let us start with the talk. Thank you, Pos, for giving me this opportunity. We all know that the phaco with the foldable IOL is the procedure of choice for cataract management, and with the advancement in technology which has occurred not only in machine but the IOL itself has led the patient to have very good outcome. But with time, the profile of the patient has also changed, so more and more patients are coming with very high demands for their better lifestyle adjustment and to have better vision after the surgery. So what is seen nowadays is the rapid shift to digital platform, which has created a rapid increase in far through near vision demands. And many of us now are always spending much of time, not only for distance, but also for the intermediate and the near one also. And as a clinician, so our duty is to have happy patient at the end. And it's not only that giving 6/6 vision is good enough, but nowadays the patients wants much more than that. So the era came with the invention of the presbyopic correcting lenses. So what are the criteria for ideal presbyopic correcting lenses? Should be able to give vision for all ranges, should be able to give good quality vision in low, bright, dim light conditions, and there should not be should it have a very negligible night vision problems. So there are so many lenses available in the market nowadays. Now most of the lenses give 6/6 and 6 vision, but many of these lenses have their night vision problems. So now the focus of the research is on how to decrease the problems associated with the trifocal or multifocal lenses. But despite all these, there are IOs which are claimed to give vision for all distances, but they have some limitations also. So there are some gaps which are not fulfilled with some of the multifocal or trifocal lenses. So the Technis Synergy is one lens which combines actually diffractive technology from Technis multifocal lens and Technis Symphony, which delivers a continuous high contrast vision across all the ranges. And these lenses have diffractive rings. Some of these rings split the incoming light to different focal points, while some of the rings stretches the light between the focal points. That's why the patient has continuous range of vision. So this technology actually mixes two technologies, types of technology to give good distance near vision without any dependence on pupil. You can see the defocus curve here with this lens, synergy lens. We can have a patient who has a nearly continuous vision from distance to near, as opposed to many other trifocal lenses. Not only that, this lens has chrome-aligned technology which corrects the chromatic aberration also. This is the just schematic diagram showing that the monofocal lenses give correction for the distance, the multifocal for distance and some near. But Technis Synergy lenses is able to give the correction from distance to near without any break. So this is actually a true continuous vision lens which gives vision across all the zone. It delivers unparalleled in the zone visual performance, surpassing the pronounced visual gaps of trifocal IOL technology. This has been compared with various other trifocal lenses available in the market. You can see with this graph the Technis Synergy lens is performing better in this zone where there is always some gap with some other trifocal lenses, like some of the lenses are not able to give between the intermediate and near vision or intermediate or distance vision. So that gaps is actually fulfilled with the Synergy IOL. There is superior low light contrast vision also with the Synergy IOL as compared to the others. The modulation transfer factor as shown in this picture shows that the Technis Synergy lens outperforms the other IOLs. There is high quality vision which starts with the proven Technis IOL platform. Which gives spherical aberration corrections of essentially to 0, and there is chromatic aberration correction also. And nowadays, many of us are using the LED light, and this LED light actually emits light which is in the range of near violet range, which causes much more of the scatter during the night vision problem. So this is these lights are going to give more scattering if you use trifocal lenses of some other companies, but here this lens has actually got some filters which even blocks the violet light filter, light source. So it actually decreases the night scattering or glare in the night vision actually. So in that way, with the LED light source, this lens performs better than the many others. This not only gives good daytime, but also nighttime driving is better with these lenses because of these various advantages. This lens has got chrome aligned technology, which results in enhanced image contrast across the range of vision, far, intermediate, and near. So if you see the diagram, if the light crosses the lens, because of the chromatic aberration, the blue light gets focused before the retina as compared to the red light. But with the lens which has chromatic aberration correction or chrome aligned technology, these lights actually gets focused nearly onto the retina, so that's why it gives an advantageous position as compared to the other IOL. So low light performance. So our experience that I have used nearly 73 patients who have undergone synergy IOL implantation, and most of my patients have been very happy vis-a-vis compared with many other trifocal lenses. Just to complete my presentation, just 10 seconds of video, that loading is also very smooth, and implantation of the lens is very smooth, so there is no problem with as such. And one advantage of this lens is also that it is glistening free also, so this is, in that way, it is better than many other lenses in the market available. My patients have been very happy with the lenses, with these lenses. So just to summarize, what is different in this lens? It combines the multifocus plus the EDOF technology to give continuous range of vision. It blocks the violet light also, so there is less scattering or halos. It is independent with the pupil, and the chrome aligned technology enhances the image contrast across the range of vision, far, intermediate, and near. So thank you very much.
Hello. Thank you, sir, for your nice lecture. Any question from the audience side?
Sir, a question. Sir,
वही लग रहा है, तो इसके बिना कैसे होगा पूरा?
as it is 55 centimeter is the intermediate, the vision, the distance which it was claimed by the Technic Synergy lens. Do you find it suitable for Indian subcontinent?
अब जैसा पेशेंट को बताओ वैसा वो खुश रहेगा. It doesn't depend, and from my heart I would say that कोई भी लेंस इंडियन इंपोर्टेड कोई भी, आप जैसा पेशेंट को कन्विंस करते हो वैसा ही होता है. It doesn't matter much, all the lenses are equally good. There are some differences which I don't think we are able to clearly analyze with our Indian patients, but most of the lenses they give very good results.
Indian patients have a small working distance, and the larger people, taller people have a large distance. That's why.
ठीक है, यहाँ भी बहुत अच्छा ही काम करता है. I have not compared, I have individualized, but I think that most of the patients are happy.
Thank you, sir. There is some change. Dr. Madhulika has her important work, so she would be the next speaker. Dr. Madhulika, please. Our next speaker is a very eminent person, Dr. S.K. Rungta, sir, who will deliver some important lecture.
My talk is preservatives in ophthalmology. No financial disclosure. This is not a research paper. This is just a theoretical review. My aim is just to reacquaint all of us with this subject. Multi-dose formulation require preservation because when pressure of bottle is released after the first drop, there is suckback. And this suckback of unreleased drop or air may lead to contamination. तो बहुत इजी है कि या तो मल्टी डोज फॉर्मुलेशन से हम लोग यूनिम्स पे मिनिम्स पे आ जाएं जिसमें कि सिंगल डोज रहता है, बट दिस इज़ एक्सपेंसिव, इतना आसान नहीं है. तो दिस इज़ द पॉइंट वेयर वी नीड something to add to prevent contamination. Preservatives are important additives in topical ophthalmic medications. These are crucial in maintaining sterility by preventing microbial contamination and extending the shelf life of multi-dose formulations. Nearly 60 years ago, preservatives were added to topical eye products to ensure optimum safety and sterility. 2 decades ago, ophthalmologists noticed that there is harmful effect of preservatives. What should be the properties of an ideal preservative? It's very difficult to achieve anything ideal, but they should prevent microbial contamination, should be non-toxic, non-irritant, non-allergic, should be effective at low concentration against all possible microorganisms. They should be compatible with all components of formulations, and ideal preservatives should be stable for the shelf life of the preparation. These are the common preservatives used in ophthalmology, but there is a long list. The common are BAK, polyquat, sodium perborate, pyrite, and softgel. Previously, mercurial preservatives were also used. Now these are banned all over the world. These may be classified into 2 main groups as far as ophthalmology is concerned: detergents and oxidizing agents. Benzalkonium, this BAK and polyquat, these are detergents. And other sodium perborate, pyrite, and softgel, these are oxidative agents. The most commonly used ophthalmic preservative has been BAK, and this has shown to cause ocular surface toxicity. This is more harming in cases of pre-existing ocular surface disease and if used for longer duration and in more frequent doses. This is more dangerous when there is severe dry eye syndrome from before, neurotrophic keratopathy, and limbal stem cell deficiency. In these conditions, the use of preserved drops should be minimized. There are limitations also. Preservative-free formulations tend to be more expensive than their preserved counterparts. And there are some issues in insurance coverage also. They do not cover the costlier alternatives. BAK is most frequently used ophthalmic preservative in approximately 60 to 70% of topical ophthalmic formulations. This is effective broad-spectrum bactericidal agent, hence synergistic effect. This is used in concentration from 0.003 to 0.02%, but the threshold concentration is 0.005%. That means below this, there are less chances of side effects. And this is relatively stable, can be sterilized by autoclaving also. This has got both hydrophilic and hydrophobic property. Enhances drug penetration into the eye. This BAK acts as detergent because of this hydrophilic and hydrophobic both properties. This acts as detergent for the lipid layer of the tear film, thereby increasing evaporation of aqueous part, resulting in a dysfunctional and unstable tear film. This is the cause. This disruption to the corneal barrier may contribute to the ocular surface toxicity. This is an effective biocide and is essentially innocuous when used for short periods and in low concentration in otherwise healthy eyes. But the ocular sequelae of long-term BAK use are sometimes serious. Its toxicity is related to its concentration, frequency, and duration. Second is polyquat. This is commonly used in contact lens solution and also in artificial tear formations such as cystine. Its large molecular size and hydrophilic nature makes it safer for mammalian cells. This sodium perborate is another, and this is probably the first oxidative preservative. It acts by forming hydrogen peroxide when combined with water, thus giving it potent antimicrobial properties. It is an effective bactericidal agent with action against bacteria, viruses, and fungus. Once this sodium perborate is applied to the ocular surface, existing conjunctival enzymes such as catalase rapidly decompose it to oxygen and water, limiting its cytotoxicity. This pyrite is also another oxidative preservative with effective antimicrobial efficacy on contact with ocular surface, converts to natural tier components including sodium and chloride ions, oxygen and water, hence less toxic to mammalian cells. This is SoftJ is a proprietary preservative being used by Novartis in Trabertan gin. It is an oxidizing preservative and this is much safer than BAK. So what can be the future formulations? Preservative free, either you use this or single daily dose formulation, so the frequency is decreased, use of other less toxic preservatives, lower the BAK concentration and take care of pre-existing OSDs. US FDA says, just a minute, US FDA says that all solutions for surgical use should be sterile and prepared without a preservative because of danger of chemical damage to the inner structure of the eye. An injured eye has less resistance to infection. Hence, BAK type of preservative should be avoided in pre-existing OSD or injured eye. These are the references. So the take-home message is take care of pre-existing OSD to prevent side effects of preservatives, avoid casual topical ophthalmic medication. जो कुछ भी प्रॉब्लम नहीं हो तब भी हम लोग ड्रॉप्स जो लिख देते हैं उसको धीरे धीरे अवॉइड करना पड़ेगा. Frequency of drops as per need, short-term topical medication, preservative-free formulations, and use of newer and safer preservatives in low concentration. Non-BAK preserved formulations are being preferred. Thank you.
Thank you, sir. Any questions from the audience?
Thank you.
Thank you. I think Dr. Satyajit sir is here. Dr. Anita is also not here. Dr. Ranjan Rai sir. Sir will be presenting on role of Nepafenac in pain and inflammation management.
कैसे चलेगा भाई? इधर आओ. बढ़ेगा कैसे? अपने आप को. वापस. Good evening. This is again a sponsored talk by JB Pharmaceuticals. Role of Nepafenac in pain and inflammation management. My question to audience, how many number of bottles you people are giving after cataract surgery? 1, 2, 3, 4 or 5? My question to audience, how many bottles of eye drop you people are giving after surgery, cataract surgery? 1, 2, 3, 4 or 5? So most of the people are with the 3 eye drops. What are those eye drops? Steroid, antibiotic, and third one is lubricant. So audience is in favor that NSAIDs has no role after cataract surgery. Am I right? Yes. So now house is divided. So some disclaimer is there, and of course, cataract surgery creates inflammation even in the best hands. Agree or disagree? We are going to break down the blood aqueous barrier at minimal level. So this is going to give the inflammatory reaction in the anterior chamber, and its sequelae after that if it is complicated one. So here is the role of Nepafenac or NSAID in cataract surgery, this is my suggestion. Lot of study has been done, and it's NSAID alone versus corticosteroid with NSAID, and the result is equivocal. Rather, few studies says that NSAID cases having less flare. It means it works on stabilizing the cell membrane. So you can see in this data, there is one term called posology, P-O-S-O-L-O-G-Y. Do you know the meaning of posology? Anyone? It is the branch of medicine which decided the dose and schedule of that particular molecule. So this is very important when you are considering the drug adherence to the patient. So NSAID in coming future is probably going to replace this corticosteroid after cataract surgery. So many surgeons are now replacing corticosteroid after cataract surgery. And so, for PG, what is the difference between suspension and solution? Anyone from postgraduate side? What is the difference between suspension and solution? Which one you would like to go with, suspension or solution? Of course, it should be solution because it is going to absorb well and it is not going to create any ocular surface disorder. So almost all the NSAID eye drop, including Nevanec or Elevro, is in suspension form, though they claim that it is micro suspension. Even this is one of the disadvantages of this molecule, that it is going to get deposited in the lower eyelid and patient feel irritation. So while you are replacing the corticosteroid, you have to add lubricating eye drop. So this is one thing. So NSAID is powerful post-operative pain and inflammatory controlling molecule. It's unique prodrug formulation. And increased retention time is because of its suspension. And that retention time is going to enhance bioavailability. Dosing schedule is once a day. So normal regime is 1 drop applied by and they have added guar gum to increase the retention time. And various studies proven that this NSAID nipepinac is efficacious in post-cataract surgery. Once a daily nipepinac was well tolerated by patients. And these are the references. And this is my last slide. Thank you very much for your patience listening.
Thank you, sir. Phaco, in pseudo exfoliative eye, big challenge. So let's see from the expert. That is none other than Dr. Satyajit Sinha, sir.
So, a very good evening to all of you. I'd like to congratulate the organizing committee for organizing a wonderful conference, and I'd like to thank the scientific committee for giving me this opportunity. As we are advancing in cataract surgery, our expectations are the same regardless of which section of society you are serving. Everybody wants that I should see distance and near properly, and therefore the demand of these premium IULs are rising day by day. So many complications are there in between which the patient doesn't really understand, and we have to take care of them. The best and the most beautiful things in the world cannot be seen or even touched. They must be felt with the heart. What I'm trying to come to is the zonules which are there behind the iris. You cannot see them, and in pseudoexfoliative glaucoma and pseudoexfoliation syndrome, the zonules behind the irises are weak. You don't see the zonules, you don't know its status, you really don't know what you're dealing with. So the bottom line is that you don't leave the bag without a CTR. I was presenting this and a little different version, and Dr. Pranav Ranjan sir, who is sitting here, he said, for every case this is true, not only for premium IOLs, and I totally agree with him. But the expectation of the patient is so high that even in the beginning, if there is a slight decentration in your premium IOL, the patient will have a lot of problem. The same is not true for monofocal IOLs. For monofocal IOLs, even if the zonules are becoming weak over the years and those finally outcome, if there's decentration of IOL, it will take many, many years. But even if there's a slight decentration with the premium IOLs, with trifocals, with EDOF lenses, the patient will be behind your back, troubling you, that the patient is having more problems than he was expecting. So several studies have shown that the entire IUL bag complex descends in the vitreous many years after the surgery, especially in cases of pseudoexfoliation where adequate support techniques were not used. Several reports have shown that CTR implant reduces intraoperative complication in pseudoexfoliative eyes, suggesting the use of the device in case of mild zonulopathy and phacodonesis. It's very important that when you're doing these cases, as soon as you see pseudoexfoliative material, a gonioscopy is must, the optic nerve evaluation is important, but it's also important to evaluate the patient from the point of cataract surgery. Now, we are dealing with one of the most dreaded complications which can happen, especially in pseudoexfoliation, which is IUL will be in the bag and it will get dislocated, and that can happen after 6 months, 1 year, or 5 years. It's really very difficult to predict. So what is actually happening? The weakened zonule apparatus, zonulopathy, is secondary to a progressive proteolytic disintegration of the suspensory ligament. So regardless of what you're seeing on that day, this is progressive in nature, and at some point of time there may be some tilting, there may be some weakness, there may be some decentration, and there may be total dislocation also. There is capsule rupture also, and there is zonular dialysis, for which you have to be seeing on the slit lamp carefully if you see any lens dehiscence. The degree of zonular laxity does not strictly correlate with the amount and extension of pseudoexfoliative material, but it's related to the age. As many years have passed, the zonules, you have to presume that they'll be more weaker and weaker. Typical signs of zonular weakness are phacodonesis with eye movement. So when you see this pseudoexfoliative material, ask the patient on your slit lamp to look up, look down, and see if you're seeing any phacodonesis. And sometimes the reduction of the anterior chamber depth due to a forward shift of the lens. There is increased weakness of the zonular apparatus. There is limited pupillary dilatation in some of these cases. There is a higher risk of vitreous loss. And we have to keep ready in the OR all these things, the viscoelastic devices, the iris refractors, the ring dilators, and especially the capsule tension ring, and to reduce the risk of intraoperative complications. All these have to be ready from anywhere from CTR to Sionis ring. All the things should be in the OT. Once you have a little tilt and then you ask your OT assistant and he says it's not there, then life will be more difficult. There are higher chances of vitreous loss, nuclear luxation, bag decentration, and dislocation of the IOL with time. Though the CTR makes it difficult, surgeon must use a capsule tension ring to support the capsular bag during the cortical cleaning and IOL implantation. Now, once you have put the CTR, it sometimes becomes very difficult to remove the cortex, but tangential stripping in combination with gentle centripetal traction should allow accurate cortical removal. In case of extensive zonular dialysis, more than one device may be employed, because even when you're removing the cortex, when you're using your aspiration handle, once you pull the cortex from the capsular bag from the equator, that also will hurt the equator and make the bag even more weak because you are pulling the cortex over there. The capsule retractors help support the zonules complex in the anterior-posterior direction and facilitating hydrodissection and cataract fragmentation, while CTR allows even distension of the capsular bag, supporting areas of zonular dehiscence by redistributing. So we are talking about putting iris retractors also, and we are talking about putting CTRs also, which makes it even more safe. The choice of IOL to implant in pseudoexfoliation patients related to the evaluation of the state and future risk of capsular instability. Also inform the patient, especially when you are counseling, that such a thing can happen and that the IOL may have to be changed at a later time. In presence of zonular weakness, following a CTR implant, a one-piece or three-piece acrylic IOL may be implanted according to the surgeon's preference, and IOL capture is also a good idea where its unpredictable future instability can always be an issue. Also keep in mind that you are using a high molecular viscoelastic because the endothelial cell loss is more in such cases. And remember using NSAID, what Dr. Ranjan sir was saying, because there are higher chances of CME in these patients. Thank you so much.
Any questions from the audience?
So, Dr. Satyajit, I mean,
wait, shoot.
We could make out that you are telling that in the premium IOL cases, with pseudoexfoliation, we should definitely put CTR in all the cases?
Absolutely. Yes.
Why not?
In fact,
okay, wherever CTR required, supposedly, if there is a zonular dialysis observed during the surgery, or you want to put a CTR in all pseudoexfoliation cases just in anticipation that there will be zonular disintegration later on, that's why you want to put it in CTR.
That is the whole message which I am trying to give through this paper, that it's a progressive.
So that means you are bothered about the decentration in
Absolutely.
cases of premium IOLs.
Yes.
Why don't we counsel for monofocals in these cases?
Because once you are seeing it's not necessary that it will happen. It's not that 100% of the cases who have pseudo-exfoliative will dislocate.
Won't it be better that we counsel the patient for monofocals, anticipation?
You can always counsel the patient that we are putting a premium IOL, but such a thing can happen after 4 or 5 years or maybe never. So at that time, we may need to change your IOL if there is any decentration. But for every pseudo-exfoliation patient, he is not eligible for a premium IOL is not true.
No, for that only I am telling, to keep your peace of mind, why not counsel the patient for a monofocals, those kind of patients?
Because what you're saying is true, but slowly over a period of time, all the patients will be asking for premium IOLs, and the patient really doesn't understand what is happening. At that point of time, he wants the best of the lenses.
I have one query. The course of pseudoexfoliation, it varies in geographical locale. The kind of pseudoexfoliation we see in South India, which has relatively warmer climate, and what we see in North India, there is a difference in the pattern, the course of pseudoexfoliation. So how do we justify this empirical suggestion?
Are you referring to any study which has been done in the entire North India saying that pseudoexfoliation takes longer, the progressive proteolytic zonulysis takes longer in South India and takes shorter time in North India?
Pseudoexfoliation cases we have seen over more than a decade in Tamil Nadu. It's entirely different than what we see here in North India.
Has any study, I can understand that in Arvind's study must have been done, but has any study been done in North India?
It's quite obvious thing. It's quite obvious thing. In warmer climate, you will get those kind of thing. So there is a geographical variation in the progression, the aggression, aggressiveness of the pseudo-exfoliation. So saying this empirical statement for all the pseudo-exfoliation cases,
So you're saying that all the cases in South India should not be offered premium IOLs because the zonulolysis is faster over there?
I'm not talking about the premium IOL only. I'm talking about the prophylactic ECR placement.
And that way, one day the whole IOL bag will come down, so you put SF IOL from the beginning only.
If it is not that, it is not aggressive. I'm not saying you should not put premium IOL. What I am saying, how the granulopathy will progress leading to decentration, that varies in different geographic locale. That I am saying.
How does that affect that individual patient? It's very difficult. You cannot say in South India there is more probability of a faster zonulolysis, so we'll not give you a premium IOL. If you were a North Indian, I would have put premium IOL for you.
It's more prevalent there.
That I understood. That point is taken.
That is why I am saying.
But that again, it cannot be generalized for all South Indians.
There will be pseudo-exfoliation.
We'll go on for the next.
Anyway, over to chairperson.
We're running short of
And
time.
another moot point would be, what if the bag along with the CTR dislocates later on in
And
life?
then we
How do
always have
take it out?
Satyaprakash Tiwari
That's
here.
another thing to talk about. But let's go on to the next speaker, please.
Thank you.
Madam, your baby has good eye, but he can't see. He doesn't have any pathology, but he can't see. We can't do anything. It is very hard to digest. So, don't worry, Dr. Taranum Fatima madam is there. She will talk about amblyopia, research development.
Good afternoon, everybody. Today I am here to discuss recent advances on amblyopia management. The word amblyopia is derived from the Greek word amblyops, means blunt, and ops means sight. So it means blunt vision. It can be, practically we see three most common types of amblyopia we see are anisometropic, strabismic, or deprivation. It can be unilateral or bilateral. If unilateral, there has to be a difference of 2 lines between the eyes. Amblyopia studies are now more based on the neuron level. Anisometropia is, in anisometropia we see loss of neurons, sensitive to fine details, and in strabismus we see more of binocular cortical neurons loss. In cases of unilateral amblyopia, there is imbalance in the image quality between the two eyes. Because of this imbalance, the 3D vision is affected. This mismatch in image quality is also associated with frequent suppression of central part of the vision. In isometropic amblyopia, typically contrast sensitivity is affected. In strabismic amblyopia, there is a crowding. And one more very important thing is that, in higher order deficit, there is hand-eye motor coordination deficit is there. So this is very important when we are dealing with these therapies. So what is the critical period? Is it less than 7 years? Is it less than 12 years? Is it less than 15 years? Everybody is confused. So the development of functional architecture of the visual cortex occurs in stages. Imbalance or disruption during this phase can profoundly alter the selectivity of neurons to visual input. It was long thought that treatment of amblyopia was only possible during this early critical period of visual development. But newer studies have challenged the concept of complete loss of plasticity in visual processing areas even in adulthood, though the quality of plasticity may vary from that of childhood. So we have seen even cases of 55-year-old recovering from amblyopia when the better eye was lost in road traffic accident. So the amblyopia treatment has evolved over time. And we can basically classify them into 3 parts. The first part, the glasses, patches, mineralization, and drugs. The second part is binocular training. And the third part, the new method in which we stimulate the magnocellular cells is the orthoptic treatment. The first step is the correction of refractive error by prescribing glasses. This is called as the optical treatment. We can go for optical treatment for the first 3 months. So if we are scared that our patient will get lost, or if then we can start patching also on the first go. The dose of occlusion depends on the severity of residual amblyopia. Pharmacological blurring of the better seeing eyes with 1 drop of atropine, 1% drops weekly is also recommended. The dose of patching is variable. It can vary from 2 hours to a full time occlusion depending on the severity of amblyopia. So what is the advance in patching? The smart glasses. So what are the smart glasses? These are LCD glasses and it has got some mirror coating from outside. So the patient, the person who is seeing the child doesn't know that he is actually occluding his eye. So there is a small button on the these glasses. So when you do this, put on this button, then that glass will occlude, and then visual task like putting beads into the bottle is being given to the child. So the battery life of these glasses is like 3 to 4 days. So can medications enhance the treatment of older children with amblyopia? Yes, they can. Levodopa has been shown to have a proven role, and dosanepil, that is a drug for Alzheimer, is also being studied. It is in phase 1. Then also there is role of omega fatty acids, and anything that is neuroprotective can be, diet which is more neuroprotective can be given in these children. So where does the management start? Does it start with treatment, or does it start quite early? Catch them young. That is my only saying. Catch them at the age of 4 to 5 years. You have got 2 years, you can manage them. So most of the developed countries, they are having very intense this screening program, and they are targeting the preschool 4 to 5 years, not school going. So after school, if they become 7 years, it becomes very difficult. So this is a map of UK, and they are doing very good screening. And this is, we are in Bihar. And Bihar, I don't think there is any screening program. I don't know. They can actually add the screening program, utilize the PHC staff to do a screening level at district level in future. But at Akhand Jyoti, we have got this 35 vision centers, and they are doing very aggressive screening. And they are using this Anganwadi school. So one thing you must see that Anganwadi schools usually have 4 to 5 years kids. And we are using this very nice photo screeners, autorefractometers, and
Screener emits the sound of chirping birds. This sound is intended to focus the subject's attention on the device. The subject results screen appears at the end of the screening.
Very easily. So you can also use this, and if it is not possible to use these devices, then you can use a retinoscope also for screening. It is very easy.
Screener emits
The next thing that is a burning topic is, should surgical management of strabismus be done before amblyopia treatment, or should it be done after amblyopia treatment? So the answer is the surgical management should be done after amblyopia treatment, because that will ensure that and the surgery after vision usually stabilizes. So can treatments be developed that are more effective for and more child-friendly than current treatments? So what we know is patching, and patching is gold standard, but the recent studies have shown that the occlusion is typically less than 50% of the dose. So adherence to occlusion, if it is less, then how can we treat amblyopia? So we have to go for this non-patching techniques also. And one of the most important techniques which also have been done, discussed in previous sessions, is the dioptic training which is being given. This is the binocs.
Dioptic therapy, a contrast-adjusted stimulus, is presented to each eye, with the better eye getting the stimulus with reduced contrast. It promotes development of binocular vision by reducing inhibitory interactions and suppression within the ocular dominance.
So if the patient is not able to afford binocs, then he can go easily for this amblyopia gain, which you can give them on the Android phone. And you can also buy these glasses which are readily available at Amazon or Flipkart. The other important techniques are the balanced binocular viewing and the eye bit system. And now coming to the orthoptic, which is another very unique technique which has been developed by Dr. Santan Gopal, and now nearly 85 centers in India is having it. It is a top-down stimulus coming from the parietal lobe, and it has got two parts of stimulation. There are row of lines, and the patient has to follow all the lines. There are two parts, the cohort attention and the overt attention. So it is a very unique thing that the hand-eye coordination is also improving in this. And I've seen recovery like from counting finger to 6-9 within 10 to 12 days using this device. So it is office-based, you can monitor it. And especially we will also be doing research on this because we are seeing that kids who are more intelligent and those who have got better IQ, they are performing very well on this device. So with this, I come to an end. To conclude, every case of amblyopia, like every case of cataract, should be considered as a different case. But we have to keep different tools in our armamentarium. Treatment will depend upon the age of the patient, the type of amblyopia, the degree of amblyopia, and the social background. And we should ensure that regular follow-up of these cases are done. With this, I come to an end. Thank you.
Thank you, ma'am, for elaborated talk on amblyopia. Any question from the audience?
Very nice presentation, Dr. Zranu. Yeah, I just wanted to know that patching which you give, it is for minimal 3 hours or it's customized according to the density of amblyopia?
It depends upon the age of the child, on the grade of amblyopia. Also, whether he is able to read 612, whether he is able to read 660. If it is like 660, counting finger, I'll give like full-time occlusion. And it will also depend upon whether he is school going or whether if it is summer holidays are there, then I'll tell the parents that you go for full-time occlusion for 15 days or maybe 1 month, you can do it full-time. And especially in severe cases. But if it is like 2-line difference or vision is 612, 6-9, then I'll give it 2 hours. So it depends on patient-to-patient basis.
Thank you very much.
Talking to me and looking towards the London. So
Ajit
our
was
next
asking
speaker.
something. Ajit was asking. Ajit, you wanted to ask something?
Yeah.
Sorry, ma'am. So basically, I wanted to ask you this that you told us that using orthoptech, you found a difference of counting fingers to 6-9, almost in 10 to 12 days. Won't there be chances of relapse in these cases? Because the faster the change in the visual acuity, the improvement in visual acuity has been
This
shown
is a very good question that you have asked. Actually, when we are using orthoptic, our aim is like to reduce the whole patching game. We don't want the kids to like patch for a year and 2 years and get that 6-9 vision. So basically, if you are even using orthoptic, you get that vision, you don't stop patching. You tell them you keep on patching for 1 to 2 hours and keep coming to me. So if they come, she is still coming now, and now she's like 6'5", she's reading. so it has, if you keep them in regular follow-up, and patching is always there. But
so
you have to add on these things.
So it supplements the effect.
It supplements, it is like an adjunct to patching. It improves the result of patching. And the children who are not able to patch, they do very well with these games and all.
Thank you.
And again, later, weaning from patching is another ball game, okay? So you don't stop patching all of a sudden. You have to monitor really and while you wean the child from patching.
So please welcome Dr. Amit Kumar for his talk on squint.
Good evening, everyone. I am going to have a talk on comitant esotropia, how to approach the case, and what are different management options. So I'm not going into detail the classification, but you should know that comitant esotropia, that means the deviation is similar in all the cases. And in comitant, the deviation is different in different cases. Now coming to the earliest esotropia which we come across, that is the infantile esotropia. By definition, the onset is always before the age of 6 months. It is large angle esotropia, more than 30 diopters. Cross fixation is present. That means object at the left is seen by the right eye and object to the right is seen by left eye. There is no significant refractive error accounting to the amount of deviation. There is no associated neurological deficit. It may be associated with IO overaction, nystagmus, and DVD. One thing you have to remember, it is to be differentiated from bilateral six-nerve palsy, which can also be seen in congenital cases. So how to differentiate? You can elicit doll's eye movement or you can patch one eye, alternately both the eyes, and look for the abduction. If the abduction on patching is complete, the cross fixation is neglected and you can easily rule out sixth nerve. Infantile esotropia should be operated at the earliest, but you should be confirmed of the diagnosis and the deviation and associated overactions. Measurement from limbus is preferable if you are operating on a case of up to 1 year of age. Ideally, infantile esotropia should be operated by the age of 2 years and preferably at 1 year. Prefer alternate patching of eye from diagnosis till the period of surgery, because if you do not patch, there may be contraction of the medial rectus and the FDT will be tight and you may land up in additional problem during surgery later on. So we can see here preoperatively there was infantile esotropia. We did bilateral MR recession. Bilateral recession, MR recession is preferable in infantile esotropia because of the good cosmesis, because of the reversibility, and because many times MR may be tight. That's why bilateral MR should be operated. Now coming to the accommodative esotropia. There is a term normo-accommodative and there is a term hyper-accommodative. What is normo-accommodative? Whenever the AC by A ratio is normal, that is called normo-accommodative, and whenever AC by A ratio is more, it is called hyper-accommodative. So the term now is refractive normo-accommodative esotropia. So there is refractive error, and so there is esotropia for distance, but since the AC by A ratio is normal, there is no near distance disparity. In this case, we have to give glasses for distance, and we have to give accordingly full cycloplegic refraction. Now coming to refractive hyperaccommodative esotropia, there is refractive component, so there is deviation for distance, there is high AC by A ratio, so the deviation for near is greater than that for distance, and it is usually more than 15 diopter. Despite correcting refractive error, there is still esotropia remaining for near in these cases. So how to proceed? You can give bifocals. Bifocal, the upper part will keep care of the refractive component and the near ad will keep care of the hyperaccommodative component. Nowadays, progressive glasses are also being used. Refractive correction for, the second option is refractive correction for distance and Fadden surgery of medial rectus for near. So this is the case where, this is a case of refractive hyperaccommodative esotropia where we have prescribed bifocal and the eye is ortho, both for distance as well as for near. Now coming to non-refractive hyperaccommodative esotropia, there is no refractive component, so the deviation for distance is nil, while due to high AC by A ratio, there is near esotropia. So how to proceed? You can give near ad glasses for esotropia which is persisting at near, or you can do posterior fixation suture for medial rectus. Here we can see for distance there is no esotropia, but for near there is esotropia. So we have two options in this case. We should have given near ad to this boy, but he was not preferring any glasses. He said he will go for surgery, and so we did the Fadden surgery, and post-operatively the deviation was, there was no deviation for near as well. Now coming to the partially accommodative esotropia. Partially accommodative, whenever there is residual esotropia despite full correction or giving bifocal glasses, it is known as partially accommodative esotropia. In any case of non-accommodative component or non-accommodative esotropia, neuroimaging is mandatory and the surgical correction is to be done for non-accommodative component. You can correct the accommodative component with glasses or Fadden surgery. Now this is case of partially accommodative esotropia. There was esotropia for distance which was partially corrected with glasses, but still on glasses there was esotropia remaining. So what we did? We did And we can see here that left eye is dominant and right eye is isodeviating. So in squint, always go for the surgery of non-dominant eye. So we went for surgery of right eye, medial rectus recession was done, and lateral rectus resection was done, and post-operatively we can see there was small amount of isodeviation for distance which was controlled with glasses. Post-operatively 6 months, after 6 months also there was there was very little deviation for distance with glasses, without glasses, and with glasses there was no deviation. This was the case 2. In this we can see there is a small amount of deviation for distance which was not corrected with glass, and there was more deviation for near. We calculated and the AC by A ratio was more. So in this case we did bilateral medial rectus recession and Fadian surgery for medial rectus. And post-operatively the alignment was wonderful for both for distance as well as near. And now coming to the non-accommodative esotropia, always do surgery for the non-dominant eye. We can do bilateral surgery only when there is equal dominance and the surgery is done under GA. This is a case of non-accommodative esotropia. Left eye was dominant, and so we did the surgery of right eye, and the eye was ortho post-operatively. Now coming to a rare entity of acute acquired comitant esotropia. It is sudden onset comitant esotropia seen after infancy. It may be associated transiently with diplopia, but most of the time suppression is seen because it is the age of cortical plasticity. Historically, there are 3 classes: Swan type, which is predominantly seen after occlusion; Franchetti type, which is decompensated microtropia; and Bilchowski type, which is associated with high myopia. However, nowadays, due to excessive use of digital devices, we are seeing a more number of acute acquired comitant esotropia. So, as the Swan type, Franchetti type, and Bilchowski type are non-progressive, and so surgical correction yielded good result. But in the latest digital device type, we can use Botox also, because many cases have been reported in which after medial rectus recession, we are seeing consecutive exotropia. So better to go for Botox in these cases, and if the deviation after Botox still comes and the deviation is equal to the pre-operative or pre-Botox deviation, you can go for surgery. And there is also one sensory esotropia, which is due to diminished vision, particularly in the infant age group. So to conclude, cycloplegic refraction is mandatory in any case of esotropia. Look for near distance disparity and calculate AC by A ratio accordingly. Prescribe glasses for refractive part and near at for hyperaccommodative part. Fadian surgery can be good alternative for the hyperaccommodative component. Neuroimaging is mandatory in any non-accommodative esotropia. Surgical correction to be done for non-accommodative component. Thank you.
Thank you. Can you call the next speaker?
Our next speaker is Dr. Amar Kumar. He will be delivered lecture on pediatric orbital lesion.
Good evening, respected judges and my colleagues and my seniors. Today my presentation on clinical spectrum and outcome of pediatric orbital lesion. This study was conducted in Regional Institute of Ophthalmology, BHU, and Ayodhya Eye Hospital, Ayodhya, and some cases also reported from the IGIMS Patna. My financial disclosure is nil. Aim of study is to report the clinical radiological profile and the management outcome of various orbital disorder. Methodology: design prospective study and hospital-based observational study. Sample size is 186 consecutive case of pediatric orbital lesion. Study period is 5 years. And inclusion criteria is all radiological confirmed case of orbital mass. Lesion is lesion in patient with less than 16 years of the age. Exclusion criteria is those age more than 16 years of age, treated elsewhere, not willing to part of the study, case losing regular follow-up. And history taking is onset and duration, course and symptom and systemic disease. And clinical examination is a type of proptosis, palpation, pulsation and extraocular movement and vision, relative apparent pupillary defect and intraocular pressure measurement, and fundus examination and cranial nerve examination. Also a exophthalmometry. Investigation done on the convenient of the child, CT scan of the orbit and MRI of brain and orbit. We can do also a USGB scan, and we can also go for a venography and arteriography in hemangioma patient. And we can also do the blood investigation and bacteriological study for culture and sensitivity. Observational, my study show the 61% in male child and 39% in female child. There is a most common extraconal lesion is 63% and intraconal lesion is 18% and intermediate lesion is 18%. Type and location of lesion. Most common location is most common type is benign lesion, and the 30%, 34% is malignant neoplasm, and 23% is a non-neoplastic lesion. Location is most common is superonasal 43% and nasal orbit is 34% and inferior to the orbit is 21%. Frequency of benign lesion is most common is cavernous hemangioma 43%, dermoid lesion is 23% and lymphangioma is 9% and optic nerve glioma is 9%. Frequency of malignant lesion is rhabdomyosarcoma is 31% and secondary orbital malignancy is 12%, lacrimal gland carcinoma is 40% and lymphoma is 16%. Orbital retinoblastoma is 27%. Pictures show the orbital dermoid dermoid cyst, and other pictures show the post-septal cellulitis in child of the 2 year of the age. Most clinical presentation in my study is pain in 40% is 40%, and diminution of vision is 43%, and diplopia is 18%, and proptosis is 88%, and restricted extraocular movement is 82%, relative affluent pupillary defect is 32%. And conclusion, most common is dermoid cyst, hemangioma, orbital cellulitis, retinoblastoma, rhabdomyosarcoma are most common. Early diagnosis and appropriate treatment is mandatory for orbital lesion. Systemic review is mandatory for radiological management like CT scan, MRI, and USG ultrasonography, and fine needle aspiration biopsy and blood serology are important for confirmation of diagnosis and to determine the extent of the disease. Thank you for attention.
Thank you so much. So with this, we conclude this mixed bag session. So any questions from the audience? No. So we'll go on to the next session. Can I please call the moderator for the next session, Dr. Bandana Tiwari and Dr. Abhishek Kedia, to take over. Thank you.
One small announcement. All the certificates are kept near registration counter. There is a separate counter for all the mementos and certificates. So speakers and chairpersons, panelists, moderators, they are requested to collect their certificates from that counter, please.
Good evening, everyone. Today, now next session is case-based discussion. So I will call all the chairperson, Dr. Pooja Sinha, ma'am. Dr. Vibhuti, sir. Dr. Nilesh Mohan, sir. And Dr. Satya Prakash Tiwari, and our panelist, Dr. Rusmika ma'am, Dr. Dibya Kumari, Dr. Jyoti, Dr. Ranjan Rai sir, please come on das. Dr. Satyajit Sinha sir, please come.
बहुत लोग हैं
So without any delay, we will start our session. We have already late. So our next speaker is Dr. Satyaprakash Tiwari. Topic is breaking barrier in the management of AMD.
Thank you so much. At the outset, I would like to thank the organizing committee, scientific committee of POS for having me here. This talk is a sponsored talk from Novartis. So, So, breaking barriers in management of neovascular AMD. What is neovascular AMD? As we all know that as we are having one of the highest population burden in our country, we are facing the challenge of managing all these long-standing retinal disorders, especially who needs constant follow-up, regular follow-up and repeated injections. So that creating an economic burden on the individual, on the family, on the country, state, and that patient volume and that burden to be catered, burden is coming on all the retina specialists, be it surgical or medical. So always the target is to achieve the good compliance and reduce the burden of the patient on everyone. So as we know that always whatever studies has been done for all the drugs in AMD or whatever disorder, all the studies are done under ideal conditions where the patient are not losing the follow-up, they are getting the injections or treatment as per requirement of the disease. There is no financial constraint on the patient, so everything is going under supervision and proper care, and the results are excellent many a times. But that good result we are not seeing in our day-to-day clinical practice or real-world data. Why? Because here multiple challenges are there. Sometimes the doctor is not available, sometimes the patient is not coming for a follow-up for various reasons. There is nobody to accompany them. There is no financial support to get injection repeated on time. So all these factors play a crucial role in getting good outcome in real world data. So what is the solution? Can we get some ready-made protocol kind of thing that which reduces the burden on the patient, financial burden on the patient, and then that patient volume and that huge rush in clinics of the retina specialists who need to be taken care by a less number of qualified surgeons as compared to the volume of the problem. So this is all about the data of stress clinical capacity, and this survey are being regularly done from even our Vitreoretina Society of India as well as American Society of Retina Surgeons and all. And all these data do say that everywhere there is a huge burden as far as the regular follow-up injection patient is required. So an ongoing challenge is to maintain the neovascular AMD treatment efficacy while reducing the clinic visit. If we can reduce the clinic visit in a significant manner, then we are successful. So in that pursuit only, this single chain antibody fragment was developed by Novartis that is called as brolucizumab. This is single chain antibody fragment, and these are the smallest functional unit of antibody. This allowed delivery of greater molar dose of the drug. The dose is 6 milligram and greater number of molecules are available. So obviously the number of drug delivered to the eye is more. So efficacy and sustained effect is much better at compared to other drugs. So it happened that Hawk and Harrier trials were done to compare the efficacy or non-inferiority of this brolucizumab. So what happens in any randomized trial? Whatever new product is launched, that is compared head to head with the established protocol of treatment or gold standard treatment. That when ranibizumab was developed, that was compared with photodynamic therapy because PDT at that time was the gold standard for CNVM. Once ranibizumab replaced PDT and it became gold standard, further development of any drug, be it aflibercept or these biosimilars of ranibizumab or whatever, was compared head to head ranibizumab versus the new molecule. Now it was found that in along the many real world data publication, large number of data and studies, that aflibercept was little bit acting more longer than ranibizumab. And now the whole purpose of development of this new molecule brolucizumab was to compare the maintenance in a long-term basis as compared to aflibercept. So this drug was compared with aflibercept, head-to-head aflibercept versus brolucizumab. And there were two studies, Hawk and Harrier. In Hawk, there were 3 arms. The first arm was 3 milligram brolucizumab, the second arm was 6 milligram brolucizumab, and the third arm was that aflibercept 2 milligram. And in Harrier, it was 6 milligram brolucizumab versus 2 milligram aflibercept, head-to-head, only 2 arms. These were the multiple international sites, and a huge number of patients were recruited across the 408 study sites, and exclusion and inclusion criteria were just similar to any other study, like informed consent, age of the patient is more than 50 years, active CNVM without scarring, fibrosis, willing to participate in the study, no concomitant severe eye disease which needs recent surgery or continuous treatment like that. Those were the cases. An important criteria was intraretinal fluid, subretinal fluid affecting the central subfield, and best corrected visual acuity should be in between 78 to 23 letters EDTA. So these were the study, and these were the designs. And disease, one important point was taken care was disease activity analysis. And it used to be done at week 16, week 20, 32, 44, and later on at 56, 68, 80, and 92 weeks. So what was the disease activity assessment? Suppose first 3 doses were given. I think my talk had 10 minutes, so I have still 4 minutes left, so I will conclude within 4 minutes. So disease assessment activity had like decrease in BCVA more than 5 letters or decrease in BCVA more than 3 letters. Along with that, central subfield thickness increases more than 75 micron. And there were other criterias also. So how the study was done? In both the arms, like aflibercept or brolucizumab, 3 loading doses were given, and after that, the target was to reduce the interval between 2 injections. So aflibercept used to be given after 3 loading doses. Aflibercept regime was every 8 weeks. It means every 2 months you have to inject. So brolucizumab tried to wean off the patient at every 3 months or every 12 weeks. So 3 loading doses. After that, you do not inject at 12 and 16 week and assess at inject at 20 week, but assess at 16 week for disease activity analysis. And if a patient is deteriorating on the scale of disease activity analysis, then re-enter that patient into 8-week regime of brolucizumab. Because just to increase the gap of treatment, we cannot let the patient deteriorate and lose vision, lose significant amount of good vision. So assess at 16 week. If the patient is doing enough and it is not deteriorating on analysis scale, then keep them on 12-week dose regime. And if they are deteriorating, then re-recruit them into 8-week regime. So every 12 week, it means 3 month aflibercept was, brolucizumab was given, and every 8 week this aflibercept was injected. And these were lot of data and analysis, and these were not of significant importance. What I would like to stress here is that primary endpoint was non-inferiority of brolucizumab to aflibercept in terms of mean BCVA, and secondary endpoints were average change in BCVA, the presence of OCT biomarkers like intraretinal fluid, intraretinal cyst, subretinal fluid, sub-RPE fluid, disease activity status at week 16, change in central subfield thickness. These were the secondary endpoints. What we found that in almost all the data, 3 milligram brolucizumab was almost equal to aflibercept, but 6 milligram brolucizumab was faring better as compared to aflibercept in both the studies, either Hawk or Harrier. The red bar is for 3 milligram brolucizumab, the yellow is for 6 milligram, and the green is for aflibercept. So we can see that more number of letters were gained in brolucizumab 6 milligram. Again, that thickness reduction in the central subfield thickness, there was much better effect in brolucizumab 6 milligram. Again, these were the factors which were assessed as secondary endpoint: intraretinal cyst, subretinal fluid, pigment epithelial detachment, that can lead to vision loss. So in all terms, the more number of patients fare better in only 24% patients had these biomarkers in brolucizumab group, but 37% patient had these markers present in aflibercept group. So it was much better in both the cases, be it if you compared intraretinal fluid, subretinal fluid, or intraretinal cyst. So in all these biomarker status also, those were the secondary endpoint. The first endpoint of study was to non-inferiority in terms of vision, but the secondary endpoint were these biomarkers like intraretinal fluid, subretinal fluid, and intraretinal cyst, because if we leave these intraretinal fluid, subretinal fluid, and cyst, then later on they will lead to poor vision and diminution of vision and scarring of the macula. So in all terms, it was found that brolucizumab was maintaining better. And the most important thing observed at 48 weeks, it means roughly at 1 year, that around 50% of the brolucizumab patients maintained that 12-week regime, that after 3 loading dose, you can keep them on 12-week dose, that every 3 months you inject and they will maintain their vision. 50% patient at some point of the time, disease activity analysis, they failed and they were re-recruited in 8 weeks regime, that almost 50% patient had to take injection every 2 months in brolucizumab group also. But what was important, that all those patients who were given 3 doses at 4, 0, 4, 8 and assessed at 16, and the disease activity was less, and they received 12 injection at the a gap of 12 weeks, almost 80% of those patients continued to maintain maintain good vision with 12 weekly regime. So that was very important, that only initial after 3 doses, if my patient is maintaining good vision for an interval of 12 weeks, then that patient is going to maintain good vision at the end of 1 year or 2 year or 3 year with just 3 monthly doses, that is 12-week doses. And those patients who fared bad or disease activity was there, then out of those patients, majority had to take injection at the 2 monthly dosing, that is regime, that is 8 weeks interval. Yeah, just I am concluding. I think 1 or 2 slides is there. Yeah. So what we came to the conclusion after studying or analyzing these 2 studies, that brolucizumab was definitely superior to aflibercept at the end of 48 weeks, that is in primary endpoint. Long-term maintenance of visual acuity was much better. The BCVA was achieved. Enhanced control of disease activity was there. There was superior control on central retinal fluctuations, that is central subfield thickness, and there was extended dose regime, that almost 56% of Hawk and 51% of Harrier were maintaining Q12 regime of injection, and that sustained Q12 regime has given us little bit of leverage or independence from calling the patient every month and assessing them, doing OCT and seeing them and managing that large number of patients. So that was the message for the house. Thank you so much for your patient listening. Thank you.
Any query from our
Yeah,
side?
thank you, Dr. Satyaprakash. One thing which you may have missed out in these is the very less incidence of vasculitis, if at all, which is still something in the doctor's mind.
That vasculitis across the globe, what I think that everywhere it is reported in all the drugs where the molar dose is very high. Like in brolucizumab, we are injecting 6 milligram. Again, that new drug has come. Faricimab. That has reported much worse cases as compared to brolucizumab. Again, the dose is high. When I queried from that company, that I think, which company is Rose? So they told that no, they are not giving higher doses. Their anti-VEGF is just only 2 milligram, and that anti-angiogenic factor is 4 milligram. So there are two, that is combination of two different drugs. So molar concentration of one drug is not high, so it should not happen. But again, it is happening. Now we are waiting for the 8 milligram higher dose regime of aflibercept. That is supposed to work much better among all the drugs available currently. But again, the finger is crossed that vasculitis, risk of vasculitis cases, we might see more number of vasculitis cases with the use of 8 milligram aflibercept.
Yes, that is what I was coming to. My next question was the high molecular weight aflibercept which is coming. So that may have give some competition to brolucizumab. So we'll have to wait till we see a number of patients.
Dr. Satyaprakash.
Yes, sir.
What next after all this monoclonal antibody in management of ARMD?
See, not only retinal disorders, sir. In all the this branches of medicine, the world is moving towards monoclonal antibody. So monoclonal antibody is going to stay, and this is going to rule the market in terms of finances, in terms of patient care also. The only thing is that all the company or whoever is manufacturing or doing expenses on R&D, they have to focus on sustained efficacy. Sustained efficacy is the biggest challenge. If we get some technology, some device that if we inject one drug and it works for 4 months, 6 months, 1 year, then that is going to rule the market. So that is there, and monoclonal antibody is going to stay. More and more number of diseases are being taken care by the development of these monoclonal antibodies. And in many cases, not only intravitreal, even subcutaneous or intradermal, many monoclonal antibodies we have started using in uveitis also, and the results are good. In cancer therapy, the monoclonal antibodies are becoming the backbone of treatment. So we have to live learning and using this monoclonal antibody for the betterment of the patients and society.
What I have read recently for Alzheimer's, there is an article, they are using this quantum energy to treat the Alzheimer's. And they are saying that any degenerative disorder, that quantum energy is going to change the telomere of that chromosome, which is expressing the disease per se. Is there anything new in this ARMD cases? Is there any genetic predisposition? If yes, then is the people are thinking on that line?
Definitely, sir, for any treatment management, even research and development also, there are always simultaneous parallel two wings working. One is focusing on the development of newer treatment, and another is focusing on the prevention of that disorder. So all these things are being done, and in all those epidemiological studies of AMD also, it was detected few genes, and people are working on that. And definitely if the quantum energy is working for Alzheimer's, they must work. But how to utilize that energy, and these questions are actually future is going to answer. As of now, we are not very much like aware about all these things. Future is going to answer this question, I think.
My concern is how many injection, how many years? This is important thing to answer.
My patient asks that you have to be in follow-up lifelong, you have to take injection lifelong. Very rarely you are going to stop injections. It happens, one of my patient has taken more than 150 injections. So that old lady, and now she doesn't want OCT also. She comes that, sir, injection de dijiye, injection laga dijiye. So it also happens like that, and sometimes patients are fed up with 1 or 2 injections also.
Dr. Satyaprakash, last question.
Yes,
regarding the vasculitis part.
Yes, sir.
Any high-risk patients, when to look for those
Definitely,
vasculitis?
sir. All those patients who are having history of uveitis, vasculitis, any autoimmune disorder, they are being considered as high risk. And if you see some cells flare, mild vitritis in any of your patient that resolves with topical steroid or systemic whatever, then exclude that patient from these drugs. You choose alternative drug, because giving second injection will flare up that situation, and that will create more aggressive reaction in those patients.
I think just the last take-home message that you should take is, when you are using brolucizumab, there is no need to give monthly regime. You can give one injection, you can review the patient every 1 month, and maybe the second injection may not be required, or may be required after 3 or 4 months.
Yes, ma'am. And to our surprise also, many of my patients have taken 3-4 brolucizumab in last 3 years, and after that they have never recurred. So that is also a very good thing, that just 3 brolucizumab, and after that they are in follow-up, but there is no relapse recurrence, and they are not taking injections. So they are off injection also.
Thank you.
Next speaker, Dr. Devkant. His topic is vectis-assisted removal of dermoid of anterior and mid-orbit. Please come, Dr. Devkant.
Good evening, everyone. My topic for discussion is vectis-assisted removal of dermoid from anterior and mid part of the inferior orbit. And I have chosen transconjunctival route. There is no financial interest. Dermoid is the most common pathology, accounting for over 40% of all orbital lesion and almost 90% of all orbital cystic lesion of childhood. Its usual site of involvement are subcutaneous tissue of periorbital area on lateral side of the eyebrow. Intraorbital dermoid are very rare. A small asymptomatic cyst do not require treatment. It may stabilize by its own or even may decrease in size over years. If symptomatic, then the main stay of treatment is complete and total surgical removal. This is a photograph of a 14-year male showing presented to us with complaint of painless swelling of left lower eyelid for 8 years. On examination, there was swelling of 3 to 3 centimeter size, globular, palpable cystic mass with a smooth surface near middle side of the left lower lid. It was free from skin and orbicularis, and it was reducible, extending to inferior orbit, producing superolateral dystropia. His ocular motility was full, free and painless, and Laplace was negative with patent tear drainage system on syringing. CT was advised of head and orbit, and it was suggestive of loculated cystic lesion of this size, noted in extracorneal compartment of infero-medial aspect of orbit, awaiting lamina papyracea, medial rectus and inferior rectus. Excision biopsy was planned. Horizontal conjunctival opening done at inferior fornix with the help of Westcott seizure between 2 toothed forceps. Blunt dissection done with tenotomy seizure to reach up to the mass. 2 muscle hook was applied, one to keep aside inferior rectus and other to medial rectus. Desmar's lead retractor applied to pull lead for more exposure. Mass popped up anteriorly after gentle pressure. Removal of mass was done with wire vectis. It was initially dissection done with wire vectis because wire vectis is a traumatic instrument. It was then glided below the mass for its elevation. Removal of in toto mass done after dissecting all attachment fiber with Westcott seizure. Conjunctival suture done with 8-0 Vicryl. This is the video which is showing. For time purpose, I will have to move it faster.
ना?
This is first post-operative photograph of this patient showing mild lid edema with subconjunctival hemorrhage. Patient was advised antibiotic steroid mix drop. This is photograph of that patient on post-op day 28. Eyelid lid edema has subsided along with subconjunctival hemorrhage. Ocular motility was full free and painless in all directions. There is no restriction. His best character visual acuity at this time was 6/9 in both eye. It was as noted previously. There is no change after surgery. Complete removal is advisable to prevent the inflammatory fibrosis and in view of rare malignant change. Rupture of the cyst may lead to lipogranulomatous inflammatory reactions, recurrence, abscess formation, residual dermoid tissue may produce inflammatory reactions and later on orbitocutaneous fistula formation. Type of orbitotomy depends on location of the cyst. If there is palpable extracorneal mass of inferior medial orbit located anterior to equator, it is inferior anterior orbitotomy which is recommended. The traditional external approach are transcutaneous route, which is subciliary or infraorbital for inferior orbitotomy, and we can choose transconjunctival incision also through the fornicel side or through the bulbar conjunctiva. But bulbar conjunctival side is preferred for scleral tear repair and intracorneal lesion. So these are the complications which is more with transcutaneous route, that is increased incidence of lagophthalmos, ectropion, scleral show, visible scarring, lower lid retraction, and through transconjunctival approach, complications are orbital fat prolapse, prolonged chemosis, seminiferon, entropion. Eyelid malposition reported in subciliary group compared with transconjunctival injection was 42% in transcutaneous route and 0% in transconjunctival route. Transconjunctival lower lid incision is the best surgical approach for inferior orbitotomy, allow excellent surgical exposure with low complication rate and hidden scar. Hand over hand dissection technique has been suggested. Prior elevator has been suggested for release of attachment. Purchase of mask can be done with traditional round tip and a speculated fingertip. Speculated fingertip is preferred one. In conclusion, anterior located cystic mass of inferior orbit can be removed in toto through transconjunctival incision with minimal lid related complication, may have less chance of rupture with simple wire vectis. Wire vectis assisted removal may be a method along with cryo to purchase mass of orbit. Deeply located cyst may require advanced procedure. Thank you for kind listening.
Any query? Next speaker, Dr. Surbhi Sinha. Please come on.
Good evening, respected panelists and everyone present in the hall.
Before you start, I would just say the other speakers to be ready with the talk on the other podium.
My topic is ocular manifestation of Hurler syndrome. I have no conflict of interest and no financial interest. Hurler syndrome is, that is mucopolysaccharidosis type 1, formerly known as gargoylism, is an inherited lysosomal disorder caused by deficiency caused by deficiency of alpha-L iodinase enzyme, normally responsible for the breakdown of glycosaminoglycans. That results in the buildup of dermatan sulfate and heparin sulfate in multiple tissues, thereby compromising their function. My case report is a 17-year-old male patient who presented to IOPD with complaint of diminished vision and intermittent watering in both the eyes. On examination, his unaided visual acuity was 6/36 in both the eyes, with a pinhole correction of 6/18 in right and 6/12 in left eye. Aided visual acuity was 6/18 partial in the right eye and 6/12 in left eye. NCT showed IOP of 17 and 22, and AT showed an IOP of 18 and 26 in right and left respectively. On slit lamp examination, eyelids and adnexa were within normal limit. Cornea showed bilateral diffuse corneal haze, right more than left. Conjunctiva was normal. Pupillary reaction was normal. Rest anterior segment details were not visible because of the corneal haze. Dilated fundus examination showed a VCDR of 0.4 in right eye and 0.3 in left, and rest fundus appeared normal. Anterior segment OCT showed a central corneal thickness of 536 in right eye and 512 in left eye. Refraction had an hyperopic shift, giving an acceptance of +4 diopter spherical and +1 diopter cylindrical at 150, correction of 6/18 in right eye, and +3.5 diopter spherical, +1 diopter cylindrical at 180, giving a correction of 6/12 in the left eye. General physical examination showed that the patient was alert and active, vitals were stable, no pallor, no icterus, coarse facies, short stature, thick skin, short neck. Cardiovascular system S1, S2 was present with the ejection systolic murmur. Respiratory system had no added sound. Skeletal abnormality showed multiple bony deformities, restriction of the joint movement like elbow joint, short stubby fingers, flexion deformities of finger, contracture of all the distal interphalangeal joint, flexion contracture of elbow, and reduced arm span. Echocardiography advised because of the typical ejection systolic murmur showed rheumatic heart defect, mild MS, mild MR, mild AR, trace TR, thickened aortic valves and mitral leaflets. Left ventricle ejection fraction was normal, that is 58%. Diagnosis, genetic analysis was done. Dried blood spot samples were used, and assay for alpha iodinase enzyme was measured using the fluorometry method. The value of this assay was found to be 0.31 nanomoles per hour per ml, the normal range being 2.4 to 12 nanomoles per hour per ml, thus suggesting that the value of this enzyme is very low and consistent with diagnosis of MPS 1. Management, the treatment option for MPS patient include bone marrow transplantation and enzyme replacement therapy. Parenteral IDOA enzyme replacement is available that improves the respiratory and musculoskeletal performance, but its effect on the ocular complication is not marked. Bone marrow transplantation has shown to cause progression of corneal opacity, thereby suggesting that there might be an intrinsic factor at ocular level that escapes the enzymatic correction. So basically the option available for our patient from ocular point of view was penetrating keratoplasty. The patient was planned for optical PK of right eye followed by left eye. Patient was resisted for optical PK and is currently awaiting surgery. Further plan, the corneal button thus obtained will then be sent for histopathological examination and if required electron microscopy. Discussion, Hurler syndrome is a multi-system progressive disorder and multidisciplinary approach is needed for its management. It needs to be differentiated from other causes of congenital corneal opacities like sclerocornea, birth trauma, ulcers, Peters anomaly, congenital hereditary endothelial dystrophy, and limbal dermoid. Other systemic manifestations and genetic analysis is diagnostic and differentiates MPS from other causes. The most common ocular manifestation is corneal cloudiness, occurring because of the glycosaminoglycan accumulation in the corneal epithelial cells, stromal keratocytes, and endothelial cell. This may impact the size of keratocytes and cause irregular arrangement of collagen fiber and lamellae, leading to loss of corneal transparency. Glycosaminoglycan accumulation in the trabecular meshwork impacts aqueous outflow, causing elevated IOP. Measured IOP is, however, affected by thick and rigid cornea. The CCT measured in our patient is, however, normal, thus suggesting that the raised IOP was mainly because of the accumulation of gags in the trabecular meshwork. Histopathology examination shows disorganized collagen fiber with heterogeneous thickness and vacuoles containing fibrogranular material in the epithelial and stromal cells. Thickened and rigid cornea and sclera is responsible for the hyperopic shift because of the flattened cornea and decreased axial length. Choroidal folds may be seen in patients with high hyperopia because of the short axial length and thick sclera. Optic nerve atrophy because of compression from the thickened dura and sclera, and because of deposit of glycosaminoglycan in ganglionic cell layer. There has been a report on recurrence of host disease in transplanted cornea. Though from an ocular point of view, optical PK is the treatment of choice, studies have shown that it recurs in the transplanted cornea. In a case report published by Zofia Kolkedi, in vivo confocal microscopy revealed characteristic vacuoles in the basal epithelium and corneal stroma, 96 corneal transplantation. The study
Please
also
conclude.
showed that anterior segment OCT demonstrating hyperreflective opacity, superficial and deeper in the stroma, which was consistent with diagnosis of recurrence of host disease in the graft. This is a slit lamp photo of a transplanted cornea 96 months after PK, showing fine refractile lines in the corneal stroma. These are my references. Thank you.
Next speaker, Dr. Akansha Rani. Please come.
If the next podium is active, the next speaker can please load their talk so
Dr.
we can go
Naila
faster.
Aftab.
Good morning, everyone. My topic is extraocular cysticercosis with atypical manifestation of the medial rectus muscle. I am Dr. Akansha, Senior Resident, RIU. A 22-year-old male presented to us with a complaint of swelling, discomfort, and acute pain in the right eye for a period of 15 days. There was no history of trauma or any surgical intervention. Examination revealed a large subconjunctival swelling on a nasal speck with 2 to 3 centimeters. The figure 1, the conjunctiva over the swelling was grossly congested and saw a whitish discoloration suggestive of an abscess. There was marked mucopollulant discharge. A provisional diagnosis of subconjunctival abscess was made. The patient was started on a local and systemic antibiotic. Blood profile was unremarkable except for a neutrophilic leukocytosis. The orbital ultrasonography revealed an enlargement of the medial rectus muscle with a well-defined cystic lesion measuring 4 into 7 mm with an eccentric hyperechoic area suggestive of a scolex. The medial rectus muscle was not separately defined. The B-scan saw a low attenuating center surrounded by a thick enhancing peripheral rim inseparable from the medial rectus muscle, suggesting orbital myocysticercosis in the extraconal space. Result: the treatment with a combination of oral albendazole 400 mg BD or a 15 mg per kg per day and prednisolone 1 gram per kg body weight for a 15 days is given in the management of myocysticercosis. There is a marked decrease in the swelling observed and the patient reports symptomatic improvement. Topical fluorometholone 0.1 suspension was used in all to reduce the ocular surface inflammation. Conclusion: cysticercosis caused by a larval form of pock tapeworm Taenia solium is potentially harmful disease with a varied clinical manifestation. Most common sites involved are eye, brain, bladder, wall, and heart. Ocular cysticercosis can be intraocular or extraocular. We report an atypical case of medial rectus myocysticercosis in child which was managed conservatively. Orbital myocysticercosis is a relatively rare condition. The presentation of orbital myocysticercosis as an abscess has not been reported earlier. The etiology of pus in this case is not clear. The pus could have been due to bacterial superinfection, and the failure to isolate the organism may be due to the prior institution of the antibiotic therapy. However, it is difficult to explain how bacterial infection occurred in this absence of an external wound. The other explanation of a sterile abscess caused by inflammation induced by the leakage from the cyst. The unusual presentation of the cysticercosis, such as this in the orbit, presented a diagnostic dilemma. A high index of suspicion in the country as ours, where the condition is relatively more common, is necessary to diagnose these cases. The imaging technique provided the diagnostic serology ELISA test for cysticercosis had not proved helpful in our experience, which has been corroborated by the other country. Discussion: ophthalmic cysticercosis is broadly divided into intraocular and extraocular cysticercosis. The latter is more common, up to 86% in Indian population. Among extraocular cysticercosis, the orbital myocysticercosis is the commonest subtype. However, the subconjunctival is 3 to 86%, orbital is 7 to 59%, and the eyelid is 0 to 14%. Tissue may get involved in a descending order. Subconjunctival cysticercosis has been mentioned as an anterior extension of the cyst from the insertion of the extraocular muscle recti and the oblique. The extraocular cysticercosis can have myriad of the clinical presentation depend on the cyst stage, its size, and relation to the adjacent vital ophthalmic structure. Orbital myocysticercosis may guard various ophthalmic manifestations both clinically and radiologically. It may mimic preseptal and orbital cellulitis, idiopathic orbital inflammatory disease, optic neuritis, acquired blepharotosis, subperiosteal abscess, double elevator palsy, double depressor aneurysm, Duane retraction syndrome, and the Brown syndrome. Hence, the initial presentation may pose a significant diagnostic dilemma to primary ophthalmologists. The radiological feature may lead in case having cysticercosis cyst with atypical scolex. The fusiform or localized enlargement of the rectus muscle, absence of scolex, atypical location of the cyst, and severe inflammation are such scenario. There is a lacuna about the atypical presentation and diagnostic criteria of orbital myocysticercosis. Moreover, the subconjunctival or conjunctival cysticercosis has been mentioned as the unusual cases in the research article and the case report. Is this a my reference? Thank you.
Next speaker, Dr. Naila Aftab. Yeah. Please come. She is discussing on case discussion systemic association of congenital ectropion uvea.
Good evening all. I'll proceed with the presentation. So CEU, that is congenital ectropion uvea, it could be of congenital or acquired type. Acquired is seen more commonly than congenital variant. Acquired is seen in inflammatory condition where NVI occurs, which leads to pulling or ectropion of the pigmented posterior iris epithelium. So it comes anteriorly and we see the ectropion uvea. This is actually attributed due to neurocrystopathy, which is the developmental arrest of the MCC cells. And another, we can say, proof why it's a neurocrystopathy is that there is involvement of the molar muscle. Hence, all these patients have a small amount of ptosis around 2 mm. The other associated syndromes associated are neurofibromatosis, Prader-Willi, facial hemihypertrophy, Rieger's anomaly. These patients also have glaucoma because of open angle glaucoma and associated TM dysgenesis and changes in the gonioscopy, which is because of the anterior insertion of the iris root. So all these things leads to glaucoma in such patients, and these are since these are congenital abnormality, so we should observe these patients much more. So we have a series of 2 cases. First one was that of a 15-year-old male who presented with diminution of vision in the left eye with headache for the past 1 year, and he was already diagnosed with glaucoma in the left eye, was on topical bimatopros 0.01%, and in the image we can see he had a previous surgical scar of the cleft lip, and he had left-sided facial hemihypertrophy with left-sided ptosis and left-sided proptosis, which was measured on Hertels with 21 and 23 mm at base 110. Best corrected visual acuity was 6.6 and 6.9, and GAT it was 14 and 28. The anterior segment examination reveals the left eye had cripless smooth iris with nasally eccentric pupil and 360 degrees of ectropion uvea. Vertical coverage ratio of the left eye fundus was 0.8:1 with inferior rim thinning, and right eye fundus was within normal limits. So the patient had fluctuating IOP even on maximum management, hence he was planned for trabeculectomy with mitomycin C. After the surgery, he maintained good visual acuity of 6/6 and was maintaining target IOP. These images shows a posteriorly directed elevated bleb and patent ostium, even after 6 months of the follow-up. The second case is that of a 27-year-old female who presented with severe diminution of vision from the right eye for the past 3 years. So the systemic association that she had was, she was previously diagnosed with adenocarcinoma colon, for which she was operated in 2016. The facial full face picture, as we can see, she has right divergent squint, right-sided proptosis, mild ptosis, and right-sided facial hemihypertrophy. The proptosis was attributed to the Hertels examination of 21 and 19 at base 108. Her vision in right eye was PL positive with accurate PR in only temporal quadrant, and left eye was fine. GAT was 38 and 16. In anterior segment examination, we can see 3 to 4 mm frill of ectropion uvea, which was around 360 degrees, and the left eye was within normal limits. These are the gonioscopic images of the right eye showing high iris root insertion. The vertical coverage ratio was around 0.9 in the right eye with circumferential NRR thinning, and left eye fundus was normal.
So the patient was advised to undergo TRAP, but she actually came for only cosmesis. She wanted squint surgery. So she declined the surgical option. To discuss, CEU is a rare ocular disorder of trabecular dysgenesis along with anterior placement of the pigmented iris epithelium. Such cases could be easily confused with another close differential, that is Axenfeld-Rieger syndrome. Till date, only 100 cases have been reported, and they don't have shown any systemic association like our case. So these patients have high risk of glaucoma. Earlier stages, these are non-progressive and open angle. In later stages, these become angle closure and progressive. So there's a stark difference in the age of presentation of both the cases, which is around a decade. So which signifies how timely treatment and presentation leads to better visual outcomes. So to conclude, it's a rare syndrome and its association with systemic disease and progressive glaucoma in children can culminate to potential blindness even at a young age. Angle surgery, although which is a mainstay for the childhood glaucoma, does not yield good IOP control in such cases. And the irreversible nature of the disease in particular makes it all more important to be analyzed earlier. And these patients should also be referred to internist or general physician for evaluation of any syndromic association. Thank you.
Thank you, Dr. Naila. Next speaker, Dr. Tripti Thakur. Her topic is orbital myocystic sarcosis, a rare case report. Please.
Good evening, respected seniors and my dear colleagues. I'll be discussing a case report on orbital myocystic sarcosis. Cystic sarcosis is the most serious parasitic infection. Cysticercus cellulose, the larval form of the poke tapeworm Taenia solium, is the causative organism of cystic sarcosis. Humans are the intermediate host in the life cycle. Human cystic sarcosis occurs by ingesting the eggs of Taenia solium from contaminated food and water. The human then becomes the accidental intermediate host. Cystic sarcosis is endemic to regions with poor sanitation. The main sites of involvement is skeletal muscles and subcutaneous tissues. The involvement of the eyeball and orbit is uncommon. Ocular cystic sarcosis may be extraocular in the subconjunctival or orbital tissues or intraocular in the vitreous, subretinal space or anterior chamber. 30-year-old female presented to OPD with complaints of sudden onset of headache and proptosis of left eye for last 5 to 6 days. That was gradual in onset. There was no complaint of any diminution of vision or pain during eye movements. On examination, left eye proptosis and hypertropia was noted. Proptosis was measured by Hertel's exophthalmometer, came out to be 20 mm in right eye and 22 mm in left eye. Extraocular movement was found to be restricted inferiorly. Best corrected visual acuity was 6 by 6 in both eye, and IOP was 18 mmHg in both eye. There was no history of thyroid, any other systemic disease. Patient was non-vegetarian by diet. On slit lamp examination, anterior segment was found to be normal. Fundus examination revealed normal appearing disc and macula with bulge in inferior part of the globe on peripheral fundus examination. This is figure of patient at presentation with hypertrophy of left eye and slight proptosis. Routine investigation showed rise in ESR. Thyroid profile was normal. B scan showed a well-defined lesion with clear contents and hyperechoic area in inferior part of the globe suggestive of scolex. MRI brain was normal. MRI orbit showed mild proptosis of left eye. Inferior rectus muscle was bulky and showed an oblong cystic lesion of size 16 into 8 into 5 mm with peripheral T2 hypointense wavy margins and few central T2 hypointense dots likely few conglomerated cyst. Features were suggestive of myocystic sarcosis vesicular stage. This is figure showing ultrasound of left eye showing hyperechoic area within hypoechoic area suggestive of cyst with scolex. This is MRI. This picture of MRI orbit showing oblong cystic lesion of size 16 to 8 into 5 mm with peripheral T2 hypointense wavy margin and few central T2 hypointense dot likely to be cyst in the inferior rectus muscle. This is again MRI orbit in sagittal section showing scolex with cyst. In management, oral albendazole was given along with oral prednisolone. Oral steroid was started 2 days before starting oral albendazole to counteract inflammation occurred by dying parasite. And oral albendazole was stopped after 14 days. On follow-up, left eye fundus was normal after 1.5 months. There was no bulge in the inferior part of the orbit, and proptosis had reduced to 20 mm in left eye and hypertropia had decreased. B scan showed no lesion in inferior part of the left eye. MRI orbit showed no abnormality on follow-up visit after 1.5 months of starting treatment. Orbital cystosarcosis can present with varied signs and symptoms like acquired strabismus, diplopia, recurrent redness, and proptosis. It has to be differentiated from other benign and malignant lesion presenting as ocular mass. One or more extraocular muscles may be simultaneously involved, although a propensity for involvement of the superior muscle complex and lateral rectus muscle has been reported. In another report of unusual association of multiple brain neurocystosarcosis with ocular cystosarcosis involving levator palpebrae superioris and superior rectus muscle has been reported. Another study has reported an unusual case of ocular cystosarcosis involving the levator palpebrae superioris and superior rectus muscle of the right eye. Two similar cases as ours, one in 13-year-old female child who presented with mild lower lid swelling and diplopia and upgaze, and other in 26-year-old male who presented with progressive increase in proptosis and diplopia and upgaze. Both had inferior rectus muscle involved. They all had their inferior rectus muscle involved. The treatment is individualized according to the location of the cyst, ranging from the medical therapy to the surgery. Despite resolution with the medical management, significant proportion may have residual functional deficit. David et al. Studied 25 patients with ocular cystosarcosis, where most cases were surgically managed without residual effects. To conclude, cystosarci can lodge themselves in any part of the ocular and extraocular tissue. The clinical presentation may vary, depends upon the location of the cyst, and treatment has to be individualized for each patient. Newer modalities of confirmatory diagnosis and treatment requires further study. Till then, preventing the infections should be focused upon improving sanitation and raising health awareness. These are various locations of the cyst, which we can see on the daily basis, though they are very rare. Subconjunctival cyst. This picture is showing subconjunctival cyst. This picture is showing cyst in anterior chamber. This picture is showing cyst, submacular cyst. This is B scan showing cystic lesion in the optic nerve. This is CT orbit showing cystic lesion with scolex involving superior rectus and LPS muscle complex. This is CT brain showing involvement of brain parenchyma. These are the references. Thank you.
Thank you, Dr. Tripti, for nice presentation. Next speaker, Dr. Nisha Jha. Her topic is a case of post-C3R corneal infiltrate.
A very good evening to everyone. Today I'll be doing a discussion on post-collagen cross-linking corneal infiltrate, which can be an infection or inflammation, and our diagnostic dilemma. We don't have any financial disclosure or any conflict of interest. So coming to the introduction, corneal collagen cross-linking based on the combined use of photosensitizer riboflavin and UVA light of 370 nanometer was introduced by Wolensek et al. From Germany in 2003. It is the only treatment directed at underlying pathology in keratoconnic cornea, which is stromal biochemical and structural instability leading to progressive ectasia. So my case, he was a 9-year-old boy who presented to the RIO OPD with defective vision in both eyes for 1 year. There was on and off history of itching and redness in both the eyes. He was a diagnosed case of VKC with keratoconus, and he had healed hydrops in right eye. On ocular examination, the best corrected visual acuity in right eye was 3/60, and in left eye it was 6/60. IOP was normal in both the eyes. There was presence of papillae in palpebral conjunctiva bilaterally. In right eye, there was corneal opacity with compression suture marks for hydrops. Left eye, the cornea was clear, pupil was normal, lens was clear, and fundus was hazy in the right side, and left side it was normal. On examining the mean keratometric value in right eye, we did not get any reading. In left eye, it was 45.50 upon 54.25 at 170 degree, and these are the AR readings. This was the topography of left eye. The central corneal thickness is around 453 microns, and there was a central cone. So this patient underwent collagen cross-linking in left eye under subtenon's block in the RIO OT. We followed a epithelium off technique, and we used riboflavin with HPMC, and we did an accelerated protocol, and BCL was placed after the procedure. So this is the picture of the first post-operative day. The whole cornea was hazy. There was a ring stromal infiltrate all around. Anterior chamber had cells. There was a fibrinous reaction, and vision in left eye was only hand movement. So
So we immediately stopped all topical steroids. BCL was removed immediately and it was sent for culture. Corneal scraping was done for microbiological evaluation, and we started with fortified antibiotic drop hourly, cycloplegic, steer substitute, and oral steroid. Once scraping reports came out to be negative and it was sterile, then topical steroids were restarted. This was the day 2 post-op picture. In first picture, it was after stopping of topical steroid, and once the topical steroid was started, this is the second picture in which we can see there is a lot of improvement and the corneal haze is decreasing. And this is the week 1 photograph of the child. We can see that the cornea has become much clearer, and at 1 month, most of the infiltrate had resolved and there was a stromal opacity. And after 3 months, the best corrected visual acuity in right eye was 6/36, and in left eye there was some stromal opacities, and the best corrected visual acuity for the child was 6/80. So coming to the discussion, removal of corneal epithelium is done conventionally to facilitate penetration of riboflavin into the corneal stroma in CXL. Epithelial removal in corneal collagen cross-linking has the potential risk of keratitis and sterile infiltrates. A prior history of atopy could be associated with the development of sterile infiltrates. The reported prevalence of VKC coexisting with keratoconus is variable, ranging from 7 to 35%. Some prospective studies are there of which have reported sterile infiltrates. Koller et al. Reported in 117 eyes, and there was sterile infiltrates in 7.6% eyes after conventional epithelium of CXL, which resolved within 4 weeks with treatment of dexamethasone 4 times a day, as was seen in our case also. Koppen et al. Reported 4 cases of stromal scarring following keratitis in a series of patients with decrease in final visual acuity. Cummins et al. Also reported a case of diffuse lamellar keratitis after collagen cross-linking in a post-operative lactic ectasia. A pediatric case reported by Arora et al. Had sterile keratitis after CXL with prior history of severe VKC. The keratitis resolved after topical antibiotic and intensive topical steroid therapy. And there have also been cases of infection keratitis after CXL, and it has variable presentation. The most common organisms reported have been gram-positive staph epidermidis, staph aureus, gram-negative E. coli, pseudomonas, fungi, microsporidia, fusarium, acanthamoeba, and herpes simplex virus. Most virulent of these organisms have been pseudomonas acanthamoeba, and studies have suggested that changes in ocular flora due to chronic use of topical steroids in keratoconic patients with VKC has increased the risk of post-operative keratitis. These are the various organisms reported in literature. So what is the risk for corneal infection in post-operative period? First is the long healing of the epithelial defect, use of BCL post-operatively, eye rubbing, topical corticosteroids, and reactivation of latent herpes simplex virus infection. Now concluding, CXL is relatively safe procedure with a low complication rate. A majority of CXL complications occur due to removal of epithelium. Sterile infiltrates has higher incidence in patient of keratoconus with coexisting VKC undergoing CXL. So it is imperative to control and treat VKC with topical steroids and cyclos for 2 to 4 weeks prior to CXL. So the take-home message, this case highlights the importance of controlling VKC prior to CXL in keratoconus as it adds to the risk of developing post-operative sterile keratitis. These are my references. Thank you.
Well presented, Dr. Nisha. Next speaker.
Next speaker, Dr. Afifa Azam. Her topic is managing ocular complication of Steven-Jensen syndrome with a scleral contact lenses post-mucous membrane grafting.
Good evening. My topic is managing ocular complications of SJS post-mucous membrane grafting with scleral contact lenses. Steven-Johnson syndrome, a dermatological emergency, is characterized by bullous lesions of the epidermis and mucous membranes. SJS and TN are spectrum of the same disease, where SJS is the milder variant while TN is the more severe one. They most commonly occur because of adverse drug reactions which lead to extensive epidermal damage. Mucous membrane involvement occurs in almost 90% of the cases. Ocular involvement is classified based on clinical stages as acute, subacute, and chronic.
phase, acute lasts up to 2 hours and includes conjunctivitis, myobomitis, pseudomembrane formations, blepharon formation and epidefects. Subacute phase results when persistent inflammation and ulceration results in chronic cicatricial conjunctivitis, trichiasis and subsequent corneal epidefects. Chronic phase, this comprises of symblepharon formation, phoenicial shortening, meibomian gland injury, entropion, trichiasis, punctal occlusion, LSCD, conjunctivalization and neovascularization and keratinization of the eyelid margins, as well as ocular surface. So, yeah, ocular surface is the most common site of the serious long-term sequelae, and that leads to permanent visual loss. The end stage is described as a dry and keratinized ocular surface, and that has very poor outcome of ocular surface surgeries or any transplantation surgeries. This suggests that the visual loss is almost permanent. Keratinization of the lid margin leads to corneal damage, and that leads to subsequent visual loss, and that is the most important reason for end-stage corneal blindness. Case presentation, a 58-year-old female came to the OPD in 2017 with both eye blurring of vision, pain, redness and photophobia, which temporarily gets relieved on instilling lubricating eye drops. She is a known case of SJS which occurred to her 20 years ago after sulfur drug allergy. She had undergone treatment for systemic complications and has now come to the cornea OPD for the management of its chronic complications. On ocular examination, the vision was 2125 parts and 2200. This is the image of the upper and the lower lids of right and the left eye, which shows thickening as well as cicatrization and lid margin keratinization. This is the image of the cornea, which shows vascularized scarring with superficial punctate keratitis, which is suggestive of bilateral limbal stem cell deficiency. To treat the disease, the cicatrizing conjunctivitis and LMK, the patient was planned for both eye MMG, where the mucous membrane was harvested from the buccal mucosa, the keratinized lid margins were removed, and the graft was sutured to the area of the conjunctival defect. For follow-up at 10 days, BCVA slightly improved to 2040 parts and 2080 parts, and all lid sutures were removed. At 2 months, this is the picture where the MMG is still in situ in both the eyelids, and this is the picture of the cornea. At 7 months, the visual acuity did not improve very much as compared to the initial one. So, and the patient still complained of dryness and irritation both eyes. Hence, to further manage her symptoms, scleral contact lenses were tried. For this 1 hour awareness trial was given, at the end of which her symptoms got relieved and visual acuity improved. So 4-hour extended trial was done, at the end of which final lens parameters were decided and scleral lenses prescribed. After 2 years of regular use of scleral contact lenses, her vision did improve to 2040 parts and 2050. So discussion. Ocular sequelae in the chronic phase occur in the form of LMK, lid malposition, symblepharon, severe dry eye, corneal vascularization, and bilateral LSCD. Amniotic membrane transplantation, if done in the acute phase, does reduce the rate of chronic ocular sequelae, but by the time the patient comes to us, the chronic ocular sequelae have already set in. So, firstly, ocular surface reconstruction is undertaken. Then after assessing the visual potential, lid margin keratinization is addressed to by doing lid margin MMG, and then scleral contact lenses are tried. Scleral lenses are large diameter rigid gas permeable lenses which are completely supported by the sclera, and they vault the cornea. There is a fluid reservoir in between the cornea and the lens. So it provides 2 advantages. Firstly, it prevents the detrimental effect of the lids wiping over the cornea, and secondly, the fluid reservoir which is there, this provides continuous hydration to the ocular surface. Hence, these 2 factors help in reducing the symptomatology of the patient. And in the long run, we also see that the visual acuity has significant improvement. So my take-home message is mucous membrane grafting was done for ocular surface reconstruction and replacing the keratinized lid margin with buccal mucosa to prevent it from further damaging the cornea. The use of scleral contact lenses post-MMG in our patient provided, firstly, visual rehabilitation of the severely compromised cornea, Secondly, relief from symptoms of dryness and irritation. Thank you.
Nice presentation, Dr. Afifa. Next speaker, Dr. Rajni Sinha. Her topic is surgical management of our vital neurofibromatosis, presenting as a mechanical ptosis.
Good evening, everyone. Myself, Dr. Rajni Sinha, going to talk on surgical management of orbital neurofibromatosis, which is presenting as mechanical ptosis. I have no financial interest. Coming to introduction, orbital neurofibromas, these are peripheral nerves with neoplasm derived from Schwann cells, perineural cells, and fibroblasts. They can manifest within the orbit, and they may or may not be associated with systemic neurofibromatosis. Neurofibromatosis 1 is a neurocutaneous disorder that affects 1 in 3,000 individuals and is characterized by multiple cafe au lait spots and cutaneous neurofibromas. It is mostly inherited in autosomal dominant fashion, although 50% of cases may be sporadic, and its location is on chromosome number 17. Neurofibromas, relatively uncommon orbital lesions, represent approximately 2 to 4% of orbital tumors. Plexiform neurofibromas are the most common subtype among the three neurofibromas encountered in the orbit and are closely associated with neurofibromatosis type 1. They typically present early in life and appear clinically as infiltrative multinodular masses growing along the course of the peripheral nerves. Like diffuse neurofibromas, they are typically poorly circumscribed and vascular. Classic characteristics include a bag of worm consistency and eyelid involvement, producing an S-shaped deformity. Improvement in the physical appearance and visual outcome, that is avoiding or decreasing amblyopia, are the most common indications for medical or surgical treatment. Those in the eyelid and periorbital region extend across the first and second distribution of the trigeminal nerve. On occasion, the ptosis can be profound, causing deprivational or refractive amblyopia. Now I am going to present a case of orbital neurofibromatosis presenting a severe mechanical ptosis with deprivational amblyopia. A 12-year-old female patient presented in oculoplastic clinic with left upper eyelid neurofibroma with mechanical ptosis since he was 5 years of age, and the mass was progressing to completely occlude her visual axis. She had a complete left eye blepharotosis. Her vision in the right eye was 6/6 and left eye vision assessment was not possible due to ptosis. Her right eye anterior and posterior segment examination was within normal limit. There was no any systemic sign of neurofibromatosis 1, that is no any cafe au lait spots, least nodule, axillary or inguinal fracas, optic nerve gliomas on MRI or any cutaneous neurofibromas elsewhere in her body. She was advised for MRI brain with orbit, which showed involvement of neurofibroma tissue in the eyelid with no extension into the orbit and brain, and also shows left sphenoid wing dysplasia. This is the arrow which I have highlighted for sphenoid wing dysplasia. She was then planned for tissue debulking surgery from anterior and lateral approach along with horizontal lid shortening and levator resection, and the debulked tissue was sent for histopathological examination. This is her post-op week 1 picture. Post-operatively, the left horizontal palpebral aperture was reduced and she is being planned for ptosis correction by frontalis sling surgery in second sitting as her levator action was very poor. Her histopathology report was suggestive of plexiform neurofibroma. Coming to discussion, treatment decisions for plexiform neurofibroma depend on the severity of the clinical sign and symptom. Plexiform neurofibromas are more difficult to remove because of their relative vascularity and lack of clear margination. Removal may be complicated by subtotal resection and recurrence or regrowth. The main surgical procedures include debulking surgery, ptosis surgery either by anterior levator resection or frontalis suspension. The lateral part of the upper lid is typically more infiltrated, creating the classical S-shaped deformity, and a full thickness pentagonal wedge resection can be done in this area. Care must be taken to spare the lacrimal gland ductus where there is extensive conjunctival involvement. Ptosis surgery in NF1 patient is quite challenging, and it is often difficult to judge the correct amount of levator resection due to the heavy infiltration. Surgery should be planned for reasonable cost basis and to alleviate any threat to the vision and comfort of a seeing eye. But ultimately, the surgical results are always compromised by the very nature of the tumor, its diffuse position, widespread involvement of all the constituents of a region, and its tendency to recur. Definitive cosmetic surgery is best delayed until past puberty or when the disease progression has stabilized, unless there are compelling social reasons for earlier surgery. Both the surgeon and patient need to understand that childhood surgical interventions may signal the beginning of a lifelong series of operations, and there are very high chances of recurrences in these cases. Coming to prognosis, neurofibroma in the setting of NF1 develop malignant transformation in around 20% of cases and require routine monitoring. In the absence of NF1, localized neurofibromas rarely undergo malignant transformation, but recurrence has been occasionally reported following surgical removal. So patients should be advised to have routine follow-up with their ophthalmologist. Thank you.
Thank you, Dr. Rajni, for nice presentation. Now,
So with this we come to the end of this session. We really thank and acknowledge your presence and bore with all the speakers till the last. And tomorrow we'll have to be there at 8:30 because the inauguration is also between 10 to 11.
10
So I
10 to
think all of you make it sure.
And I think it is time to catch the cash. I think, Abhishek.
Yeah.
Just, it will take just 5 seconds only. Catch the
So,
cash.
another interesting question for the quiz coming on. Catch the cash.
Can the chairpersons participate?
Yes, everyone can participate. Everyone can
Very
participate.
easy question. Just
very easy.
जो पहले हाथ उठाएगा पैसा उसके पास जाएगा.
Very easy question.
Deepak sir, please try to see who answers first. सामने सामने.
ये क्वेश्चन ऐसा है कि पहले कौन हाथ उठाया उसी को मिलेगा. इतना आसान क्वेश्चन है. अभिषेक की आप देखिए पहले जो पहले अभी हाथ उठा लिया वो डिस्क्वालिफाइड है. This is to acknowledge your presence.
Please name the IOL. IPCL में 3 होल रहता है.
किसको मिला प्राइज? किसको मिला?
उधर से मिलेगा उधर से. अरे ये बच्चा लोगों के लिए, आप लोगों के लिए नहीं है.
अच्छा देखिए नहीं देखिए तिवारी जी सबसे पहले बोले लेकिन
सबसे पहले तिवारी
को
आंसर
स्पॉन्सर
किया.
करना होगा ये वाला प्राइज मनी बच्चा को सबको. ठीक है कि नहीं?
I'm Dr. Supriya Sharma, JR from EAMS.
Thank you everyone.
Thank you everyone for being here.
Please join us for the banquet. I request all of you to please join us for the banquet.